Warahmatullahi wabarakatuh. Good morning, everyone. It gives me immense pleasure to welcome you all to the IHOP 2022 conference. Thank you all for taking the time to join us today. I'm Rima Al-Graishi, a senior PharmD student at King Saud bin Abdulaziz University for Health Science, and I'm honored to be the host of the third session. We're so excited to have you here to present to you our first topic, entitled Artificial Intelligence in Hospital Pharmacy Practice. I would like to introduce to you our moderator for this session, Head of Project Management Section at the General Administration of Pharmaceutical Care at the Ministry of Health, currently having her master's degree of Health Informatics at King Saud bin Abdulaziz University for Health Science, College of Pharmacy, PharmD at Princess Noura bint Abdurrahman University. Ladies and gentlemen, please welcome Dr. Afnan Al-Mardi to stage.
Thank you, Dr. Rima. Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning, ladies and gentlemen. Welcome to the second day of IHOP conference. Today, inshallah, at the beginning, I would like to extend my thanks to the scientific committee for giving me this opportunity to be the moderator for this interesting session. Today, inshallah, the main topic for the first session is artificial intelligence in hospital pharmacy practice. I can see that a lot of you are excited for this unique topic. Inshallah, today we will have 3 expert speakers in this field. First, I would like to introduce our first speaker, Dr. Hassan Ashmawi, who will talk about the demystifying artificial intelligence in hospital pharmacy. Dr. Hassan is a business analysis consultant working at ILM. He started his career after graduating with a bachelor degree in pharmaceutical science from King Saud University, and then he worked as an inpatient pharmacist for almost 6 years at Prince Sultan Cardiac Center. However, his motivation for the digital technologies and applications inspired him to merge his healthcare expertise with his passion by obtaining a master's degree in health informatics from Swansea University. This allowed him to take his newly acquired knowledge to a career path that mainly focuses on finding solutions to challenges that allow healthcare providers perform their tasks easily and support them to provide better patient care outcomes. Please welcome Dr. Hassan Ashmawi.
Assalamu alaikum, hayyakum Allah wa sabah al-khair. Thank you for the nice introduction, Dr. Afnan. So today program or this presentation that I will give you is just to inspire you to understand what is AI and how we can implement it in a hospital pharmacy. If you can go to the next slide, or I can use this one. Okay. So this is my. Can I have a mic? I would like to work. No? Okay, sure. So the objective of this session is to have an informative information about what is AI, how it forms, how you can use it in hospital pharmacy, and how to actually approach it in a critical way. So when a company or a provider or an innovation facility actually comes to you and says, we have an AI solution for one of the problems in your hospital, you will say, listen, I need to know how it works, what it does, and what's the proper outputs for it. So what we are going to learn in this session is, as I mentioned, we will understand how AI works in general form, and we will not have a coding session. I will not teach you how to code. This is not the primary purpose. And I don't think as a clinical pharmacist or a pharmacist in a hospital, you need to understand how the code works. You just need to understand the concept of AI. We will look at 3 main functions in hospital. I have a couple of use cases that I would like to share with you. We have the clinical, inpatient, and outpatient pharmacy and administrative functions in general. And I will explain to you in general terms what is my role as a pharmacist in approaching the whole AI space war. So this is the basics. Artificial intelligence. What is artificial intelligence? It's the use of computer to simulate how the human interactions and perceptions of its environments. So basically, we use a computer to perceive some information and give us decisions, or it will learn how certain patterns of data we have in here. It will also, in some situations, plan for you and give you problem-solving solutions. And this is the whole concept. It will have the ability to understand language and give you reasoning for it. I have found a general classification for AI solutions. We have machine learning, cognitive computing, computer vision. Also, we have natural language processing, neural networks, and deep learning. And each one of them have a totally different kind of applications depending on what you need. Most of us actually interact with the computer vision, where you have So most of us interact with the computer vision. I think most of you have an iPhone, and when you try to open your mobile phone, it actually detects your face. And this is one of the applications that most people actually interact with, and it's based on AI. It's a very narrow type of AI, but it's actually there. And not many people actually notice that. And this is the beauty of AI. It's integrated with our human life and interactions to facilitate its work. We want to access our phone faster, so we implement an AI. We want to do other processes in the hospital, we will implement an AI to improve it. So we have different types of AI. We have artificial intelligence, machine learning, and deep learning. And this is a drill deep. The artificial intelligence is like the whole scope of the industry itself or the topic. Machine learning is basically you give a certain data sets to an AI solution or an algorithm, and it takes it and it gives you an informative decision. And this is very nice when you want to take quick decisions, especially in CPOE, for example. You are entering a specific kind of medications, and it will alert you that, be careful, this patient is already on different kind of medications, and we have seen a pattern that if you take this kind of medication, it will cause some adverse effects. Deep learning is totally different. Deep learning is when you give a huge amount of data sets, and you don't know what you want from it. It just keeps analyzing, it tries to find patterns, and it will give you deep analytics about it. For example, drug combination that has been done for multiple medications or for multiple medical clinical pathways, in oncology, for example. And you take this and you give it 10 years worth of data sets, and it will tell you after doing its analytics that, look at this drug combination, it's actually more beneficial for the patient to give this sort of combination. So why we want AI and machine learning in healthcare? This is a concept called iron triangle. It's a very important concept because most health facilities are actually challenging with. So as you can see, we have quality, accessibility, and cost. Whenever we try to improve one of them, the other two will be affected. So if we want to give higher quality in our hospital, we will definitely have to pay for it. If we want to give accessibility, we will have to reduce our quality and we will reduce our cost. That's why AI solution is important. It will switch to a fluid triangle. Fluid triangle meaning I will pay a certain amount of money to improve my quality and accessibility and reduce costs at the same time. And this is the beauty of it. So before we proceed to what kind of use cases we have, is hospital pharmacy a good environment to apply AI? And I believe so. Basically, we have a lot of data, and we are one of the few practices that have full kind of structured data in our daily work. We have drug databases, we have clinical significant markers that we always look at. We understand how patient utilization happen in the hospital and what kind of pathways they go through. We have also drug-related problems that are very wide and ranged from different kind of topics. So this is a diagram that I was looking at a few days ago, and I really noticed something. Pharmacy is missing in here. We have the pharmacogenomics, but it's basically drug production. I have went into many research and papers, and I tried to look at for an actual AI that was implemented in a hospital pharmacy, and I can only find some topics about clinical research, about drug innovation, about drug design, and this gave me an indication that companies or pharmaceutical companies are actually the current drivers for AI, where we actually need AI in our hospital practice because it will impact the patient healthcare immediately. And that is our purpose in a hospital as a pharmacist, to improve the patient care, to make sure that he is getting healed and treated in a proper way. So AI application in hospital pharmacies, we have clinical applications and we have non-clinical applications. This is a general kind of segmentation between the two type of applications. So for example, we have symptoms analysis for COVID. Since COVID was recently like an epidemic and there has been a hot topic on it, a lot of research studies has been there to identify, using AI, what is the symptoms for AI, and what's the symptoms for COVID, and using like infrared sensors and what do you call it, camera with facial recognition. They try to identify patients as they walk in with a COVID kind of disease. Also, we have other non-clinical applications such as automation of administrative tasks, accelerating and amplifying insight generation, meaning that while I'm working on my system, it will start giving me a couple of information about why am I doing this? Do I need to focus on this patient? Is there an actual better process that I can use to utilize my daily work and come up with a better outcome at the end of the day? Also, we have other things, and you will see a lot of details on this and a lot of research where you can fraud, waste, and abuse detection and prevention, especially when it comes to insurance company, medical devices, and so on. We have also a couple of AI solutions in risk management, medication-related errors, and customer experience conversational AI. And this is the conversational AI, I think, have been booming for the last few years. You will see a lot of applications that you can talk to. It will give you like a sort of a triage on what kind of symptoms that you have, where should you go to a clinical. It's very usable to accessibility, actually, to the patient, but the sort of application that doesn't impact the hospital pharmacy. So here I have a few use cases that I would like to discuss with you or explore with you. I couldn't find any research based on this. So this is my previous experience with the hospital and how it works and how the pharmacist actually functions in the hospital and what we can do in there. So we have retrospective analysis on previous decision and outcomes. What I mean by this, when a clinical pharmacist or a physician or actually a pharmacist take a couple of decisions and prescribe medication or modify them, the AI should be able to store those data, capture it, analyze it, and then come up with an insight for you as a user on why did you take this decision, and these were the outcomes for those decisions. And based on that, we would like to change your behavior from taking such actions in the near future to improve the patient outcome in the far future. Also, we have pharmacogenomically application. This is very interesting. I actually found a research about it where you can predict the proper dosing for a patient using AI to reach the target levels, meaning that it will save you money to actually ask an AI, how which is improve patient monitoring and assisting clinicians. And I see a lot of physicians and clinical practitioners in the hospital where, and this is some sort of a missing feature in most HISs. The system needs you to be active to give you insights on the patient. So you have to open the patient profile, you have to check his lab results, you have to check his details to understand what's going on. Where in AI, it should actually automatically detect a couple of situations that happen to your patient that he is assigned to you, and it will give you like flags. It will send you an email. It can be as simple as that. Please be careful. This patient levels is not reaching to the proper place. He needs your attention. Some medications that was prescribed for an outpatient patient a few days ago is not proper. Do proper reconciliation for him, and so on. Of course, we have also administrative things like specific to medication management and inventory management. And I remember when I was in a satellite pharmacy, we always find few medications that is missing because of the daily work. It's really hard to manage your medications, especially when you have a lot of cases in your ICU. So having an AI-enabled solution for your inventory management will predict for you how many IV medications you need in the satellite pharmacy, how much you need to order for your outpatient pharmacy, and how to distribute it actually within the pharmacy. So we can detect if you are putting, for example, azithromycin on the top shelf, and you want to reach for that, and you are frequently reaching for that. We can detect that and analyze it and give you good insights to it, that it has to be changed to reduce the amount of effort this pharmacist is actually moving in the pharmacy. Why we are wasting his time? And there was like a very good research about this, where they looked at one of the nursing station in a hospital, and they found that the nurse walked between 10 and 15 kilometers within the nursing station just to be able to reach to the patients. And that was due to the faulty design of the environment. Having an AI to actually detect this and tell you, you need to change your workflow. You need to bring things together. You need to bring it closer. It will improve the efficiency of the nurse in a huge manner that it's saving him a lot of calories. He will be relaxed. He doesn't have to walk 300 meters to just reach the patient. He doesn't have to go 200 meters to get a small package of medication. Of course, we have one last use case: medicinal design, clinical trials, and finding new drug combination. As I mentioned before, drug combination is a very good topic for our use case. So in oncology practice, and this is actually one of the cases that Dr. Abdullah Rajhi, we were discussing about last week. He told me that for the patient who is going through oncology treatment, he goes through so many clinical pathways or so many treatment therapies, protocols, that in some situation, the results is not what they are anticipating. And they have to switch time and time due to mutations and other things clinically. Having an AI that can deeply look at why we prescribe this medication and what kind of pathway and what kind of mutation this patient have will actually enable us to easily give a better kind of drug combination for our clinical pathway. So it will improve the patient care on the long run. As I mentioned earlier, this was the oncology diagram that I found. So they are using currently artificial intelligence and machine learning and deep learning for cancer diagnosis. And you will see that in a lot of new facilities across US, where they get the patient blood samples, they feed it to the system, and they ask it to give us, does this patient have cancer, basically mutated cells. Also, we have a lot of things on biology and mechanisms and discovery, target discovery. We have automated countering. We have automated also treatment planning. And I see that in the most sophisticated or new HISs, you have to build this from scratch. Where if you have an AI solution, it will automatically build it for you and have it ready for the clinical team to validate it. Of course, we have one topic which is precision treatment, patient prognosis, response to therapy and immunotherapy. And I had this topic specifically for one reason, or I had this slide for one reason. If you notice, we are only talking about cancer because it's a very important topic for us. And I think hospital pharmacy is a very important topic for us. And we need pharmacists to be inspired to look at problems, not just, I want an AI. We need problems that we can identify as an opportunity to build AI and have the solution later built for it. So what are the challenges in adopting AI solutions? We have ethical and legal issues. Basically, you are feeding patient data to a system. It's looking at all your information. It actually can detect things that you don't want to be detected. We also have legal issues where if an AI system gave you a wrong diagnosis or a wrong recommendation, it might affect the patient health, especially if the clinical practitioner did not validate it, did not make sure, and that will have a legal implications on it. There was a very nice use case for it that I could share on the bias and discrimination problems. Basically, one of the big companies in this world use AI to look at resumes across all the applicants, and for certain kind of elements, they started eliminating those applicants, even though they were competent. And we might have this in a hospital. So you give it a lot of data about the patient care, and you expect that it will give you the best treatment. In some situation, it might not. It might give you a totally different based on its discrimination pattern. One of the most heavy things in it is operating complex AI models. So AI is very complex. Having a team who understand it and how it operates is also expensive. You need them to be aware of what are we going to have, what are outputs that we want from this AI, and how to approach it. Also, we have the last problem, which is purely financial, is compute power. We need PCs. We need powerful PCs to be able to operate AIs. So we have one last topic, which is measuring outcomes for adopting applications in hospital pharmacy. How do you measure it? There is a solution that is called simulation hospitals or simulation healthcare environment. Basically, you feed the system data from real world, but you have it anonymized, and then you analyze it, and you keep giving it inputs, and you see how people interact with it. We can take a couple of use cases on it, and we can do also small case scale testing, where you actually have portions similar to clinical trials. You have to do a clinical trials on your AI, otherwise it will give you bad outputs. And there is a very nice saying always in data science and AI, garbage in, garbage out. So you have to feed it properly to be able to give you the proper outputs that you are looking for. In conclusion, I want you as a pharmacist to proactively interact and engage with your team members, with your hospital teammates, on how we can use AI, what are the opportunities that we have, and discuss it with your RT department. Look for opportunities, search for them. Don't wait for them to happen for you, because you are the main driver in the hospital. Also identify problems or challenges that exist in your workplace. Critically evaluate AI models and their claims. This is very important because a lot of people claim that they have an AI, and in most situations, it's not an AI, it's just a decision tree that is purely basic. You just need to dig a little bit deep with them and understand it. Identify when technology advance is likely to enhance patient care. So even if you find a problem, you need to ensure that this will affect the patient care and it will give you the best outcome. Thank you.
Thank you, Dr. Hassan, for your presentation. Inshallah, we will allow the questions by the end of the session. Our second debate will be on the application of virtual care for home healthcare service delivery. And actually, I'm glad to introduce our speakers, Dr. Abdelaziz Al-Hamoud and Dr. Saad Al-Nafai. Dr. Abdelaziz Al-Hamoud, he is the Chief Medical Officer at Sahha Virtual Hospital and Ministry of Health, which is a specialized hospital that uses the latest innovative technologies to provide specialized services and support the health facilities in the kingdom. Dr. Al-Hamoud holds the American Board for Medical Informatics and Emergency Medicine. He had an extensive experience in the digital health before joining Sahha Virtual Hospital, and he has been an integral part of many innovative projects in the US with many organizations. Welcome, Dr. Abdelaziz. Our third speaker is Dr. Saad Al-Nafai. Dr. Saad, he has a 20 years experience in the medical field and medical informatics and information technology. He is an expert in implementing and managing the mega projects in the healthcare system in many entities. Dr. Saad, he graduated from King Saud University College of Pharmacy and had his master's degree in the health informatics from King Saud bin Abdulaziz University for Health Sciences. Currently, he is an Associate Executive Director for Corporate Data and Business Intelligence Management at the Ministry of National Guard Health Affairs in Saudi Arabia. Welcome Dr. Al-Hamoud and Dr. Al-Nafai to the stage.
Assalamu alaikum. Sabah khair jami'an. It's an honor to be here. Thanks, Dr. Shinawi for your invites. Dr. Hassan, amazing talk. I tried to copy a lot of it. It's amazing. Hopefully we'll see it across many hospitals very soon. So we want to talk about care at home. So I always try to link what we're doing today with what happened in the past. To know that there is a continuum for improvement. We came as a step in a long history of providing care that goes more than 5,000 years. This is a piece from a letter by Dr. Gale, written in 1927. I don't think anybody in the room has used barqiyya or telegraph in the past. But he looked at the telegraphy and says, why can't we have telemedicine then? So we could walk up to the receiver and then put your dollar and then use the particular tool and then just put it in your anatomy piece and talk to a doctor and see how could he manage you remotely. The fun fact is that almost 50 years before this, actually the first reported telemedicine was published in a paper, especially in Australia, where it was a way to manage trauma cases remotely, using telegraphy actually. But why is this? Why telemedicine is easy to be done? Why it's been around since the 1800s? It's because it is a term that covers a lot of things, covers any interactions that happens where the two parties are not in the same room, as long as it's related to patient care. As an example, these are the things that we've been doing, and I think when you look at this list, you feel very comfortable about telemedicine, that you've been using it since a really long time. Calling for an appointment is some sort of a telemedicine activities. Sending your report to a friend using WhatsApp, for example, is again a form of telemedicine. Telemedicine is everywhere. We're now just aware that this way of providing care comes with a package that has to be dealt with, comes with governance that's required to be managed, comes with risk and opportunities that has to be put in place. And why is that? It's all because of the quadruple aim. If you have a clear and focused aim, you could definitely reach your goal. Clearly with telemedicine, we improve our patient experience. A lot of us like to use convenient care and processes to access care remotely. Cost, there's a big question mark about it. Today in the virtual hospital or other project, we see how The capex expenditure is a lot with telemedicine, with using technology, but eventually you reduce cost by minimizing complications of disease. Patient clinical experience, definitely by providing access to decision-making, access to information. As Dr. Hassan mentioned, the number of data that has to be reviewed to make the accurate decisions is huge, and allowing for telemedicine and technologies to support will lead to the right direction. We're lucky in Saudi that we have almost everything that we need to move forward, to be leading. People, technology, and processes are usually across a lot of hospital activities, but if it's linked with a clear strategy and very supportive regulation, then your way to success is very well paved. This is a one slide that I'd like for you guys to look at it and maybe have it in your cheat sheet. It's a way to really have any telemedicine activity, any digital health innovation safe, applicable, and helpful. We usually try by doing our homework, by reading a lot, by trying to build a decent use case that has been tested outside the bedside, that has been published, and the science is full of information. As you saw, we were able to go more than 200 years to see a lot of relevant data from telemedicine. So if you, any tool that you want to do, artificial intelligence, for example, you will see a lot of activities that have been done around. So building a very good use case and then have a persuasion, come to the leadership, to come to, and Dr. Shinawi's feel that sometimes we reach out to them with questions, with thoughts about how do we implement telemedicine. I'm sure we're going to come across pharmacy-related activities in the next slide. And then you have to persuade decision makers to make sure that this is the right thing to do. Go back and look at your regulation. Say, is this product, is this design fit for us? For example, if you're doing it in the US, you have to put HIPAA in the middle of your design. If you're doing it in the European area, you have to understand that you understand the GDPR. If you're doing it in Saudi, a lot of regulations are coming, and so forth. If you want to design it with a goal to go cross-border, then you have to be regulation agnostic. You have to be very safe. Whenever you go, you will meet all regulations. And then focus on technology. But if you look at, I have people in bold, because whatever technology you have, if you don't have the right set of people, the right skills, the right way of applying it, you will never fly. And then clearly, when you build anything, as we mentioned, you have to have a clear diffusion strategy. We all talk about patient journey, patient experience, but when you're doing telemedicine at home, I think you have to think about it from different elements. There is an emotional journey for patients when they have an awareness that they need care while they are at home. Okay, there is a person journey for persons before they even get sick to be able to access telemedicine, to be able to feel comfortable that they will consult Google or any assessment form that the government or the hospital providers have for them. And then there is a physical journey. The patient is at home while the provider is somewhere else, and the rest of the team might be in other locations. It's good to keep this in mind when you build the design. I will speak briefly about two different initiatives related to the home care, the Saha Virtual Hospital home care activities. First one is remote patient monitoring for advanced heart failure, and the other is an acute care hospital at home. I won't talk about successes. I'm going to focus on how do you implement it, what things to look at, and what things to really be aware of. And this is courtesy of Dr. Adil Tash. When we designed our remote patient monitoring program for advanced heart failure, again, we were ahead of the curve. This has not been applied in a lot of countries, but we've done our work making sure that we provide to our people here in Saudi the top tier products, the maximum solutions to make them have a very decent life, even if they have complex diseases like advanced heart failure. I'm not sure if anybody here worked in the emergency room, but you will never have a shift without having 3 or 4 heart failure patients. It's good to focus on clinical readiness, on the disease specification that made it safe to be managed at home. It's very important to know your players. Usually, if you're doing something in the hospital setting, you know that your players are your nurse, your pharmacist, your lab, your doctor, your maybe social worker or whatnot. But if you're doing it at home, you have different groups of users. You have to know your personal preference. A lot of people want to do it themselves. For example, if you're looking at Generation Z or the younger people, they're known for wanting to take care of their own health. They're not very submissive to physicians, or in the past, when you want to do shared decision making with your patient, they would say, "Anta doctor," they would say, don't ask me to help in making the decision. Today, no, they want to know what choices are there, what's the financial application, what's the recovery cycle for it, do I have to go for rehab, or maybe do a knee replacement, do I lose weight rather? It's a lot of decisions, and our customers now really want to be part of the decision. It's really good to know who is your, how can you get powerful team. So the three things that made it possible for us to work at home is medication, technology, insurance coverage. If your work at home will not be covered by insurance or the payer, the hospital will not provide that service as long as it's not covered. Especially in Saudi now, with more than 30% of our population is insured. Technology and medication. The goals, you have to have laser-focused goal. Because these patients are at home and having pieces that can be monitored simultaneously, remotely, by a big group of support is the way to success. And I have the care plan on the right side. You don't need to go through it. It's just to know that you have to have a clear care plan. The other project that I wanted to share with you, and I think it's pharmacy heavy, is the acute care virtual hospital at home. This is one of the newest additions to healthcare across the globe. Maybe the first acute care hospital at home was disseminated in the US sometimes during COVID, and now there's more than 200 acute care hospital at homes across the globe. Ours might be considered the first one, especially with its focus on acute care conditions. And this is just briefly how did we create it, how did it break the ground and became one of the solutions in the healthcare system in Saudi. So first we spent almost 10 months reviewing all use cases for virtual care, acute care virtual hospital at home. We ended up with a very robust 5 use cases. We made sure it is safe to provide such acute care at home, knowing our limitation, knowing that you will need to work with EMS, you will need to work with home visits from nursing, you will need to work with virtual group. And then we had to look for strategic partners who could actually render care at home. If you see in the bottom of the slides, the home care administration at the ministry worked with us closely. Riyadh Cluster 2, Riyadh Cluster 1, and the Medina Cluster. These 3 clusters were part of our program. Then we decided to come with workforce design. We have nurses and physicians doing virtual rounds and nursing doing home visits. Then we looked at the technology and how can we do it, what are the enabling factors. Eventually, the 3 questions that I think will be successful for any home activities is how to staff, what to monitor, how to engage. This is the last slide, and I want to focus clearly on the prescription side, given that this is a pharmacy conference. When we did our acute care hospital at home, or decided to really facilitate early discharge, we wanted to look at how can we make it possible for us to intervene. Intervention is usually with procedure or with medication or prescription. OPAT, Saudi is pretty advanced when it comes to OPAT. A lot of organization has a robust OPAT system, and we think with smart infusions now, we could capitalize on that. Convenient pickup hubs, I mean, with Wasfati and Anat now, you could go and pick up your medication from any participating pharmacy. And then we're working closely with with the home health, with with WASFATI to allow for home delivery. Today, I think today or maybe tomorrow it will be live, and you could opt to have your prescription delivered to home. Briefly on the left side, and maybe Dr. Shinawi has a lot to say on that, but we're trying also to use these convenient hubs like the pharmacies to be more of a one-stop shop. I mean, we know that there is a lot of restrictions around it. There is a lot of regulatories that has to be met. There is a lot of shift in the design of these convenient hubs, but it could potentially be collection sites for samples or whatnot. For laboratories, we're doing a lot of phlebotomy work at home, self-directed testing. A lot of the team in the room, I'm sure, has done their own COVID swab at home. In addition to the point-of-care testing that now can do more than 50 tests simultaneously. I hope you guys had a piece of telemedicine and how pharmacy could really make it to flourish and support our patient. Thank you so much.
السلام عليكم ورحمة الله وبركاته. صباح الخير جميعا. شوف البرزنتيشن مو طالع على الشاشة. Take this opportunity till the presentation will be prepared in the screen to appreciate the Ministry of Health متمثلة في الدكتور محمد الشناوي والتيم اللي معاه ما شاء الله تبارك الله على التنظيم الجميل والجيد لهذا المؤتمر المبارك. كم حنا سعيدين أن نرى الميديكال فيلد combined with the medical informatics in same session. Today is one of the example of how the medical field and medical informatics coming together. This is exactly what I deliver a simple message to our colleague here to take home message. Everybody know this Nokia before. Nokia is one of the best in the world before. Why it is dying? And this smartphone, other smartphone coming, iPhone, Samsung, etc. Exactly what I talk today about is if we strict for traditional medicine, for practice, will be stay as a Nokia. We have to smart enough to combine both of them, the medicine or medical field with medical informatics to be coming with the trend. Future will coming with medical informatics. Nobody to be keep all information in your mind now. All software, smart software to support you to take a decision and save your time. Presentation not yet start. However, I will get the opportunity to thank you, Dr. Rima and Dr. Afnan for moderating this session. And Dr. Hassan, thankfully, he's elaborated a lot of things about artificial intelligence. Dr. Abdulaziz already has elaborated also more about virtual concept of home healthcare delivery system. I can start my presentation. I can start until the presentation will be in the screen. I will start with the objective. We'll talk about taxonomy. What is taxonomy? Classify of the concept of virtual. This is very important to start in any topic to understanding exactly what's meaning this term. If we understanding this term, we understand the concept. Virtual or telemedicine or telehealth starting since 1905 with Dutch physician, innovator. He's not informatic. He's a purely physician. He's starting statement of tele. Then it's elaborated more and more until 1967. Then another concept is coming to the floor called telehealth, almost 78. Then another concept is coming after that called e-health. Then another concept is coming also called m-health, mobile health, which is coming with 2003. Why mobile coming in the floor now and overcome everything? Because smartphone is coming at 2003. All smartphone is applications coming or the monitoring and track system is coming in the floor. This is called 4 pillars as defined by ICT, Information and Communication Technology. Is defined this domain for telehealth or virtual. It's okay, I can proceed. I can proceed. It's okay. Okay, since the presentation will be not on the screen, I'll continue. I keep the presentation in my mind. It's okay for it. Okay. However, these 4 domains, we talk about telemedicine, telehealth, e-health, and m-health. This 4 domain. If you're going a step I talk about what the exactly component of virtual health or virtual home health care delivery as an example. There is several things. Software. Should be there is software support you. There should be there's Internet of Things. There should be there's some called scalability of the solution. There should be there's a regulation. All this coverage of network, all this component should be in the floor to be covered or deliver this system. Any one of us understanding how is important the technology, especially with the COVID outbreak. Everybody first have an issue with to visit a hospital. With tele concept, everybody take the treatment or advice or refill medication at home or consultation. This is the beauty things of the technology. No doubt, after COVID, for technology, not as before. Everybody now and colleagues elaborate more about why this is important in the flow. And the future is coming in like this side. And we have to follow the trend. We talk about now 2 topics, component categorization, and now we'll talk about, there is called PPT framework. I'm sure Dr. Hassan, Dr. Abdulaziz elaborate about this one. PPT framework is people, process, technology. 3 components. If you starting to think about how to improvement, enhancement, the technology, you have to think about 3 domains. People, we understand the people, either healthcare provider or the patient education also. Regulation. Processing, how to processing communication between the patient and the healthcare organization, and technology itself. This is 3 domains. If you think to improve or enhance any solution, you have to think about 3 things. Conclusion, this still, we are in the scientific point of view. We are not go too deep with the virtual and against, but we have to address it as scientific way. The people who believe and they have passion for this virtual coming in the future, no doubt they have make fact for them, because talk about there is medical device enhancement, smart medical device, there is smartphone, there's communication, all this support their case. However, still they draw back something to be think seriously about the regulation. Still have missing in the regulation about virtual concept. We talk about human being. Human being is the safety, right? And we have to think about seriously about the regulation. And colleagues addressed some point of the ethics and conduct of practice in this virtual, because not a physical side. However, this technology will be promising in the future. Clinical, and this very important point, healthcare provider is very crucial for any technology, and don't think this technology will replace them. They will add value for them. This add efficient time. Several studies coming with a virtual clinic or virtual home health care or virtual pharmacy, and say the no-show is go down through the virtual, comparing with the physical. However, both of them complete each other and support each other. I would like to thank you for listening to that. Thank you, organization, for missing the presentation. Okay, but I will go down for the debate discussion. Thank you, guys.
Thank you, Dr. Al-Hamoud and Dr. Al-Nafai, for your informative presentations, and we do apologize for this technical error. بس ما شاء الله دكتور, you don't need يعني slides. Now I would like to introduce Dr. Ashmawi, so we have the time to have our panel discussion. يعطيكم العافية. الصوت واضح؟ يعطيكم العافية جميعاً. I would like to thank you doctors for joining us today and for this informative and comprehensive presentations. You did highlight a lot of areas in artificial intelligence and also the initiatives of the Ministry of Health when it comes to telemedicine and telehealth. Before we take the questions from the audience, I just have two questions for you doctors. Maybe we could have a small discussion for the next 10 minutes. My first question for you, Dr. Hassan. Dr. Hassan, when it comes to artificial intelligence, as we discussed earlier this morning, the first thing that comes to our minds is the drug development, the drug design, the pharmaceutical industry. But when it comes to the hospital pharmacy, still we are behind. And you mentioned this, and although we do have big data in our hospitals, so what is your recommendation to the pharmacist in order to improve this area and to nourish this area? You can just press the... Yes.
Okay. Thank you, Dr. Afnan, for this question. What I would say is always look into opportunities, look into problems and challenges in your workplace, clinically or administrative. Try to figure out what's the root cause for them, meaning that if I have a challenge that old-fashioned or current practices will not solve, I think this is a very good opportunity for AI to be there. I would like to clarify something, that AI is not robotics, so the drug dispensing machines is not part of the AI. The AI can be as simple as just identifying the handwritten or the prescription in the physician. If it's handwritten, you can use that. You can use AI to detect what the physician have written, what kind of medication he have prescribed. Even you can identify what patients have written with AI. So it's actually a huge range of applications that you can try to find out. I would suggest that you read a little bit more about it. There has been a very good movement into the natural language processing, meaning that you can communicate with an AI and it will respond back. I don't know if you have heard of it, but it's called ChatGPT. Basically, you can send to it a lot of questions and it will respond with a reasoning, like it's an expert person. And I think having some sort of awareness about the AI application, how it's developed, and what's happening around this world, it will be very nice, and it will help you to identify the problems that you will be able to solve.
Thank you so much. My second question for you, Dr. Al-Hamoud. Doctor, we all know that telemedicine, it is a technology and a tool that will help healthcare professionals and their work, and that will ease the workflow in their workplaces, and also to improve the patient outcomes. So where do you see the future of telemedicine in the healthcare sector in Saudi Arabia, especially with the transformation plan in the healthcare?
Thank you so much. I think there's two main points. The first one is when telemedicine started and technology, people were thinking of building a digital front door that really allow for improving access. Very soon that will not be enough. We'll have to have a lot of digital hallways, digital pathways. This is one. The second is, I think, instead of having telemedicine as an adjunct today, something added to the work, to the design, to the model of care, we're going to move into telemedicine first or digital first approach, where the norm is having the care delivered virtually.
Thank you so much, Doctor. Before we move to the questions from the audience, Dr. Saad, you mentioned a point, which is there is like this wondering for the healthcare professionals. They're always afraid that those emerging technologies will replace their work. Are they going to replace it or not? So how can we deal with this conflict?
Okay, thank you, Dr. Afnan. That's exactly what's happening anywhere. Is a technology replace healthcare provider? If in the not the operation section, the best answer now, technology cannot be work without human being, and especially we talk about healthcare. Healthcare is talk about the patient. Patients talk about the patient safety. You cannot. This technology add value, make it effectiveness and efficient of the service, and add to the patient the quality of the care. Moreover, this give an accessibility to the care. One of the KPI for the healthcare organization talk about accessibility to care. Now with this technology, accessible care will become rich, and the load in the healthcare institution will be goes down since we implemented the tele or virtual concept. And no doubt we see in the healthcare all the organization now starting the virtual clinic. Virtual consultation, all this concept is in the place right now. However, is it mature? Not yet. We expect in the future more better than what we have now.
Inshallah, Doctor. Now we will move for the audience. If you have any questions, our speakers are pleased to answer. There is a question. I see two hands. Dr. Abdurrahman Suwaidi.
Assalamu alaikum. Thank you for your informative presentations. I have two questions, one for Dr. Hassan and for Dr. Rahman, Dr. Saad. First question is about CDS, Clinical Decision Support Systems. Is our HIS exactly in MOH have this type of service, of this type of system? Other questions for Dr. Mahmoud and for Dr. Saad, it's about what is the exact definition of telepharmacy? And what's the application of telepharmacy? Do we have telepharmacy in Saudi Arabia?
الله يعطيك العافية. شكرا على السؤال الجميل. Most of the clinical decision systems that currently implemented in Saudi Arabia, in general, are a little bit old-fashioned. They need a lot of technologies to improve. I don't think there have been implementations with AI. I haven't seen one. And if there have been, it will be very simple and minimalistic because of the adoption rate is not very fast. And when you have vendors that are not seeing an opportunity or not seeing like the need for such applications, they will not develop it for you. So within the Ministry of Health and the whole health sector, there should be a vocal voice that says we need AI in certain areas, because we are seeing the trends of issues and the problems. So if we don't know, if the CDSS or the clinical decision support system that you currently have is doing its job, that means that there is no problem. So we need to identify the problem first to be able to adopt AI, basically.
Thank you. Perfect answer, Dr. Hassan. I have to comment on the CDS. So today we're pushing a lot of organizations to have CDS, and we're also trying with Sibahi to ensure that this is one of the standards for approval. A lot of the EHR systems, when they have CPOEs, will have CDS. It's how you implement it, how do you design it. It needs a lot of physicians, a lot of minds to sit down, a lot of protocols to be reviewed. And I could speak of our own experience at the virtual hospital and at KFMC or King Fahd. When these solutions actually does provide CDS, it's just how much resources are you going to dedicate to it, because it's complex. There is a lot of linkage to CDS and outcomes. So if it's not designed properly, you might cause harm. So it can't be taken lightly. And I know Majlis Sahi today is working closely with a lot of groups in building these protocols. Once you have the protocols written, making it digitalized, making it embedded within your prescribing unit is not very complex. And I think that goes back to providers. If you keep asking for CDS, you will get CDS. That's the first part. The second piece for telepharmacy, as we mentioned, tele is a term that covers a lot of things. I will comment in one example that we're currently working on with the leadership, Dr. Al-Judea, Dr. Shinawi, at the virtual hospital. We're trying to build the first virtual antimicrobial stewardship program, where the clinical pharmacist will be the core in securing that patients are getting the right treatment. We're not overshoot, we're not undershooting. And a lot of work has been done around this pharmaceutical initiative with lab, with microbiology, with ICD-10 coding, with how we practice medicine, with how we have medication available. This is just, I would say, an example. And if you look at it, you will notice that telepharmacy is in the core of telemedicine. Thank you.
Thank you, brother, for the great question. And also, I'll add small thing about CDSs because I implemented the AHR in Ministry of National Health Care, and we implemented the AHR with CDSs. In the market, there is CDS, very smart CDSs in the market, but is in place the big question, and Dr. Hassan, I think, and Dr. Abdulaziz mentioned that. Yes, there is in the market CDSs. CDSs is very simple things here. There's knowledge or information in the software embedded with the HR system. Very simple, like concept, it's a concept. However, there is discrete data, the support of the diagnosis, there is in place. Personally, I'm implementing National Guard, this concept. Yes, in the future, we're thinking more and more about we should be in advance. This is from the CDS's point of view. I'm sharing with the experience since we had debate discussion. However, about your question about telepharmacy, yeah, we are ashamed as a pharmacist background, we don't have too much application to support telepharmacy. Yes, there is pharmacy, when we talk about system now, applications focus about the patient care, not to focus about the modality. Patient have looking for his file to sign, looking for the medication list, and looking for the visit, booking the appointment online. This is called precise medicine or personal health record. However, telepharmacy can consider the pharmacy refill. Pharmacy refill is an point of the telepharmacy. However, in the future, inshallah, with support, everybody work together, technology and pharmacy team to implement another application for pharmacy. Until my knowledge, at this moment, telepharmacy until this moment, there is consultation and pharmacy refill.
Thank you so much, doctors. By the end of this session, I would like to thank you, doctors, for joining us today and for this informative and comprehensive talk. And also, I would like to thank the audience for their active listening and their cooperation. Thank you so much. And I hope, inshallah, you enjoy the rest of the day's activities and sessions. Have a nice day.
Okay, we will start the recognition now. Dr. Abdurrahman, معليش. شكرا جزيلا لكل السبيكرز وكذلك الموديريتورز ومدراء وعفوا رؤساء الجلسة. راح نبدأ بداية مع دكتور حسن عشماوي. دكتور حسن. دكتور عبد العزيز الحمود. عندنا المودريتور دكتور أفنان المرذي. شكرا جزيلا. مديرة جلستنا لسه باقي لنا واحد. مديرة جلستنا ريما القريشي. عندنا الآن الهدية اللي يتم اختيارها من الجمهور بشكل عشوائي. ما أدري لو كنتوا معنا اليوم اللي فات، لكن إحنا بين كل جلسة وجلسة نوزع هدية بشكل عشوائي على الحضور. فحالياً الكاميرامان راح يختار واحد منكم الموجودين، واللي تتم اختياره عن طريق الكاميرا. ألف مبروك مقدماً. كاميرامان الموضوع عندك. ألف مبروك.
Moving on to the next topic entitled Saudi Health Policy, I'm very much delighted to introduce this topic's moderator, General Director, General Administration, Pharmaceutical, College Business, Al Faisal University, Master Degree in Administration, School of Pharmacy in King Saud University, Bachelor of Science in Pharmacy. Ladies and gentlemen, please welcome Dr. Mohammed Shinawi to the stage.
بسم الله الرحمن الرحيم والصلاة والسلام على أشرف الخلق سيدنا محمد عليه الصلاة والسلام. It's my pleasure. Thank you all for being here. It's my pleasure here to introduce the next session, Saudi Health Policy. Thanks for the organizing committee for giving me this card to introduce Dr. Al-Jadea. In fact, and I memorized Dr. Al-Jadea like more than myself. Dr. Al-Jadea graduated from King Saud University in 1996. Then he joined King Faisal Specialist Hospital in 1997. He went to St. Louis, US, and he got his PharmD degree, and with the PGY1 and PGY2 in transplant specialty. Then he joined, of course, King Faisal Specialist Hospital. He went through all the positions from pharmacist 2 to pharmacist 1, then to department head. Then he became the director of pharmacy. And I really believe that the era that he was there, the King Faisal shifted a lot, especially with the automation and informatics and all fields and clinical side. Then he joined MOH 2018 as the assistant deputy minister for therapeutic affairs. Dr. Judea, he is not just only a boss. He's my boss. He's a brother. He's a mentor. He's a supporter. If I want to talk about achievements or to introduce Dr. Judea, I need a special conference in order to list all of his achievements. Dr. Judea simply, he created the Saudi Society for Clinical Pharmacy. He's the founder of the society, of that society. And I really, we can say that in pharmacy field, especially in MOH and King Faisal, we've never been reached our achievements without his support, without his guidance to us. Dr. Judea has a lot of abbreviations after his name. However, that I believe that his name is more than enough. Dr. Al-Judea, please welcome with me Dr. Ahmed Al-Judea.
طيب السلام عليكم ورحمة الله وبركاته. أسعد الله صباحكم. بسم الله الرحمن الرحيم. Thank you, Dr. Muhammad, for the introduction, and would like to thank the organization committee and also the scientific committee for putting, one-of-a-kind IHOP conference. It's really my pleasure to be part of this. Actually, the scientific committee asked me to discuss the recently completed utility evaluation study based on the EQ5D5L in Saudi Arabia, which is a very important study that is done once in a lifetime. This is something that we do to get the utility evaluation of certain health utilities in terms of quality adjusted life years, or QALYs, for any health technology, whether it's medication, medical device, medical supply, procedure, or intervention. We really need to assess it in terms of its cost effectiveness and cost utility. And part of this assessment, we really need to develop our own utility set in Saudi Arabia. Having said that, I'm going to explain in details. Let me go over the objectives, but before this, the disclosure of conflict of interest. I don't have anything to disclose regarding this presentation, and I will not be discussing off-label use of medications. So I'll define the health outcomes in a very simple manner for non-health economics specialists, and then different types of health outcomes, and then move to discuss the need for obtaining the measured outcomes, and finally provide the guidance on the utilization of the Saudi utility sets. So this is the outline. I'll go over some introduction, why do we need this, and then talk about the EuroQL EQ5D5L instrument, and then move toward discussing some of the valuation of the EQ5D5L, and finally the stratified sampling that we did. And I'm not going to discuss the results because the results are actually in a huge in terms of the utility sets itself, the value of the utility set. And as you will see in a few minutes, you'll see that we're going to end up with thousands and thousands of different health statuses, and each health status will have its own utility set. And that's what we did, in fact. So it's very hard to present it in a presentation. It's going to be published soon, hopefully, for the specialists. But let me talk about why do we need this. So what are the health outcomes? The Constitution of the World Health Organization in 1948 defined health as a state of complete physical, mental, and social well-being. You know, most people think of, health as physical well-being. And some more sophisticated people think it's the physical and the psychological. But very few incorporate the social well-being. The social well-being is actually part of the definition of health as per the WHO. And not merely the absence of disease or infirmity, which means if I take a sample, well, I take everybody in this room, it's going to be very hard to find somebody who's 100% with 100% complete health, okay? You either have some physical, social, or psychological issues. Most people do. So in order to achieve what we call 100% health, you really have to be healthy, absence of not only diseases, but also having full physical, psychological, and social well-being. Now, what are the health outcomes, though? The health outcomes measure the change in the health status of an individual or group of individuals that is attributed to an intervention. Utilizing health outcomes of care will determine the impact of the process of care or the intervention on the patient's life by using specific measures before and after the intervention or the treatment, okay? And this is what we are trying to do in our utility valuation set for Saudi Arabia. Now, what are the different types of health outcomes? So everybody understands the clinical outcomes, cure, survival, prevention of a disease is an outcome. Reduction in certain morbidities or mortality is an outcome. And this can be measured through different ways. One is observer reported. So you, as a clinician, you observe the change. So the blood pressure, when you treat somebody with high blood pressure, and you give them antihypertensives, and then you measure their blood pressure, you observe the change. Same thing when you do with hypercholesterolemia, look at their LDL, diabetes, HbA1c, and so forth. Or it could be patient-reported. And before we move to patient-reported, and this observer-reported could be either by the clinician himself or caregiver sometimes. So when they, if somebody has, let's say, gastroenteritis, a kid having gastroenteritis, and the mother would tell you that they have improved, their vomiting has subsided, their diarrhea has decreased, then that's a caregiver, or could be a nurse, for example, taking care of a patient and monitoring their response to an intervention. Or it could be what we call proxy-reported outcome. And proxy-reported, it means that reported by someone other than the patient or the caregiver. Now, the other type of outcome measures is what we call patient-reported. So if somebody, let's say, having migraine, for example, there is no way of knowing whether they have responded unless the patient tells you that my migraine attacks have subsided significantly, for example, or did not subside. Same thing when we move to physiologic, and physiologic could be done through radiological examination like MRI and CT scan. You know, when we see, for example, when we treat multiple sclerosis and we look at lesions in the spinal cord and the brain that have either subsided in terms of their number or size, or actually stabilized in somebody who has been treated with a new therapy for multiple sclerosis. Same thing with CT scan when we talk about tumors or others. Now, all of this is under the clinical outcome. جماعة في mobile mic يا جماعة, instead of holding two things in my hand. The second outcome is what we call economical, and this talks about the cost effectiveness, or what we call sometimes, for simplicity, the value for money. And value for money can be expressed in different ways. There are multiple ways of economic evaluation. Part of it is cost effectiveness, cost benefit, cost minimization, cost utility, and others. Okay, the question is, can we measure health and the health outcomes? You know, there are multiple ways of measuring health. So for example, let me give you an example that we are all familiar with. You know, part of the vision KPIs, which actually helps us as healthcare professionals understand, is the expectation by 2030, or the target by 2030, to have our average life expectancies in Saudi Arabia reaching 80 years. Currently, it's around 74.8 or 75 years between males and females as an average. Our target is to be 80 years. Why do we have this target? Because it's one of the ways of measuring health in a society. There are multiple ways of measuring health in a society. Two main KPIs. One is what we call the life without illness, or life-free disease, and the other one is called the average life expectancy. Now, average life expectancy has its own limitations, but it's very good measure, among other measures, of evaluating the overall health of a society. So the longer you live, not as an individual. Yes, thank you, Mahmoud. اشتغل. أيوة. لا. يقطع يا محمود. Okay, good. Do we have virtual بالمناسبة people, Abu Ahmed? Okay. So I apologize for those who cannot see me here. So anyway, when we talk about the measure of health, we said one of the ways is to look at the average life expectancy. So average life expectancy, as I mentioned, has its own limitations, but it's a very good indicator of how the society, how healthy the society is. Now, you could argue, what's the benefit of extending life if this life is going to be full of diseases, complications, and all of these things? And that's when we talk about the quality of life. So when you combine the average life expectancy, when you improve life, and then you improve the quality of life, then you are addressing most of the health issues for a society. So measuring the length of life is easy, and that's what we do. You know, we look at mortalities, and we look at birth, and we look at what's the average or the median survival, And that's what we do usually for any calculations of average life expectancy. And it's very important to remember that in Saudi Arabia, in the early 1960s or late 50s, the average life expectancy was about 47 years. Can you believe that? 47. And that was about 60 years ago. Now, with the huge improvement in healthcare, and again, healthcare is not health. Health is different than healthcare. Healthcare, if implemented right, can improve health, but not necessarily. You could improve healthcare, but you don't improve the overall health. A good example is in the US. You know, in the US, they have the most sophisticated diagnostic and treatment technologies, the top hospitals in the world. Talking about quaternary care hospitals, they do very sophisticated things that, you know, cannot be done in other parts of the world. However, this did not really translate into improving the health of the society. Why? Because there are other determinants of health: social, psychological, and others. So not every improvement in healthcare can result in improvement in the overall health. The second important thing to remember is the quality of life. What kind of life are we talking about here? So in the quality of life is really a subjective thing. You know, if I ask any of you about the quality of life, you would give me something that is based on your subjective interpretation of quality. And in order to objectify it, there are ways, scientific ways of different pain interpreted by the clinician differently. So, you know, Dr. Abdulaziz, for example, as an emergency physician, has very high threshold of pain because he sees, the toughest, cases. Once an emergency physician told me, as long as you are breathing, for me, you are stable, okay? I don't have to see you. Family physician, they perceive pain and the interpretation of pain differently, similar to patients. Somebody who has a high pain threshold perceive it differently. So the effect on their quality of life can be variable. So knowing more and quality of life is an important endpoint in medical and health research. So you see research for some of the primary literature in the 1960s and 70s, you will find very little research on quality of life, even in randomized clinical trials, because it wasn't really a focus of researchers. But since the 1990s, the quality of life concept in terms of as an outcome in clinical trials, okay, has emerged and then became one of the most important endpoints that we look after. So we look at, for example, mortality as a solid outcome, but also we look at improvement in quality of life, because it doesn't matter if you extend, for example, but dialysis, all of these, then most probably it did not improve their quality of life. So now let's talk about three categories of what we call patient-reported outcomes. For patient, we outcome direct pro that the momentum to treatment, satisfaction with the treatment. I was given, Tara Muhammad, more time. You tricked me. طيب, give me 10 more minutes. رئيس اللجنة العلمية والله هو اللي قال لي. طيب. طيب, the second thing is, so these are the tools and instruments that we use to measure the patient-reported outcomes. The last thing is what we call pro-PMs, and these are the performance measures, the patient. And these to for obtaining different or measures or measuring the pros. You know, pros could be symptoms or patient functions like physical, emotional, psychological, and others. But we use pros to tailor patient therapy. So when the patient comes to you and tells you about their symptoms, you either adjust their medication or modify it. Of anything, any pathologies, okay? But the patient talks about the symptoms, heartburn, talks about, you know, flatulence, about regurg, about multiple symptoms. And if you focus only on the evaluation that you do without getting the patient-reported outcomes, then you are not really addressing what we call patient needs. So what's EuroQL? Okay, so EuroQL is a very prestigious institution, okay? Stands for European Quality of Life Institute, is actually the reference that created tools to measure the patient utility sets for each. So it's a very standardized way in order to measure the perception of patients in different societies or different countries. And that's why we need to do something that is specific to Saudi Arabia. In order, we cannot just import the EQ 5D5L utility sets from anywhere, and I'm going to show you why. Simply because the society is different. The values of a society is different. The perception of. So for example, we here in Saudi Arabia, being, you know, in our traditions, Arabs, Easterners, Muslims, whatever, all of these cultural differences than the West, for example, we perceive sickness and illness and we perceive death differently than a Westerner living in Alaska, for example, perceives it. Okay? Why? Because we come from different background, we come different value sets, we come from different culture. Levels or 5 levels, the Y means young. Use EQ5D, 5L, we use it in different ways. So clinical trials, observational studies, population health surveys, routine outcome measures, and health technology assessment, which is important in our talk today. So when you would like to evaluate the cost utility or cost effectiveness of a health technology, be it a medical device, okay, let's say would like to get a robot in the virtual hospital that Dr. Abdulaziz manages, and then they ask us, is it worth it? Is it good value for money? Then we will have to assess it in terms of health technology using health economics as well as quality of the intervention, as well effectiveness, efficacy, and safety. So we look at the clinical safety, efficacy, as well as the health economics evaluation. So let me explain the cost utility, because this is very important. When a quality of life, rather than the length of life, when I would like to measure the quality of life rather than the length of life, because length of life is very easy. We just calculate the pool of the population and we take the median, and that's the average life expectancy. When we would like to compare intervention versus no intervention, or two different interventions, then we need what we call the quality of life in this context. To quantify the benefits of in a cost utility analysis, we have to calculate what's called quality adjusted life. And in very simple terms is actually the years of life gained multiplied by the utility set value. So the years of life gained, we get it from where? From the studies. So if you tell me you take statin and then there is a reduction in mortality by such and such, and then you calculate number needed to treat, and then you calculate the number of years gained. So we get it from clinical studies. It's as simple as this. Well, it's not that simple, but I mean, we get it from clinical studies. Now, the second thing, how are we going to estimate the quality for Saudis? We have to calculate the utility set value for Saudis. So in order to calculate the quality, I multiply the utility value, and this is what we have been trying to do in our national study, with the number of years of life gained. So for example, if I gain 1 year and the utility value is 0.7, then it's 0.7 quality. If I gain 3 years and the utility value is 0.3, okay, then it's 0.6, even though I gained 3 years. But the utility value is so low, 0.3, the quality is actually 0.6, okay? Now, this is the example that I just explained. And we usually compare it with what we call the standard of care. So when I compare a new technology, let's say a new medication, I usually compare it to the standard of care. It's either placebo if there is no other known standard of care, or it's the current standard of practice that we use to treat such disease. And then I calculate the quality gained in order to say, if I use this medication, I'm going to gain 1.2 qualities, for example. Versus if I use that standard of care, I'm going to gain 0.8 quality. And then you can say, this is, then you can claim that this is more cost effective or has better cost utility. There is what we call ISOR, which is the incremental cost effectiveness ratio. It's the ratio between the increasing cost and the increase in the mean effectiveness, which is commonly used to compare the interventions. So when we have lower ISOR, means that it's better value. It means, so if I have, let's say, a new medication for diabetes, okay, and it's better in terms of HbA1c, it's better in terms of weight reduction, but at the same time, it has very prohibitive cost. Its ISOR could be high, despite the fact that it provides me better efficacy in terms of HbA1c, better weight reduction. Now, this is only talking, if the ISOR is high, then it might not be cost effective. And that's why sometimes you have medications for a disease that has no other medication. But then NICE, for example, comes and say, this is not cost effective. Why? Because its ISOR is very high. Last, I know you're waiting, Muhammad, but so there are multiple ways of doing it, and there are multiple statistical models. I'm not going to confuse you with this, but this is to tell you why EQ5D5L is important to facilitate the economic evaluation in terms of cost-utility analysis, because it's generic instrument. And when I say generic, means that it can be applied to everybody. Doesn't matter, any disease, any condition, any health status. If we use the EQ5D, and this is what I want to do, if we use the EQ5D 3L, we are going to end up with 319 different health statuses. Okay? Why? Because we have 5 dimensions and 3 levels, so 3 us 5, okay? صح? To the power 5. Now, if we have 5D, 5L, 5 dimensions and 5L, it's 5 to the power 5. We end up with 3,125 different health statuses, which means we have almost more than 10 times different health statuses, so it's more granular. It actually gives you more understanding of the different health statuses and different utility sets. Why can't we just use global utilities? I told you before, because we have different values, different culture, different backgrounds, and it would actually not work. These are the different countries that have completed the EQ5D 3L over there, okay, on the right side of the screen. And then once the 5D 5L has replaced it, newer countries that haven't done that, they were not allowed to use the 3L anymore. But the EuroQL said, okay, for most countries who cannot repeat it, it's fine to continue to use the 3L. Some countries elected to redo it, like US, for example. As you can see over there, they actually redid it to do the, for the 5L. Now, in the region, there is only Egypt that already completed their 5D 5L, EQ 5D 5L. Saudi Arabia is the next that completed the study, and we are publishing it, inshallah, Jan, February, inshallah. And then Lebanon have started, but actually it was stopped for multiple reasons. UAE, they just announced that they are going to start. They haven't received even the approval of EuroQL. The process was very lengthy. So we started this project 3 years ago. We had to submit a scientific proposal to EuroQL Institute, went through multiple ways of revisions and approvals. It got approved by the scientific committee and then approved by their executive committee. Despite the fact that there were 2 prior submissions that were rejected because of the scientific merits. And then they actually liked our proposal to the degree that they actually sponsored us. They gave us 40,000 euros and said, we would like to support you to do this study. We haven't received the 40,000 euros إلى الآن بس بتجي إن شاء الله. Then we moved to identifying, these are the phases. Then we moved to identifying the study documents development. We submitted our IRB to Ministry of Health and we got it approved. And then we recruited, EuroQL wanted, because this was the first time it's done in such culture, they were hesitant to do the whole study, so they asked us to do a pilot. And we did the pilot on 200 subjects. And then they checked every single data for their quality check. And we received more than 98.6% good quality. And they said, okay, you can move on with the rest of the 1,000 patients. And we recruited 1,000 subjects. And we got subjects from everywhere. Nas healthy, nas more healthy, terminally ill, people from malls, from airports, from vaccination centers, from everywhere, okay? And we had to, interview the patient with a very structured questionnaires. It's a computerized questionnaire for at least 1 hour. If we missed 1 minute, EuroQL would reject our interview. And finally, we ended up with huge data that went through, as aggregates, that went through deep analysis in order to estimate, some questions are trade-off questions. So we asked the patient, okay, if you get, for example, renal failure, chronic renal failure, end-stage renal disease, would you prefer to die while you get end-stage renal disease and receive dialysis? Okay? Some people would say this or that. No, it's not as simple as this. And then if they say, مثلا, of course we prefer to be on dialysis, but not die. And then we tell them, okay, how about if you receive dialysis, okay, would you prefer to receive dialysis in exchange as a trade-off, in exchange of losing some other health benefits? So it's a very sophisticated survey in order to quantify each health status. And we ended up with complete documents that we analyzed, and we finalized this into, we had to go through multiple ways of announcement. So when campaigns, it was very difficult during COVID-19 because during the lockdown we couldn't recruit subjects. And we went, this is the different 5 dimensions, but I want to go over this, and I promise you, Muhammad, I will stop here. So these are the different 5 dimensions. These are the 3,125 possible health states, okay? For each dimension, there are 5 different levels. So mobility is 1 dimension, okay? For example, here, I have no problems in walking about. No problems whatsoever. Now, the extreme example is I am unable to walk about. And by the way, when we translated it, because it hasn't been translated before, we had to go through multiple ways of translations, okay? We had to even customize the translation into what we call the Saudi version, okay? Because the way people understand things here are different than, for example, Egypt in terms of wording. The self-care as a dimension, usual activities, pain and discomfort and anxiety and depression. And in each dimension, there are 5 different levels, which brings us to 3,125 health states. Okay, I think I'll stop here. So what we do, for example, here, if we calculate the EQ5D5L values, we end up with huge number of health states depending on the different health states that we get from the 1,000 subjects, okay? So for example, this patient or this subject checks number 1 for dimension 1, but checks number 3 for dimension 2. The other patient or the other subject checks it differently. So we ended up with more than 21,000 different possible health states. Okay. طيب, so I'll stop here, Muhammad, and wait for other questions. طبعا, I cannot present to you the results because that means I'll have to show you the 21,000 different set value for each health state, which is meaningless. It's going to be published as an appendix, inshallah. Thank you very much, and I apologize for taking longer than expected. Questions now, Muhammad? Questions now? Questions الحين؟
تفضل بس. طيب, thank you all. We will take just only if we can have one question. Okay, before the questions, Dr. Judea, and I know that you have a meeting in the ministry. Does this allow us to take the next speaker, Dr. Jafali, then we can open it for the questions, or should we finish the questions for you?
My meeting starts actually in 19 minutes, so I'm afraid I can't.
Okay, so we will take just only one question from the audience. I know that we took longer period of time for this lecture. However, this is done once in the lifetime. Therefore, it is worth that everybody knows about it. Thank you, Dr. Judea, for this great effort. Thanks for this presentation. And audience, if you have any question, please. Dr. Hamoud, تفضل.
شكرا. Amazing, Dr. Ahmed. We're really excited to see this published. One thing that I wanted to highlight, maybe not in the core of the talk, but the effort that you had to do to get this translated. We've had a lot of challenge doing similar work in other validated tool. And I would like to ask you to also publish the effort for just publishing translating the tool, if that's possible.
Thank you, Dr. Abdulaziz. In fact, this was a very lengthy process. We had to translate it into by 2 authorized translators separately, okay? And then 2 other different translators had to review it and revise it. Then we had to bring different Saudis from different regions, okay, in order for us to test their understanding, because we did this across the kingdom, in the whole different cities, because different, values might, or perception might be different in different regions. So we made sure that we bring Saudi individuals from different regions and test the translated version multiple times. We had to change certain wording based on their feedback. يعني ما أبغى أعطي أمثلة بالعربي, لكن we really had to change certain wording so that it can be understood by different people. يعني sometimes instead of مثلا saying in Arabic مثلا موت أو death, we say it not being alive, okay, in Arabic, which is sometimes very difficult for people to understand it. But we had to customize it to the Saudi, I would say, dialect or level of understanding the Arabic. It wasn't, pure Fusha, Arabiya Fusha, لأنه sometimes the way العربية الفصحى would change, would reflect the meaning is different. But absolutely, this is going to be also published in an appendix. We'll have it as different appendixes and supplements. So the details of the study will be published to everybody, because this is very important for researchers, for clinicians, and most importantly for health economists, to use the utility set values whenever they are conducting economic evaluations.
Thank you, Doctor. Any other question? Any other question, please? So, thank you, Dr. Judea.
Thank you.
Thanks, doctors, for this fruitful discussion. And now I would like to invite Dr. Abdurrahman Al-Swaidi to the stage for recognition. دكتور أحمد الجديع. الدكتور محمد الشناوي.
Actually, they are giving me the most hardest session in the conference. The two lectures actually are two things done once in a lifetime, and we really appreciate the hard work done by the two speakers in their areas of work. Our next speaker is Dr. Ibrahim Al-Jaffali. Dr. Ibrahim, he's the Chief Strategic Purchasing Officer, Center of National Health Insurance, CNHI. He's an Associate Professor at College of Pharmacy, King Saud University, PhD degree in Pharmaceutical Science, University of Georgia, Master Science in Pharmacy, University of Georgia. Please welcome with me Prof. Ibrahim Al-Jaffali when he will talk to us, give us his presentation about insurance in the kingdom.
ممتاز. السلام عليكم جميعا، صباح الخير. Today I'm not going to present CNHI, I'm going to present National Health Insurance. I'm going to present things that are a little bit related to the coverage of beneficiary in the private sector. We work closely with CHI, which is the Council of Health Insurance, to standardize access to medicine in the private sector. it's not necessarily a government discussion, but this is the reforming access to medicine in the private sector. Privately insured patients currently represent around 30% of the entire population, but it's expected to increase significantly by 2030 to represent more than 50% of the patients that are receiving care in the healthcare facility in Saudi. So when we talk, most of my discussion today is around private sector. So 21% of the overall expenditure or spending in the private sector is currently medication. If you have a private insurance or a commercial insurance, or they call it التعاوني, you know there is a massive issue in access to medicine. You can visit any practitioner in the private sector within your network, and he can prescribe freely without any guidelines or regulation any product that are currently registered by Saudi FDA. And most of the time there is no prior authorization or request for an approval from an insurance company, especially if the product is below 1,000 riyal prior to November of 2022. So the medication cost is increasing significantly, especially with the introduction of a new product, especially of an advancement in medication, especially with the discovery of medication that could be used to treat diseases that we never thought that we're gonna treat it in the past. With a tag or prices that are insanely expensive. Some of these medication could be used in the private sector, but most of these medication are used in the government sector. But still, some of the medication that even used to, currently are used for treatment of chronic disease are costing the system a hefty amount of money, taking in consideration that some of these diseases are expected, or the percentage of the population that's suffering from the disease is a little bit high. For example, diabetes, hypertension, or hyperlipidemia. Some of these diseases or some of the medications that are recently introduced to the market are costing the system a hefty amount of money. So private health insurance growth, I mentioned in 2010, it used to be only 3 million population. In 2020, we have about 20 million population, or 20 million beneficiary that have a private health insurance, and expected to reach around 21 million population. And this is actually in alignment with His Royal Highness the Crown Prince, when he mentioned that we are pushing to increase the population of Saudi Arabia to 50 million inhabitants, including Saudi and also expats. So the percentage or the overall number of beneficiary at that time will reach around 21 million beneficiary that will have or should have a privately health insurance. Plus that we are expecting to receive or to have a 33 million visitors. So when you combine these together, it's expected to have more than 50 million beneficiary at any single year that need to be, their insurance and their private health insurance need to be regulated properly. We are talking about 60 billion riyal worth of policy in 2030. The overall objective of CHI is to provide comprehensive health services that are aligned with the health transformation program. And there is a lot of talk now about universal health coverage. There's a lot of talk now how we're going to expand the services, how we're going to expand the offering, how we're going to expand what are the diseases that are covered by a private health insurance, just to make sure that we're in alignment with the national transformation program. So this is just to get an overall understanding. In Saudi Arabia, by year we have an increased expenditure per capita when it comes to private health insurance, but still the outcome is not measurable, or it's not necessarily increasing as we're increasing investment in the healthcare sector. the presentation here are only talking about private health insurance. But when you look in other country where they have a significant transformation in their program or in their offering, for example, in Netherlands, then the expenditure somehow flattened or decreased a little bit and then start to getting flattened, but they introduce a lot of intervention. Primary care services or primary care acting as a gateway, population health and population health management, introducing or redesigning or remodifying access to medicine and introducing insurance drug formulary, remodifying and increasing the benefit in the benefit package, redesigning payment program or payment methodology, introducing DRG. Hopefully these, type of information is not boring to government, people who work in the government, but believe me, this is the future of even governmental funding. Governmental funding currently are working or using what we call a line budget item or an input-based budget, where the only thing that we are counting is an input, for example, salary, budget for pharmaceutical expenditure, number of beds in a specific hospitals, but the future is actually to change funding models that will match outcomes, or at least it will be linked to outcomes. So if we keep the system operating as it is, so it's expected to increase without proper increase in outcomes. So most of the, introducing value-based care or introducing value-based payment or re-engineering how we're going to fund service into the private sector, potentially or hopefully it's going to bend the curve. So instead of increasing significantly to reach about 3,500 Saudi riyal per capita, especially in the private sector, we can at least reduce the expenditure to normalize it around 2,000 riyal per capita, which is a 42% decrease from an expected increase in the cost of doing business. So when the CHI, when they develop their own strategy, then they design a strategy that will uplift the private health insurance from 2020 to 2024. And most of the focus that I'm going to focus today is about EBP reforms or essential benefit package reforms. So the idea that probably if you are following the news, or I think some of you have a private health insurance, you noticed that the announcement of the CHI about introducing a new health benefit package, an expanded health benefit package, some of the adjustment to the access to medicine, pushing a beneficiary to switch to generic, introducing copay in the access to medicine, introducing insurance drug formulary, so it's no longer an open menu for practitioner to prescribe. So the strategic pillar for such strategic programs are actually beneficiary-centric. So we need to improve the beneficiary journey, beneficiary quality of life. We need to have an enablement to the sector. We need to enable the sector, make sure it will grow. It's a value-driven sector, so it's focusing on outcome, not necessarily an input. Being a progressive regulator that are focusing on how we're going to improve the sector in general, and also having a digital excellence. So formulary system, I'm guessing you are familiar in the government sector of why and how we should implement a formulary management within a specific hospital. But in the private sector, it wasn't the case. It was a fragmented effort. Most of the practitioners are actually acting independently. Physician in their own clinic, they are acting independently from the entire hospitals, especially if they work in a polyclinic or a primary care facility, or in some of the hospital. So they are working independently, they can prescribe, and there is no internal or external regulation when it comes to access to medicine. So the idea is we need to make the prescribing more rational, enhance appropriateness, and also minimize the risk. And also improve cost effectiveness when it comes to pharmaceutical expenditure. One of the main issues that are facing the local market is actually generic substitution. And I know that some of the pharmaceutical market that are pharmaceutical manufacturer that are currently in the room, they don't like that picture, but it's actually a reality. You know, if you compare our market to a mature market like US, you know, in US market, 10% of the entire expenditure are actually branded, and 85% are actually generic, and the rest could fill the gap with a specialized generic or modified generic. While in the Saudi market or the Saudi context, the percentage of brand is about 76%, while generic account for 23%. This figure not necessarily applied to governmental hospitals or governmental procurement, but it's purely true when it comes to expenditure in the private sector. So the idea of implementing, why we are implementing a national formulary. So when health insurance drug formulary introduced, it was an open formulary. It covered most of the medication that are cost effective in a certain category. So the idea by implementing that national formulary is that we're going to enhance generic substitution. We're going to promote generic substitution by having a full or partial replacement of brands with generic that will trigger cost effectiveness. We're gonna encourage guideline adherence and the saving will come from a clinical impact or a potential impact, and also that clinical guidelines by not only adhering but also improving the outcomes of following the clinical guidelines. Uncalculated saving from such an exercise, it could be massive. We haven't, most of the issues that are related to data structure, the way insurance or providers submit their claims when it comes to medication expenditure is a little bit fragmented. So we try to understand as much as we can from the data that we have. So a simple guideline, following a proper guideline or the recommended treatment for metformin alone will reduce or will save about 28% when it comes to expenditure for diabetes only. And we took some of the cases, we review it, we look into it. We know that metformin is not going to be the drug of choice in most of the cases, but at least if you follow properly the guideline by introducing the first line of treatment in type 2 diabetes, the potential saving and that pocket of, or in that category of beneficiary is massive. So it's an evidence-based formulary. It wasn't done out of the blue. It was structured in a way to make sure that there's going to be a proper governance and a comprehensive process that are evidence-based, are taken in consideration, that we're going to provide equity. It will actually improve or ensure cost containment. That will, the entire process will be governed by a proper rules and regulations. And also, it will support us or support CHI to push private health insurance to have an improved premium utilization. What I mean by improved premium utilization, by the introduction of a new benefit package last month, we added new services. So we are, not to overwhelm we call them the policyholder or the employer or the one that actually who's paying for the policy. So if we introduce more services without trying to manage the cost, so the cost of the employer will rise significantly. So, hopefully by introducing insurance drug formulary, we'll be able to have a cost saving from one side that will support the payer and support the policyholder for improved premium utilization. And last but not least, having a standard implementation. We don't have a way to capture standardized data when it comes to medication utilization in the market. Some insurance or some provider will use Saudi FDA. Some providers will use different type of coding. Even Saudi FDA coding or registration number, it doesn't give a lot of information when it comes to medication or when we try to compare medication. So we introduce a proper implementation of coding, especially when it comes to diagnosis or the treatment or the diseases that we are trying to treat, and also proper coding for medication. So, and how are we going to introduce saving, or what are the other issue in the insurance drug formulary besides generic switching? So we introduce what we call prescribing tool or prescribing editing tool. So things that will be used by for emergency only, step therapy, quantity limit, how many milligrams or pills or bottles or capsule that could be or should be dispensed or prescribed in a single month or a single cycle. We are limiting the use of OTC or over the counter we are limiting only for a specific condition with a specialized prescribing. For example, we are no longer covering cough syrup in the private market. It used to be covered, but no longer. Making sure that there is no concurrent use that will prevent duplicate therapy, and also making sure that there is a protocol edit, especially for diseases that will require multiple medications that we're going to use at the same, for example, chemotherapy regimen. So in the first release of the insurance drug formulary, we did not cover all of the medication, but we cover all of the indication, but we cover a good percentage that represent 80% of the overall spend. So this is how we get how the insurance drug formulary is actually published. It's actually published on CHI website, that if you are interested, you can take a look at it. We classify or we categorize the medication by, instead of how formulary are actually built in most of the governmental hospital by drug classes or by drug name or by scientific name, we switch it. So we're gonna start the formulary by the indication. So we'll start by the indication and then list all of the drug classes that are covered by that or should be used for that type of disease. And then we use the ICD-10 code for that specific type of indication, using the drug class, active ingredient, ATC code, dosage form, route of administration, strength, if there is generic available or not, and that is just for guidance only. We should rely heavily on Saudi FDA website. If there is any prescribing edit, and it's usually mentioned in the notes, if there is any quantity limits for adults, and if there is any quantity limits for pediatrics. So we exclude a lot of groups from that formulary for the purpose of some of these groups are not necessarily covered or shouldn't be covered, or there is no scientific evidence that these excluded medication should be covered. For example, surgical aid, artificial tears, topical agent for bruises and burns, cosmetic fillers and therapies, OTC medication, vitamins, so acne medication. So we're trying to make sure that we cover what should be covered based on the benefit package. So in the first release, we cover 16 category and 139 indication. The number of indication will increase soon to start to cover most of the indication that are currently provided in the private sector. So we group them in 16 category: disease of the circular system, endocrine, mental and behavioral, immunological, nervous system, other type of disease, neoplasm, respiratory tract infection, and also other type of preventive groups that we could add these medication into, or add these indication into this category. So following up, what are the how the market should adapt to that insurance drug formulary. So it was a concept that wasn't necessarily introduced previously in the market, which is a PBM function or pharmacy benefit management function. It used to be it wasn't, properly introduced in the private health insurance, but now we see a lot of the insurance company currently, at least mega insurance company in Saudi market, start talking about pharmacy benefit management. It's a concept that are widely used in mature market like in the US. But hopefully we'll see it soon that we will have a pharmacy management programs and pharmacy management platform that are introduced into the market. I'm not going to spend too much time on but it's a future role of pharmacists in the private health insurance sector. Some of the policy that we introduce is a cost containment and utilization control by eliminating or limiting prior authorization for some of the medication, introducing step therapy, and also enhancing or improving or supporting generic substitution by improving generic drug utilization policy. We have a long-term priorities when it comes to revision and also introduction, high-cost and specialty drugs. We know that gene and cell therapy will come into the market, especially in the private health insurance arena. So we need to work as a regulator progressively to cover that gap. So in conclusion, it's access to medicine is a major area of development in the private health insurance. We know that we have been doing a significant amount of work in the past, but more to come within the next few years. Hopefully, as a pharmacist, we'll be proud of how the private health insurance sector will be developed soon, and more opportunity and more scientifically equipped pharmacists will be required to work in the private sector. Just before I close, I just need to make sure that I don't represent CNHI today. I'm representing CHI. I work as an advisor for Dr. Shabab for pharmaceutical sector development. So most of my talk today is about private health insurance, nothing related to governmental health insurance. Thank you so much.
Thank you, Dr. Ibrahim, for this great, insightful presentation about the insurance and formulary and creating of the formulary. If you allow me, I have one question. How dynamic the formulary is? For example, if there is a new drugs that are coming to the market or will join the market, so how can we, is there, in the regular process, we know that we will have the Pharmacy and Therapeutic Committee and they have to review the drug. So what's the process in order to add or to include in that formulary a new medications, and vice versa, if there is a delay of or a medication that needs to be deleted or withdrawn from the market. So what is the process of the dynamic of that formulary?
طبعا we believe this is a dynamic and also an ongoing process. It's not going to stop by the development of the formulary. I haven't spoken about the different formulary committee that are established under CHI. If you look into or go into the website, especially if you're a pharmaceutical company are interested, or a provider that you're interested to add or to submit a change to the formulary, we have a long process. I'm not going to say a long process, but a formula that you need to, or for forms that you need to submit. We actually work closely with the Health Technology Assessment Center at MOH to evaluate products. We have a P&T committee that are reviewing the outcome of health technology assessment entity or centers and approve or reject introduction to the formulary. So the cycle is a pretty good, short. Is about 4 to 6 weeks for review and approval or adjustment. For approval or adjustment. But it's an ongoing process. The committee meets at least once or twice a month. We have a good secretary that works at CHI. And we expect that the work was not gonna stop. But again, if something happened on the market, and a product that are introduced into the market that wasn't covered, so insurance and the insurance company and the provider can agree together to prescribe and dispense based on scientific evidence that are currently available.
Thank you, Doctor. I want to open the questions for the audience. MashaAllah, we have a lot of questions. So we will start. Dr. Hazza.
Assalamu alaikum. First of all, thank you all for the great conference that we are in now, and thank you for Dr. Ibrahim for the great presentation. I only have one question for you. When do we expect to see rejections or waiting for approvals to be more happening when the pharmacist is dispensing a medication like what we have now, and when we have lab tests and when we have other services, we wait sometimes for a long time for approval. Is this going to impact the way that medication dispensing going to be dealt with, and that we will have more time to wait for approval in other parts, or this is something that we'll not see in the near future?
طيب, I mentioned removing prior authorization. So the idea is by introducing PBM function. So if you go into the detail of CHI regulation, now we are asking insurance company to have pharmacy benefit programs or pharmacy benefit platform. So that pharmacy benefit programs or platform will have an e-prescribing or e-prescription capability. So the idea is that most of the authorization for pharmacy dispensing and prescribing should be done electronically. So instead of manual approval or sending, and there is a human being at the end, at the other screen reviewing the authorization, it should be done automatically by introduction of e-prescribing and e-authorization, an automated authorization, and also pharmacy benefit management. So this is a massive change in the market. It will require a proper infrastructure in place, a proper connectivity. So I haven't spoken heavily about the journey of the prescription, but the e-prescribing, it will remove a lot of obstacles when it comes to patient journey. So before the patient even left the physician office, he will know that his prescription is actually approved. So a physician will type in the prescription, will hit submit. He will receive an instant response, either by approving or rejecting or a warning or any type of messages, and then he will be able to generate the prescription. And the beneficiary is not going to be potentially in the future. And we are working with the insurance company to implement this. We will not, or we should not have paper prescription anymore. So it's going to be an electronic prescription, similar to what most of the governmental hospitals are doing now. But instead of going to the pharmacy within the hospital, you can go anywhere within the kingdom by having an electronic prescription in your cell phone or in your mobile phone or in your application that you are using for prescribing.
Thank you, Dr. Ibrahim. The time allows us for one more question, please. Dr. Fagihi, تفضل.
أنا الحمد لله يعني أنا توقعت إنه يعني في IHOP الناس ما هو interested في الانشورنس، بس يبدو إنه كويس.
السلام عليكم، دكتور عبد الرحمن فقيهي، كلينيكال فارماسيست. شكرا دكتور ابراهيم على المحاضرة القيمة والفورماتيك أيضا. بس أنا بطرح السؤال بالعربي على أساس يكون cleared for all the audience. أولا هل موضوع الفورمولاري هل تعملون تحت مظلة اللجان الأخرى سواء في وزارة الصحة أو في السعودية FDA؟ هل الميديكيشن المعتمدة عندكم في الفورمولاري تعمل تحت المظلة هذه، ولا أنتم عندكم committees different وعندكم other items not included in the Ministry of Health or Saudi FDA؟ هذا السؤال الأول. السؤال الثاني، ما شفت الزيكاتريك ميديكيشن ديبريشن شيزوفرينيك لايك ذات، يعني هل هو اكسكلودد من الفورمولاري
او حتى من الديزيز نفسه الانشورنس ما يغطيها كزيكاتريك بيشنت؟ شكرا.
طبعا بجيب على السؤال الاول. in the past psychiatric disorder wasn't covered as part of the benefit package, but currently is covered. But there is a cap on how much you spend per year on that specific category, and also the medication is covered. And there is also rehab session or psychotherapy session are currently covered as part of the new benefit package. Formulary, no, it's a separate. Remember that insurance are not similar to the governmental sector when it comes to coverage, but we abide by Saudi FDA registration. So we use the Saudi FDA registration as the entry into the insurance drug formulary. But you know, and most of you know, that there is some medication that is not registered by Saudi FDA, and we have to use it. So if there is an alternative medication that could be used as a registered medication, we usually avoid unregistered medication. But if there is no option but to use unregistered medication, especially for crash card items or some of the disease that you have to use unregistered medication, so we use it. So it's not related to the PNT or not related to the formulary of the ministry. Ministry of Health, Dr. Mohammed can elaborate better than me. It's a closed formulary system. In insurance drug formulary is an open formulary system. So it's two totally different type of system.
عندما نستخدم مثلا دواء خارج المنظومه الموجوده وتحتاج انك تدخله للبلد، ايش الصعوبات اللي يواجهها مثلا المريض ونفسه انتم حتى يدخل للبلد؟
يعني موجود طبعا. الميشنت ما يواجهها، هو اللي يواجهها البروفايدر. يعني عاده مستشفيات وصيدليات القطاع الخاص اذا في بعض الادويه اللي يحتاجونها خصوصا في الهوسبيتال. اغلب الادويه اللي يحتاجها المريض هي موجوده في الهوسبيتال، او اللي يحتاجها المريض وعاده ان ريجسترد تكون في المستشفيات. ففي بروسيس موجوده مع الزملاء بالاف دي اي، اذا البرودكت ما له بديل ولا له الترناتيف ومحتاجه المريض، في له اليه للاستيراد.
شكرا جزيلا دكتور إبراهيم. Thank you. I know that يعني despite your flu and you are sick.
لا والله I'm a little bit sick.
You attended our conference. Thank you. Thanks a lot. And we really appreciate your presence with us. Thanks for everything.
شكرا جزيلا.
شكرا.
It's time to appreciate Dr. Ibrahim Al-Jaffali for this enriching talk. Dr. Mohammed Al-Shannawi, please step in for the recognition. Proceeding to our next topic, entitled Automation in Hospital Pharmacy. Our moderator for this topic is a Pharmacy Informatics Officer at King Faisal Specialist Hospital and Research Center. He holds bachelor's degree in pharmaceutical science from the College of Pharmacy at King Saud University in 1996. Had a Master of Science in Health Informatics in 2012-2013 at King Saud bin Abdulaziz University for Health Science. Ladies and gentlemen, please welcome Dr. Mu'tasim Al-Zamil to the stage.
Assalamu alaikum. Good morning, everybody. First of all, thank you very much. It's really a pleasure and honor to be again coming to IHOP. I remember I came there before 3 or 4 years ago, and this is really just refreshes my memory to be back with my colleagues again, and looking forward to be having this presentation with you. Hopefully this is going to be delivering something very special for you. Unfortunately, I just have a small announcement that we should have been having also Dr. Rani Al-Jaber with us. Apparently, unfortunately, she cannot make it today, so we apologize for that. But what we're going to be having, inshallah, we're going to be having a scientific debate. We do have 2 highly respected delegates with us. We're going to be talking really about the current and future roles of pharmacy informatics in Saudi Arabia. As you know, we're moving right now towards a vision of 2030, and one of the objectives of moving towards 2030 is to be having digitalized healthcare. This is what we're aiming to. So I'm sure that this session is going to be delivering for us something very valuable, especially we have two highly respected delegates with us. So we do have Dr. Hazza Al-Ghamdi. Hazza Al-Ghamdi right now currently is in King Faisal Specialist Hospital. Currently he is in Health Information Technology Affairs. But he just got promoted right now as a manager of pharmacy services. He's going to be in outpatient pharmacy. He was the team leader in the Healthcare Information Technology Affairs. Currently, he's taking studies in Executive Master of Business Administration at Prince Mohammed bin Salman College. And he holds a Master of Health Science, Health Informatics, and at King Saud bin Abdulaziz University. And also he holds a bachelor degree in pharmaceutical science from King Saud University. So please everybody welcome with us Dr. Hazza Al-Ghamdi. تفضل دكتور هزاع.
Bismillah ar-Rahman ar-Rahim. I would like to thank the organizing committee for this great conference and for giving me the chance to share with my colleague Dr. Mu'tasim Al-Zamil and Dr. Abdullah Al-Sheikh this session. Before we start, we had a debate between me and Dr. Abdullah Al-Sheikh actually on how we should approach this session. And we concluded that there is a misunderstanding between the differentiation between health informatics and pharmacy automations. So what we decided that I will tackle pharmacy informatics from a pure perspective of informatics, and then he will target the automation as an automation. Even though in real life they are both integrated so much and they both interchange so many of their aspects in real life. But for the sake of the debate, we will separate them 100%, and hopefully we can deliver the differentiation and to deliver for you how we can utilize both the informations and the technology and technology and automation solutions to improve our practices. So going a little bit to the history, what's health informatics in general? Health informatics is the science of how to use data, information, and knowledge. It's not about a robot, it's not about a computer, it's not about any other thing. It started as a libraries of patient information documented in folders and stored at the hospital. Whenever you want to utilize the patient information, the data of their labs, for their history, and the knowledge that was captured in previous visits, you are using or you are utilizing health informatics solution in that point of time, regardless if you are using an electronic health record or hospital information system or anything else. So this is how it started in the beginning, with the purpose that you use it to improve the human and the healthcare journey in general, and to deliver the healthcare services for the patients. After that, started to be implemented in a more focused area in pharmacy in the early 80s, where pharmacists started to document what they dispense for multiple purposes, either for inventory management or for financial documentation and financial reports. Then in the beginning of the early 2000s, when the To Errors Human report was published, more involvement in the electronics and in the electronic solutions were implemented in pharmacy practice, starting with computerized physician order entry, where the physician started to enter the prescriptions directly in the system, and the pharmacist receiving those prescriptions without paperwork, and in implementing the clinical decision support system that was discussed in the morning from our colleague. But at that time, there was no application of any AI in those clinical decision support software or systems. It's basic if-then rules that if the patient have this allergy from this medication, for example, and you enter that medication for that patient, then I will give you an alert to stop you from that action. Very simple clinical decision support system was introduced at the beginning of the early 2000s. Later on, this field or pharmacy informatics started to grow a little bit until it was recognized or it was identified from the ASHP, which is the American Society for Hospital Pharmacy. They published a report to define the roles, responsibilities, and the competencies that you need to be a someone working in pharmacy informatics. And they updated that report in 2016. So there is a recognition of the role of pharmacy informaticians in the pharmacy practice. And it started to grow year by year with more information and more data stored in the electronic health records in the hospitals. So the electronic health records started to get more integrated, and we started to have more than a CPOE component in hospital information systems. So we have lab information system, we have radiology information system, and all of those solutions integrated to each other and communicating with each other, delivering information between both systems, all of those systems. We started to have a cumulative hospital information system that give better utilization of the data and the information stored for our patients. And with those integrations, it started to have a huge opportunity to create specified work list where you can see all of those information for your targeted patients. And you started to create more specified clinical decision support system and creating rules that are more advanced. So if you have a patient with that certain lab monitoring the lab results, and the physician is trying to enter that medication for that patient, it gives him an information or an alert that you shouldn't do that because the patient lab results are 1, 2, 3. So the patient is in risk to have any other complications. So such automations and such rules are only able to be done because of the integration between the multiple information systems that are related to multiple practices in the hospital. Going a step further, after those integrations and those AKM rules and those automations, we started to have specialized modules within the information system or the hospital information system. We started to see oncology-specific modules. We started to see transplant specific modules. Even there is clinical trials specific modules that can be implemented within the health information hospital information system to improve the quality, the safety of the services provided, and also to ease the use of the practitioners themselves to make them do their job more efficiently in timely manner. So one of the projects that actually I worked with in King Faisal with the team to create a work list that can minimize the time spent by the pharmacists or the clinical pharmacists or the physicians to see all the patients that are on antithrombotics from 90 minutes to cover 5 patients to see all their labs, all their related documentations to 5 minutes. So, and that doesn't only cover 10 patients. You can see all of your patients within 5 minutes. How? By creating work lists that can capture all the related information from your specific in that work list, you will see all the data in front. What type of intervention was done, what documentation have been applied for that patient. So those applications cannot be done unless we have the previous steps done. So we have pharmacy information system, radiology information system, other information system in the hospital, all integrated with each other so you can have a comprehensive picture. Sorry. Last but not least, there is also different applications of health informatics in the practice, not directly related to patient information, but to solutions or systems that can be implemented together with it. like having virtual clinics, like having telemedicine. Now we have a lot of clinics for follow-up with antithrombotics for the patient, transplant patient for anti-rejection medications. Those services started to go to the virtual era, to have a virtual clinic where the pharmacists from the hospital are video conferencing the patient at home, checking his lab results from the patient self-monitoring devices or the near hospitals that he got their results from. So those services started to also emerge, especially with COVID-19, that made the process of implementing new technologies get a huge advancement, that within 1 or 2 years, we got the advancement that was projected in 10 years in the future. After a few years of implementing those hospital information systems, collecting data from the patients, we started to reach a point where we have big data in our hospitals. With those big data, we can create multiple new things. I will start to talk a little bit about data analytics. In general, any study that we do, any retrospective study that we do, it's actually a descriptive or we start with descriptive analytics. Describe the patient, the data that we have, and what happened from those experiences that we faced in the past. Going a step further in the data analytics journey, you will try to understand why those things happened. So that's called diagnostic analytics. A step further, that will require having a big data, which you reach a point of having predictive analytics. And that step is what currently we are starting to see in some of the hospitals, where we have prediction models to predict what will happen in the future. Using those technologies and prediction models is actually started to be seen in the pharmacy practice. Some of the hospitals started to get prediction of how many prescriptions is going to be done during the week or prescribed during the week before the week starts. So you can plan for your staffing, you can plan for the workload, and even which time of the day you will have a huge amount of patients coming to your way. So that's one of the applications. Other applications also in the clinical pharmacy to predict patients' outcomes from specific actions, like when you are starting to plan to discharge the patient from the hospitals, then there is some prediction models that can predict that the patient will be readmitted within a few number of weeks or a few days. So those actions, to be able to reach that point of predictive analytics, you need to have big data, you need to have proper data. Our colleague Hassan Ashmawi in the morning mentioned, if you have a garbage data in, you will have a garbage data out. So it all starts from the first step of the way, the first point that I discussed today, which is the data and the knowledge that we have and how it's documented in the system. Sometimes we forget that when we are dealing with the system in the hospital, that we just want to deliver the care of the patient as fast as possible. So we bypass some of the data entry steps that should be done, or we don't focus more on the quality of the data we enter in the patient file, especially when you have specific directions to get the medication. Some of the pharmacists, sometimes they will say, I don't have time, I have a long waiting time, I will just type it in the prescription or the label after I print it. Those information will impact whatever you create later on as a prediction model, as other point in the future. With that, I'll try to stop now to give my colleague more time to talk about the automation, but it's really important that the journey of the information that starts from the pharmacist documenting his data, the patient data in the system, to how to make it integrated with multiple systems, how to create rules, create CDS, clinical decision support systems to improve the daily practice of the pharmacist and the other healthcare providers, to a point where you can start to create prediction models to predict what will happen in the future. And the ultimate predictive analytics that we can hope for is to have perspective analytics, where the prediction is not coming only as a prediction to what will happen, but with recommendations to what you should do to prevent that prediction from happening, or to improve what will happen with that prediction. So that's what we call perspective analytics. With that said, the pharmacy informatics is now one of the fields that are really important in hospital settings, and we started to create multiple platforms to educate people about pharmacy informatics and to start to empower pharmacy informaticians within the hospitals, either by having their own teams within each hospital settings, or to have a specific task force within each pharmacy or hospital, pharmacy department in any hospital. With that said, I would like to thank you all, and I will give my colleague the time to start to talk about the automation, which is, for the sake of the debate, is totally different about informatics. Thank you.
Thank you very much, Dr. Hazza. I think that was very informative. Healthcare informatics, really, it's a spread of information that you look into. So I think that one session that we talked about is a small part, which is the informatics part of it. And I think that there's another role, a continuation of that role, is talking about the automation in it. Having that part is going to be delivered by Dr. Abdullah Sheikh. Dr. Abdullah Sheikh is a population health management led and at Ministry of Health, health holding company project. He holds a master's degree of health administration from Health Informatics Concentrate School of Health Studies and Education from St. Joseph's University of Philadelphia. And he holds also a bachelor's degree in pharmacy from King Khalid University from Abha. So please welcome with us Dr. Abdullah Sheikh. تفضل دكتور.
بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. It's a pleasure, Allah, to be here with you today. My speak today, it's maybe a first time after a while. So thank you so much for being here and support me to present this topic. Thank you, Dr. Muhammad. Thank you for the organizational committee, for the scientific committee, for this informative conference. Today, as what Dr. Hazza said, we will focus more in digitalization, especially in health informatics, in pharmacy informatics, and pharmacy automation. He covered the first part. I will move to the pharmacy automation, but before that, I need to mention our vision 2030 because the big part of this vision, it focused more in digitalization and how can we get a benefit from technologies. I think the main thing that automation can solve some of our issues by using data and technologies to get benefit from. The main program of the Saudi Vision is the Health Sector Transformation Program, and it aims to restructure a health organization. Talking about the pharmacy automation, we have to think about the history. So it's shaped in the late of 60s by Krebs, who invented the first portable digital tablet counter. So he's a role model in pharmacy automation, and there is a company by his name. So the definition is the electronic process of distribution and storing and packaging, also counting prescription medications by using, for example, robotics or medical equipment and information technologies solutions. Of course, if we implement the automation, we will get a lot of benefits Some of these benefits, the automation will increase the speed, also increase the accuracy, enhance the security, getting better productivity, also reduce the cost, which يعني the main concept in these days. And the last thing is reduce the medical waste. I would like to mention this picture because it's يعني الclosed loop of medication management. يعني this process it integrate all components of medication ordering and verifying, then dispensing and influencing. يعني we have to consider this closed loop when we implement pharmacy automation. Impact of pharmacy automation يعني to reduce errors. There is a lot of studies that show us reducing of errors, and by using some of technologies we can prevent a high percentage of errors. Some examples of some of these errors in the ordering stage, like the wrong dose or wrong drug or wrong route form. Also, if the patient has allergy or drug interaction. In the second stage, maybe it's the same, beside adding the time. In the third phase, the dispensing phase, يعني incorrect labeling, maybe يعني the main things in this stage. And in the administration stage, the frequency will influencing pump. And here's some examples. If you can see the table, if you use يعني some of technologies here, for example, in the first stage, the prescribing stage, if we use the computerized, if you use the CPOE, we will prevent 64% of the total errors. In the second phase, the pharmacy evaluation or preparation and dispensing phase, by using, for example, the barcode, we can prevent 80% of total errors. If we use the automated dispensing, we can reduce 38 of total errors. Moving to the administrating phase, if we use the barcode medication administration, we can, the study shows us, and it's a fact, it prevents 98% of total errors. التايب of pharmacy automation technologies صراحة it's too يعني we have many and a lot of technologies around the world, and alhamdulillah in Ministry of Health يعني some of hospital يعني implement some of these technologies, and they have يعني a successful story في جميع أنحاء المملكة صراحة، شمال جنوب غرب شرق، فالله يعطيهم العافية. يعني أنا by يعني doing يعني small research I يعني categorize التايبس إلى 3 types، اللي هو الفيرست one storage and dispensing, combining medication, and packaging and labeling. في storage and dispensing technologies يعني there is a lot of examples, but here is the main 2 examples: the automated dispensing cabinet, ADC, also the capsule storage solution. And I think it's implemented in the most of hospitals, especially the capsule storage solution. يعني جبت هنا ممكن الآلية اللي يتعامل فيها الستاف مع الماشين. For example, يعني different machine has different يعني way to work with. بس يعني في هذا المثال بسيط الفارماسيست or الستاف placed the medication في الكاونترز في الكانز sorry with the barcode and then going to the particular type of drug. Then a robot scan the barcode and place the cans into a storage unit with the machine barcode. After that, the system register each cans and keep track of expiration date. Then the medication يعني recalled by machine upon request. Every time is count photographed checked against the database. الصنف الثاني أو الكاتيجوري الثاني combining medication, and here is two examples of that. The TPN, the total penetration mixing machine, والrobotic IV admixture preparation. يعني هذه dealing with these machines, it's not hard to learn. It's so simple, as you see here, the medication prescription created by pharmacist, then go to the machine. After that, robots acquire ingredient and form الدوز بشكل عام ويعمل لها الوزن, then mix them in a sterile environment. والباكج يعني after that بيكون ready and giving to the patient. النوع الثالث اللي هو الباكجينج اند ليبلينج، وهذا انواع كثير ويعني بحر. فممكن السائد على مستوى العالم اللي هو الاوتوميتد اورال دوز بري باكجينج، سواء الليكويد او السوليد. طيب نيجي هنا للنقطة المهمة. اوكي بس يعني نطمنكم جميعا، هذه التكنولوجيز will not replace الجوبز. يعني في دراسة يعني أنا حاطة هنا ديلويت يقول automation created 3.6 million opportunities between 2001 and 2017، وستخلق إن شاء الله وظائف يعني 2.3 million by the end of 2022. فهنا استذكر مقولة للدكتور معالي الدكتور سعود المتحمي، سمعت له لقاء قبل أمس. هو مختص في الارتفيشال انتليجنس، من الأوائل في هذا المجال. يعني التقنية والارتفيشال انتليجنس والautomation will complete our job and participate with it. It can't replace it. يعني الله خلقنا بعقل مميز وبروح مميزة، مستحيل الأجهزة تكون يعني بديل لهذا الشيء. شكرا لكم، الله يعطيكم العافية. شكرا دكتور محمد والفريق القائمين على هذه الدعوة الكريمة، ونراكم بإذن الله على خير.
شكرا دكتور عبد الله. يعطيك العافية دكتور عبد الله. Thank you very much. Before we open the session for questions, since this is a debate session, I would like to debate with Dr. Abdullah and what he mentioned in his presentation just right now. Don't you believe that we reached to a point that there's no more additional automation that we could include to the pharmacy services? What do you say about that?
I think in the pharmaceutical practice we can use the technologies in some areas, not in all areas. We can't replace the pharmacist by machines in some process like the preparation, the contacting with patient. هذه الأشياء it's important to have it in person without machines.
Do you think right now with all of the solutions that you just showed us, do you think that we reached to the top, to the ceiling of it?
No. We are way behind, but we just started, and I think inshallah by the future we can do a lot of work, especially in Ministry of Health, by unified patient file and use the technology بإذن الله.
يعطيك العافية. Thank you. دكتور وزاع. تفضل وزاع. دكتور عبد الوزاع عندك كمان.
Yes. First, I would like to thank you, Dr. Abdullah, for what you mentioned. Actually, we are still, we need a lot of work to implement the basic automation solutions in our hospital settings. We didn't reach the point that we can say that we implemented the basic automation solutions in our hospitals to look for the optimum or the maximum amount of automation. And if there is more extra automation solutions that can be implemented in the future. So we're still in the beginning of implementing the basic automation solutions that should be available in most of the hospitals. But also we need to really understand the need, if we actually need those solutions. So I don't expect any small, medium hospitals to implement all the automation solutions available in King Faisal, for example, or any international hospitals. It doesn't make sense. It's only spending more money on things that you are actually don't need it. So with that said, we can never reach a point where we have the optimum amount of automation, but sometimes in certain hospitals, you can only need a little bit of automation. You don't need to have all the available automation solutions.
You have to understand what you need.
Yes.
First.
Yes, that's true. That's true. Dr. Azza, you mentioned just an initiative that we had done in our hospital, using artificial intelligence and giving predictive measures of prediction about number of prescriptions that we're going to be receiving next week, number of patients that we're going to be seeing next week in each pharmacy. With what Dr. Abdullah mentioned right now, that humans will not replace, or the automation will not replace humans, and I think that probably is something really signifies what you're trying to say. Without using artificial intelligence, we have to have people who are driving this information and giving it and feeding it the correct information, knowing what is needed for that. But again, going back again and circling back to you, Dr. Azza, do you think that this predictive analysis that has been done in your hospital, was it something that you gain benefit from?
There is multiple points that I need to address before reaching that question. Because of the flow of the information you mentioned, I really love the way that you presented this idea. Because even if we have predictive analytics, even if we have a prediction to what will happen, if we don't have qualified people who will create those prediction models, we will not be able to have appropriate prediction models. So even if, let's just say, for example, that we will reach a point that we will decrease the number of pharmacists who are doing technical work. That doesn't mean that we have pharmacists that will be jobless, but there will be created new job opportunities to work as pharmacy informaticians who will create those prediction models to help utilize the workflow better, in a better way that will make the need for technicians to work in the pharmacy is less. So repurposing the pharmacy workforce is actually what we really need and what will be impacted in the future when it comes to prediction models or automation solutions. And the last point is, did we get benefit? For sure we will be benefited. So in case of knowing that we will have 2,000 patients at a certain point in a specific pharmacy, we will know to have enough staff that can cover those kind of patients to serve them within the appropriate time that we set for the patients. So if I don't have those information, I might have been understaffed at that specific time, at that specific day for any reason. So if I knew before, I can allocate more staff from other pharmacies or other areas, and that will increase the patient, and will improve the patient experience after all.
I think Dr. Abdullah has
If may I add something? Don't be afraid. Machines will replace our job because we are the brain of those machines. So who program it, who control it, who maintain it. So
that's true.
Don't be worried.
Thank you very much, Dr. Abdullah. I will open the floor for any questions from our audience. Yes, تفضل دكتور.
Assalamu alaikum. I think the automation now is the era of in the Ministry of Health nowadays, and it is the strongest point for the automation machine to competitive. The company will competitive now to the Ministry of Health. This is the time, while the Dr. Muhammad with us now, we prefer to make a committee for make standards for the choice of the automation to the MOH hospital. Otherwise, if we are keep it for the for the hospitals or for the region, I think there is a lot of distribution will happen. There is no good standard for the choice what the automation machine can be chose to the hospital. So, a good point, a good home message to our decision maker to make a good committee to implement standard for the automation machine for our hospitals.
Thank you very much.
We have a good hospital there work at King Faisal, another hospital, Hopkins.
Yes, we do have another question from over there, please, from the lady over there, please.
السلام عليكم جميعا. أمر بالشكر medication safety تخصص جدة. يديكم ألف عافية. Excellent talk. I'm really happy that you guys shared such great examples that will set the ground for others to follow. First question, Dr. Abdullah. How, as a hospital pharmacy, can we overcome the challenge whenever automation is said to be a target to be implemented in a hospital, and then you come to the budget and you decide that you're not going to use that feature because it's not justified enough or impactful enough? How can we take it, the whole package, because it's implemented, we can see it in US practice, and I think if it's fair enough to say that maybe we are a decade behind compared to US practice, for example, in terms of automation and use of informatics, maybe, and applications. Dr. Hazar, again, excellent talk on. I'm happy that you shared the example with anti-robotics. As a stewardship, programs to be supported with informatics is definitely brought it or upgraded it to be utilized in much more efficient way, capturing more patients and screening them timely, and expanding the patients who need to be targeted. How can we use it more, considering the talk in the morning about artificial intelligence, capturing or assessing the risk for current patient on REMS medication, adverse reaction reporting is way underrated. How can we capture such information through the system? And then after it's been implemented, how can we monitor the impact on this, from the data from the system, if it's been impactful also enough on patient outcomes? Thank you.
يعطيك العافية دكتورة مروج. We only have probably 30 seconds, so please can we make it very direct to the point?
To make it short, as you saw, we didn't mention the challenges because we have to start. We have a lot of challenges, we have a lot of issues, but in the recent we have to start, then we will figure out how can we do.
Thank you, Dr. Abdullah. And I believe to answer your question about what to do next, as I mentioned in the hierarchy of data analytics, after starting to have a retrospective analytics and see the previous and see the current situation and to identify the patient that we need to capture them, the next step is to create prediction models so we can predict what will happen for those patients with that specific category of diseases and characteristics, what we expect or predict that will happen to them in the near future, so we will be able to prevent it or capitalize on it if it's a positive thing.
Thank you very much, Dr. Azza. Thank you very much, Dr. Abdullah. With this, I think we conclude this session for us. We thank you very much for joining us, and we appreciate all of the efforts from the organizing committee, scientific committee, and everybody from over here. So thank you very much. Inshallah, looking forward to meet you again, inshallah, very soon. Thank you.
Thanks, doctors, for this fruitful discussion. I would like to invite Dr. Afnan Al-Mirdi on the stage for the recognition. Yes. I will start. دكتور هزاع الغامدي. دكتور عبد الله آل الشيخ. دكتور معتصم الزامل. And now we'd like to invite Dr. Mahar Al-Salim to the stage to give the audiences present.
عندنا الآن الهدية الثانية اللي بيتم تقديمها لأحد الموجودين من الجمهور، وطبعا هي عبارة عن أن الكاميرا تختار شخص من الموجودين بشكل عشوائي، فالموضوع عند الكاميرا مان الآن. طبعا مبدئيا ألف مبروك للجميع، وألف مبروك للي فاز شخصيا. دكتور أفنان تتفضلين معنا تكرمينا.
Up next, the fourth and final topic for this session, entitled Supply Chain in Hospital Pharmacy. Our next moderator, Dr. Abu Bakr Umar, has a distinguished career as a Saudi Commission for Health Specialties, Clinical Sciences Examination Committee, a member for the Saudi Pharmacy Licensing Exam, National Command and Control Center, Ministry of Health Specialties in Physician Information, Senior Specialist, King Saud Medical City, Head of Scientist and Staff Development Unit, Deputy Manager of Clinical Pharmacy Services, Ambulatory Care Clinical Pharmacies. Ladies and gentlemen, please welcome Dr. Abu Bakr Umar.
Thank you very much, Dr. Rima Al-Graishi, for this nice introduction. Assalamu alaikum wa rahmatullahi wa barakatuh, everyone. I hope you guys accept our apologies for a few minutes. We're running behind the schedule. Today, inshallah, we're going to have an amazing talks, the same as we had this morning. We're going to focus this now on supply chain in hospital pharmacy, and we're going to start with the distinguished speakers. The first of which, Dr. Mohammed Batog. He's the Director of Logistic Operations for the Western region from NUBCO, Saudi Arabia. Dr. Batog has a PhD in Management Science and Management of Technology from the Department of Management Sciences from the University of Waterloo in Canada. His bachelor degree was in science, in electrical engineering and electronics and communications from King Abdulaziz University. I'm as much excited as you are to hear from Dr. Batok, so please welcome me in joining him to the stage.
طيب السلام عليكم ورحمة الله وبركاته. In this topic, inshallah, we will run very fast. We will try to run this presentation very fast so we can catch the time, inshallah. In very brief, we are going to talk about sustainability in healthcare supply chain. Yeah, Muhammad. I will go over many topics, but first we need to be on the same understanding and the same page of understanding what is sustainability, what is supply chain management, and how we can compose two concepts together in order to understand how we can achieve sustainability in supply chain, and in particular for healthcare sector. We are going to deep in three dimensions of sustainability, which is social and environment as well as economic, and then give some examples from Kingdom of Saudi Arabia as well as international examples, and end up with some future venues. I will try to go fast on this. So what is sustainability and why we need it? If we look to the Vision 2030 for Kingdom of Saudi Arabia, we will notice that it is one of the main pillars that we are going to focus on sustainability. And from that perspectives, as well as talking from United Nations perspectives and pushing all the country towards sustainability in order to sustain the resources around us, as well as lectures from a different academic lecture who always try to push toward sustainability in general without now focusing on the supply chain. That will give us many of the opportunity in order to achieve a positive environmental impact, as well as promote business and give a good reputation for the business itself, as well help the decision makers to prioritize their decisions in order to achieve sustainability. So what is sustainability? In very brief and short definition by the United Nations, it was defined as meeting of needs of the present without compromising the ability of future generation to meet their own needs. And then after that, this definition has been expanded to focus on the human needs, as well as try to specify that we don't want to harm the ecosystem around us. Then this definition has been expanded to be the balance between doing whatever we are doing right now without harming the environment and the society around us, as well achieving the economic goals. On the other hand, if we are looking for the supply chain management, and I'm sure that we have many experts here around us for the supply chain management and how we can achieve it, it focuses on all the activities from moving the raw material, the goods from the raw materials up to the production or the product itself, as well as moving of the information. If we look to academic definition for the supply chains, they are focusing on associate between more than one representee or more than one entity, where suppliers and end user could be of those, and it conditioned that supply chain will be managed well by focusing on the effective coordinating between the suppliers, as well as better performance associated with a good long-term agreement between the representative of who are in the supply chain. In order to identify that, we are focusing on three main activity for the supply, which is planning, outsourcing, which focus on the procurement, as well as inventory management, which include how we can save the environment, how we can save the items in a good environment, as well as distribute this item through the warehousing to the end destination. To understand sustainability in the supply chain, it is better to look to the literature, and by focusing on the literature, it is better to understand how a literature review has been done for some of the literature was shared through the effective scientific journal, where I select one of the reviewer, and it was focusing on many of the studies of around 56 articles that has been shared between 2010 and 2020, where out of this article it was very clear that there is increased interest in understanding supply chain sustainability, as well as it was focusing on the developed country more than the emerging country, where more empirical studies was done in the developed country, and it focused on what dimension of sustainability we can focus on and what dimension of sustainability we can study and improve. That lead us to focus more on the dimensions where there is economic dimension, environmental dimension, as well as social dimension, in addition to many other dimensions that focus on different stakeholders, focus on the performance itself for the organization, focus on the performance, how it will contribute to the general goods of the countries whose the operation is done within. On other hand, if we are look to the inventory, we notice that the inventory, when we are looking to the supply chain, we notice that it includes inventory management, waste management, and all different types of operation that is part of the supply chain management. We notice through the literature that many of these topics has been addressed and analyzed well, while others still need some more attention. That includes the cold chain management, human resource practices within the supply chain, risk management, as well as waste management, which is very important that overlap with the concept that we are talking about today. So, out of those literature, many framework has been evolved, and this frameworks for the supply chain sustainability has include or has focused on a circle, what they call it, circle supply chain sustainability, where the production will use the waste and report it again, post it again in the production, or closed loop supply chain, where the waste for the production is used for another manufacturing line or a product line, reverse supply chain, where we are using the waste back into a different industry, and the sustainable supply chain, where we are trying to develop practice within the current practice of the supply chain, which we are focusing on today. From that, we noticed that supply chain sustainability is not an easy task. It is a difficult task. It needs more focus. Supply chain is everywhere, almost in every single organization, there is some type of a supply chain. And in order to maintain some kind of sustainability, you will need to develop a different type of practice to achieve that. But we understand that in order to achieve achieve the sustainability, you need to meet the criteria without compromise or without losing the competitive for the process and procedure you are doing with your supply chain. So the question is why we need to go there, why we need to apply sustainability. We are doing supply chain and we are focusing on delivering whatever we want to deliver without focus on a different aspects that will help us. From a literature and from expert point of view, that this will add a lot of benefits to the organization on the long run, sometime on the short run. It help us develop our reputation for the organization. It help us meet many of the regulation by the governments, where I mentioned at the beginning that the government going to impose many of the regulation in order to meet with the international trend of having sustainability for all the process and the procedure. As well, it will increase the value and the share value for the shareholder. It will reduce cost and waste on the long run. It will help outsourcing with a good standard with a different company. All this will be achieved through having the supply chain. So this is why they said it will be a value creation instead of additional cost, where you need to meet all these aspects of environmental, social, economic. You will need to consider it while you are doing all your operation for the supply chain. That will lead somehow to cost reduction, process efficiency, asset utilization, inventory optimization, and service reliability. As well, you will pay more attention to the risk management, which will help you avoid many of the concerns that is highlighted by the sustainability for the environment. So saying that, we are reaching to the concept now, which we call it sustainability supply chain, which has a very complicated definition. If we read it directly, I had put it on the screen. If we read it directly, it will be noticed that it has been going everywhere. It has covered the dimension of environmental, social, as well as economic to be considered with applying it on the inter-organizational business system, as well try to be very effective and efficient in terms of managing the material, information, and capital. And here we are talking about material, information, and capital flows as a supply chain process. And that all will be associated with all the operation of procurement, production, distribution. At the end, you are try to achieve your stakeholder satisfaction somehow, and that include your shareholder, include the customer you are serving, include the staff you are trying to perform all this by their help. That all you are going to try, try to do that, and at the same time try to be a profitable organization in a competitive and with good resilience. So that definition gives us focus on the three dimensions: environment, economic, as well as social, and give us the sense that it needs to be balanced between, without focusing on one of these aspects and ignoring the other aspects. So you need to focus, for example, on the economic, considering all the concerns that are going to be around the environment, for example. And that will together will work to move us from a traditional supply chain to a sustainable supply chain, inshallah. This simple diagram helps us understand this. So if we are going to perform well in environmental aspects, as well as social aspects and economic aspects, normally organization is targeting the profit, and that will be reflected on the economic aspect. So if we are focusing on the intersection between the social performance and economic, as well as environmental and economic, which is normal, that will be better for us. However, if we are focusing on the intersection between the three aspects, that will be the best, and that will help us achieve the sustainability for the supply chain. So I will go over these three dimensions very fast in order to reflect on the examples. Environmental has been started in order to avoid the concerns that has been raised during the development era, in order to avoid all these concerns that will harm our environment. And that is the main idea here. In this perspectives, many advice has been raised in order to overcome these difficulties by focusing on reduce the consumption of the natural resources, by reduce the waste that we are producing, by having some kind of balance between giving the resource, using the resources where it can be regenerated, and as well as having the full capacity to deal with the waste that generate by the operation done here. All this to be considered as part of the environmental sustainability dimension. We can summarize it that it will help us in order to make all the regulation within the company or maybe upper level within a ministry or a government, as well as help us focus on dealing with all the issues that will impact or risk or harm our environment, and that is represented by the disposal or packaging or shipping. And we will see through the examples how this is work. Social sustainability, in very brief, it is caring about the human side of the equation. So it will take care of the human, how we are dealing with the human, and here human including every human that is interact either as a customer or as a staff or as a supplier or whoever is a human. And that is talking about fairness and equality as well. There are many dimensions under the social sustainability, but it has been defined that the highest priority was given to the repetition and media as well as organizational practice, which reflect on, again, the sustainability and how we can sustain our supply chain. In summary, that will help us manage the risk to organizational repetition, as well as create competitive advantage for the organization in order to maintain a good balance between the economic dimension as well as social dimension. The last dimension is economic sustainability dimension, and it is easy that if we are doing what we are doing right now, with only taking more care not to harm the environment. To maintain that economic sustainability, economic capital must be raised, and the expansion must not deplete the natural capital. So in summary, sustainability can be cost efficient, or sustainability can enhance shareholder value. So this is the dimension, this is the definition for sustainability and how it was applied. Now we are moving to the most important part, which will take short of this presentation, how this has been applied. Many companies has working from a different perspectives. I will use 2 international examples, very fast example, and 3 local examples. For example, Puma company has a focus on the packaging and how this packaging was contribute somehow to use resources that could be reduced and could reduce the waste. And they work on what they call it clever little bag. We can see it on the corner of the screen, that instead of the normal bag that we know, they create this normal bag, and they create the red bag, where they can reuse it very easily, and it is created from a material that is outage or a waste of other materials. By this, they, according to their website, they save 65% of the packaging that they were used. They contribute to the reduce the number of the shipment through the different fleets. They contribute somehow to the CO2 emission reduction. Same happened with the Walmart, where they implement what they call it the 7 R's: remove, reduce, reuse, renew, recycle, renew, read. And they reflect so many metrics that measure how that contribute by reducing only the packaging or focusing on the packaging, and how that contribute to the saving of our environment in a way or another. Looking to the examples from Saudi Arabia, of course, SABIC is one of the leading companies in Saudi Arabia, and I just captured this out of their website. They have a very detailed report, consists of 79 plus pages, which include the most important aspects about sustainability and how they are dealing with that, how they are contributing to the sustainability, even though that we know somehow the production of the petrochemical manufacture is harming in a way or another. So they are doing very well in terms of identify all these important aspects and how they are dealing with it. They put it in some kind of a process within the company. They put goals for, they started by 2008, and they put some goals for 2025, and they achieved many of these goals, and they reflected on the report that they share on their website. This is some of the numbers that they are reflecting, how they are contribute to reduce the emission, how they build the different chip to chip their product where it can carry more with a less emission of CO2, as well as how SABIC has achieved many of the excellence in their industry by applying many of these. So that is reflecting on the repetition for the company itself. Same thing here if we are looking at a different example from a different industry, Al-Mara'i, as well a very good report of 124 page, which reflect how they are managing sustainability, how they are taking care of their employee, environmental impacts caused by their operation, as well how they use innovation in terms of developing their production or products. And they reflect many of the aspects in very details and in very clear number, how they contribute by focus on the innovation, how they contribute by studying the change of the environment or the climate, and how they are managing the waste. It is easy to access their website to read this report. And they reflected on a very detail how they are moving during the year from one number to another number, which reflect very discipline by this company in order to achieve this sustainability. Last example is, of course, NIPCO, how NIPCO is trying to deliver their products and run the healthcare supply chain by focusing on these three services, and by focusing on that, how they are tried through the unified procurement and development of the supplier relation management in order to focus on the supplier certificates, how the supplier will meet the condition for the environment, how the supplier will focus on the sustainability, as well as how we are focusing on the local content to serve the purpose of the vision by focusing on a company that will be committed to the sustainability conditions, offering different channels to make it easy process, to reduce the cost, to reduce the way how the products can be found and collected. WASFAT is one of the examples how we reduce the move of the products to be in a different stages in order to reach to the end user very easily. And the most important is the reports and the information that we share. In terms of logistics itself, NIPCO developed many of their warehouses considering all the environmental aspects based on the best practices, implementing a temperature monitoring system which will help having the products in the very right environment, as well as different using images, electrical images in order to handle all the items within the warehouse and avoid any emission within the warehouse, different warehouse management system, as well as using cages instead of using more packaging in order to deliver the products. Different focus was with overlap with Rust from Saudi FDA, as well as using NIPCO Sharik, where it tried to minimize the waste by sharing the extra items that is available in a different government agency in order to avoid or to reduce the waste of the medical items. For the fleet, they use a very brand new fleets, try to use a GPS in order to reduce the distance that they move from one point to another, as well as measuring the temperature. To conclude with this, what is the future for the supply chain? We are going to have many shared best practices through the literature, so we need to focus on this. I was happy hearing today about artificial intelligence. As well, we will hear more and more about blockchain, and that will help us in order to move our supply chain to be more sustainable, focusing more on KPI and measurement for the sustainability, as well as considering the stakeholder perspectives. Two more slides has been given in order to draw the roadmap in order to achieve the sustainability. And I think it is very clear these steps in order to define what kind of pain you have up to the moment to reach to a sustainable supply chain. So to conclude, we know now about supply chain. I know that most of the audience here, if it is not all of you are pharmacists, so how we can contribute somehow from pharmacist point of view in these efforts in order to have our sustainable supply chain. Thank you.
Thank you very much, Dr. Muhammad. This is indeed a very worth listening to and a very important issue that we're facing on our everyday practice in the hospitals, community pharmacies, and everywhere. It indeed needs much more time than allocated, but unfortunately, we still have other distinguished speakers to hear from. So now, please, everyone, join me to welcome Dr. Fahad Al-Malafiq. He's from King Faisal Specialist Hospital and Research Center, Supply Chain Management Group in Riyadh, Saudi Arabia. He has a Master of Business Administration from California State University, and where he presented his master thesis in logistics and supply chain industry in Saudi Arabia. So please, everyone, join me in welcoming Dr. Fahad Al-Malafiq. The other side of the debate will be delivered by Dr. Naif Al-Jasham, who is the advisor of the ministry's auxiliary agency for medical logistics and supplies. He is also a member of the executive board of the Health Council of the Gulf Cooperation Council countries. So everyone, please join me in welcoming Dr. Naif Al-Jasham.
السلام عليكم. حبيت أتأكد بس إن الميكروفون شغال. هنا. جرب الآن. السلام عليكم. مساكم الله بالخير. We will try to make it يعني زي ما يقولون quick, especially it's lunch time now. ثم من الصباح ما شاء الله يعني قاعدين يتابعون كل السبيكرز اللي هنا. طبعا اليوم أنا والدكتور نايف قلنا بنخلي الدسكشن يعني smooth وخفيف. We will talk about the supply chain management implications, transformation implications. ايش اللي حصل في الفترة الماضية من بعد الترانسفورميشن والفيجن اللي حصلت في البلد؟ ايش التحولات اللي حصلت؟ ايش الاثار حقتها نفسها من اثار ايجابيه او سلبيه نتعلم منها يعني. فكان في different discussion. اذا نفتح بس نقاط الدسكشن بعد اذنكم. الاخوان اللي معاهم الباوربوينت. بشكل عام يعني الاكسبوجر اللي حصل على موضوع ترانسفورميشنز ابلكيشنز في البلد وفي الهيلث كير خاصه تعلمنا منه الكثير يعني. اللي بعدها هي واحده بس فيها اللي بعدها بعد منك هي واحده منها. فانا اذا تسمح لي دكتور نايف انا ببدا معك. واحنا وي وير ديسكسينج الجلوبال انتجريشن. نتكلم عن جلوبال وانتجريشنز واشياء كثيره. الدسكشن هنا نتكلم على الانتجريشن، مو هو موضوع سيستم انتجريشن قد ما هو موضوع بروسيس انتجريشن جلوبالي. الان حاليا اذا بننظر للسبلاي تشين اكتيفيتيز، بننظر للسبلاي تشين اكتيفيتيز اند تو اند سبلاي تشين. وي كان نوت زي ما يقولون اجنور كل الاكتيفيتيز اللي تصير في السبلاي تشين، خصوصا عندكم انتم الفارماسيست والميديكيشنز الخاصه فيكم. مهم جدا ننظر لكل الاكتيفيتيز الخاصه فيها from زي ما يقولون A to Z until the consumer level، وكلها هذه مربوطة ب different levels و ب different processes و ب different rules و ب different حتى financials اللي احنا داخلين عليها، و different logistics و different countries، ما هي one country يعني. فلما ننظر للبرودكت جيرني نفسها، لايف جيرني كلها، حتلاقوها it doesn't just stick to one country or one player. فالجلوبال انتجريشن was يعني الانكريز بشكل كبير في الفتره الماضيه فيما يخص ترانسفورميشن للسبلاي تشين اكتيفيتيز، والناس بدأوا يكونون اوير نفسهم اللي هم الفرونت لاينرز بدأوا يكونون اوير في هالاكتيفيتيز to at least address their issues و make the proper decisions when they want to make the proper decisions. I'll leave the floor for you في النقطة هذه دكتور نايف.
أتوقع اليوم بالجلوبال انتجريشن بيكون في زيادة في التريتنج، زيادة في معرفة التريد اجريمنت، الانفراستراكشر product to achieve the يعني الدروب في البرايس، الانكريز في الافيلابيلتي. اليوم نحتاج نكون مالتيبل اند ادفيرس في السورس. بهالطريقه هذه ان شاء الله تكون اوضح الامور.
طيب النقطة الثانية دكتور نايف اللي هي لما تكلمنا سابقا، يمكن كان في نقاش بيني وبين الدكتور نايف وبعض الأخوان على أنه ترانسفورميشن علمتنا أن نكون أجايل. الفريكوينت تشينجز اللي قاعدة تصير والديفرنت ريكوايرمنتس والتشينج كمان ان ديماند. أنا كنت أتكلم أنا والدكتور شناوي عن الميديكيشن شورتجز الحاصلة الآن حاليا، وكنت أتكلم على موضوع كمان بعض السبلايرز اللي نتعامل معهم والفندرز اللي في البلد. I don't think they were agile enough to deal with الديماند اللي صاير في البلد. الاجيلتي مهمة جدا بالنسبة لنا احنا to adapt to whatever changes is happening at the moment. واعتقد تعلمنا كثير previously من البندمك اللي حصل how to be agile و how to address الاكتيفيتيز اللي موجودة. فin order to transform and to be one of the biggest big player worldwide, agility is an important factor بالنسبة لك. You need to be able to adapt, to change, to downsize, to play bigger roles. This is the agility. So I believe agility is one of the implications that happens, that comes out after the transformation. دكتور
دكتور يعني نركز في الاجيلتي اليوم على البيبل، تغيير الكونسبت والمفاهيم اللي جالس نتحول معها. نرجع اليوم يمكن 4 ستيج، اذا نجحنا فيها باذن الله حننجح في الترانسفورميشن اللي هي الدينايل ستيج، ريزيستنت ستيج، الاكسبلوريشن ستيج والكوميتمنت ستيج. اذا نجحنا فيها المراحل هذه اتوقع ان شاء الله بنكون في مرحله ايجابيه في موضوع الترانسفورميشن.
طيب يعطيك العافيه دكتور نايف. هي نقطة مهمة جدا احنا قاعدين نتكلم عنها، how reliable we are, how reliable we are, how reliable we are. Transformation since 2017 والinitiatives والvision 2030 exposed a lot of activities, exposed a lot of issues within the country نفسها to work on. One of them is the reliability. يعني different players في الماركت، different players في الجيم نفسها اللي احنا قاعدين نعمل فيها في السبلاي تشين ترانسفورميشن. we could tell who's really reliable ولا اللي عنده الضعف، وهذا مهم. مو عيب انك تكتشف انه فيه low reliability في اريا معينه but at least you know what's going on to tackle. فالreliability كانت very important aspects بالنسبة للtransformation implications. If you are not reliable enough, then how would you just succeed? والبلايرز والانتجريشن اللي تكلمنا عنها مهم جدا ان نكون كل بلاير is reliable enough في اللعبه نفسها او في الماركت نفسه زي ما نتكلم فيه. فالريلايبيليتي كانت واحده من الاسبكتس ودكتور نايف كان برضه كان عنده نقاش في الريلايبيليتي وحب الموضوع هذا.
اتوقع اليوم بالريابيليتي اهم شيء يكون في الاكيورنسي والاتشيفمنت. اذا نجحنا فيها اتوقع ننطلق في بالشكل الصحيح في موضوع التحول. يمكن اليوم بننتقل للنقطة الثانية هي السبيشاليتي. اليوم لازم الفوكس يكون جدا عالي على تخصصات السبلاي تشين. يمكن اليوم نحتاج نطور التخصص بشكل يتلائم مع المرحلة القادمة بإذن الله.
طبعا هو الوحيد اللي جالس هنا مو فارماسيست أنا.
لا
هذا انت برضه محمد مو فارماسيست؟ طيب احنا اثنين الان. هذا بس يوضح انه السبيشاليتي حقت السبلاي تشين it becomes more important واعتقد راح يكون في ميكس جديد في المستقبل ما بين الكلينيشن سايد والبزنس سايد نفسه. راح يعمل في البزنس سايد نفسه بشكل كبير. الفارماسيست الان ما شاء الله عندنا في التيم حقنا تيم كبير فارماسيست trying to specialize في السبلاي تشين اكتيفيتيز وما شاء الله عليهم ممتازين. اعتقد الاذر كلينيشنز من ناحيه اللايد هيلث من الار تيز من النيرسينج المعلومه اللي عندهم كلينيشال وايز لما تخلط وتكون تقوى بالسبلاي تشين سبيشاليتي نفسها راح تخرج منتج جديد للهيلث كير سبلاي تشين. واعتقد هذا في احتياج كبير له. في الاول كان كل واحد يعمل لوحده وكل واحد يتكلم لغته ما فيه تواصل كبير فكان فيه lots of waste زي ما يقولون. تتكلم صيني وانت تتكلم انجليزي وما بيننا لغه مشتركه راح تسبب مشاكل، راح تسبب تاخيرات، راح تسبب اشياء كثيره. اعتقد تطور الموضوع بعد ترانسفورميشن الى الافضل. الان فيه في الفيلد عندنا ما شاء الله الاخوان من الفارماسيست وخلافه انفولفد معانا في سبلاي تشين سبيشاليتي قاعده تكبر بشكل كبير في الماركت السعودي الان حاليا وفي عليه نيد. يعني ما شاء الله معنا الاخ محمد من نبكو خلوا الاخوان حقينا بالسبلاي تشين خلوهم في حالهم. يعني فهذا يدل على انهم قاعد فيه طلب كبير على السبيشاليتي هذه واعتقد الفيوتشر نفسه موجود. ودي برضو انكارج يو الفارماسيست تدرسوا سبلاي تشين حتشوفوا الفيلد كيف ماشي حتفهموا اكثر حتعرفوا مدى تاثيركم من ناحيه الساينتفك واي مع البزنس نفسها لما تخلطوها مع بعضها. طبعا في نقطه الريسبونسفنس nowadays is not like before. الانفورميشن الحين في تو انفورميشن لما تو موضوعين احنا لما نتكلم على الانفورميشن فلو والماتيريالز فلو في السبلاي تشين فيلد. الان الانفورميشن مطلوبه منك يسترداي مو هو زي اول كان على اساس تجمع الداتا وتحط الداتا وترتب الداتا وتنتربت takes you 1 week 2 weeks sometimes on month وما في احد على راسك قاعد يقول لك what's going on let's do something. Nowadays no information لما تطلب منك you have to be ready. responsiveness صارت عاليه جدا. التاثير هالانفورميشن واتخاذ القرار صار سريع جدا موجود جدا. فالريسبونسفنس انكريز بشكل عام. طبعا من الجهه الاخرى بشكل طردي كمان يتعامل معها الماتيريالز فلو مع بعض ما هو بنفس التسارع زي ما نقول عليه ولكن من بعض الايشوز اللي يواجهها الماتيريالز فلو حاليا في السبلاي تشين ماركت.
بخصوص السبلاي افيلابيلتي اليوم يمكن عقد الشراكات الاستراتيجية وإنشاء شركاء مثال شركة نبكو هي لزيادة توفر تنوع المصادر، منصات متعددة لإدارة المخزون وتلبية الاحتياج بالوقت والشكل المناسب. يمكن الدكتور محمد وضح كثير من الأمور هذه، ونتأمل إن شاء الله خلق تنافسية في المستقبل القريب إن شاء الله.
ما زلنا في الطريق، الافيلابيلتي ستيل فيها ايشيو، ما زلنا في الطريق، مع انه الفورمولاري عندنا كبر، صار اكبر، في بدائل، في اشياء كثيره. however فيه availability issues، ما زلنا في الطريق لان نكون افضل في المجال هذا.
مجهزين لك عليها السؤال هذه الافيلابيلتي، لكن
طيب هي تو سبجكت عشان ننهي الموضوع. في اكسبانشن كبير لليوز اوف جي بي اوز الان، الجروب بيرشيسنج اورجانيزيشن لايك نبكو، واعتقد ما راح تكون اونلي نبكو ذا اونلي بلاير. اذا تسمح لي محمد، اعتقد في اذر بلايرز از جوينج تو بلاي ان ذا ماركت. الجي بي اوز is not only for the governmental institutions, it's also for the other institutions. طبعا راح يكون في تغيير في الماب هنا فيما يخص طريقه التعامل في السبلاي تشين، هل تراديشنال سبلاي تشين ولا نون تراديشنال سبلاي تشين، وهل جي بي اوز وش راح يكون دورهم. اللوكال كونتنت واللوكاليزيشن از انذر اسبكت، واعتقد الموفمنتس الكنتري ولله الحمد حطت ستبس جباره للموضوع هذا، وفيها لسه سم ايشوز بس شغالين عليها على ديفرنت ليفل، واعتقد راح تكون واحده من البيلرز اللي المهمه جدا في الرؤيه 2030 الخاصه برضو من ضمنها كانت اللي هي سبلاي تشين انيشيتيف في رؤيه الام بي اس 2030. كذا خلصنا.
الله يعطيكم العافيه جميعا.
تفضل الدكتور اذا تبغى تسالي سؤال عشان الناس تروح تتغدى بس، لانه
طيب
سكناهم على الغداء.
احنا ثانك يو فيري ماتش. والله صراحه انا اتقدم نيابه عن نفسي واعضاء اللجنه العليا واللجنه العلميه والحضور جميعا بشكركم جدا. انا ارى صراحه اوفرلاب عالي جدا ما بين الكونتنت اللي طرحه الدكتور محمد واللي تناقشتوا فيه، مشكورين. مثلا الجلوبال انتجريشن والريلايبيليتي والريسبونسفنس او السبلاي افيلابيلتي، هذه يعني في اوفرلاب عالي جدا من بين الموفمنت تورد الترانسفورميشن. لعلي اطرح يعني كم نقطه من الاشياء اللي ذكرتوها جميعا. يعني اول شيء عندي سؤال جينيريك، اين احنا متجهون مع الترانسفورميشن اللي قاعد يصير الان واللي نعيشها الان واللي احنا مقبلين عليه شئنا ما بينا. ممتاز. في موضوع الصحه والموفينج تورد الفيجن 2030. النقاط هذه رائعه جدا، ولكن الريلايبيليتي والريسبونسفنس انا اعتقد ان يعني المفترض انها تشمل الاند يوزر والممارسين الصحيين واللي لهم علاقه في التوفر الدوائي والسستينابيلتي والسبلاي تشين بالعموم. نرى يعني بعض الاحيان استياء مثلا من المرضى انه هذا الدواء ما هو موجود، وهذا يرجع برضو على السبلاي تشين، واحنا نتكلم كلنا تحت غطاء او مظله السبلاي تشين. نرى مرات ان بعض البروفايدرز، وهذه قد تكون شوي فيها اوفرلاب مع السيشن اللي ما قبلها مع الدكتور ابراهيم الجفالي، انه والله في بعض الادويه انا ما اقدر اسوي لها بريسكرايب كهيلث كير بروفايدر، يا اما لانه فيه ريستريكشنز من الانشورنس وهذا شيء ثاني. لكن نحن نتكلم هنا تحت غطاء السبلاي تشين. اين احنا مقبلون من ناحيه reliability of maintaining and sustaining drug delivery او medication delivery او حتى medical supplies، لان هذه كلها تدخل تحت النطاق. والresponsiveness، لان نرى يعني على ارض الواقع في بعض الاحيان الاستياء والرضا يجي على ويفز، فتلقى المريض اذا حصل دواء رضا وقال جزاكم الله خير على ذا البرنامج لاني لقيته جنب بيتي، الوصفتي مثلا لقيتها جنب بيتي جزاكم الله خير، ما عاد تعنيت لين الشميسي وانا ساكن في شمال الرياض ولا انا برا الرياض. واذا ما لقاه جاء ودعا علينا قال انتم اللي تسببتوا. Where are we moving في الترانسفورميشن هذه؟ Are we containing كل هذه الاسبكتس؟ هل عندنا measurable outcomes to measure هذه الاشياء اللي موجوده على ارض الواقع؟ يعني هذا السؤال اللي قلت لكم زي اول جينيريك قد يكون مفتوح لكم انتم الثلاثه، يعني لانه في اوفرلاب عالي بين الاطروحه. نبدا مثلا بالدكتور محمد.
طيب هذا طيب يعطيك العافيه دكتور. السؤال طبعا عريض. منظومة السبلاي تشين ان جنرال ما هي عمل منظمة واحدة دون أخرى، هي عمل عدة منظمات بتنسيق كبير بينهم للوصول ل خلينا نقول مخرج مرضي. وهنا عندنا مثلا يعني إذا أخذنا في السبلاي تشين للهيلث كير نتكلم في جزئية الميديكيشن، المريض هنا ما يعرف ايش التفاصيل اللي قبلها، لكن هي عبارة عن كمية عمل بمعلومات معينة، بريدكشن مسبق، ريكوايرمنت، بسكوب اوف ورك لهوسبيتالز. كل هذه تترجم في الاخير انه يكون في دواء موجود في صيدليه تعطى للمريض، سواء كانت صيدليه مستشفى او صيدليه مجتمعيه خارجيه. الانتجريشن زي ما ذكر هنا اخوي فهد، الانتجريشن بين الديفرنت انتيتيز ما هو بسيط. الترانسفورميشن يعني نحن اذا قلنا اول قبل الترانسفورميشن نحن كان ما هو بسيط، الان مع الترانسفورميشن وانت قاعد تتغير بشكل سريع، قاعد تتواكب مع معطيات جديده، مع مدخلات جديده من الانترناشونال ستاندردز، مع التحول باتجاه تحقيق رؤيه بطريقه معينه. هذه كلها يعني different factors impact العمليه نفسها، عمليه انتقال او وصول الايتم الى الاند يوزر خلينا نسميه، سواء كان ممارس طبي او كان المريض. فالعمليه هي عباره عن انتجريشن، لكن يمكن افضل جواب للموضوع هذا we are on the way ان شاء الله. المؤشرات كلها تقول انه we are doing better in some aspects, we are still behind in some other aspects. المؤتمرات بنفس الطريقه هذه، العمل اللي قاعد يصير، التنسيق الكبير اللي قاعد يصير بين الجهات كلها قاعد تسوي هايلايت على الاسبكتس اللي نحن لاك بيهايند، وقاعد تسوي هايلايت على الاسبكت اللي الحمد لله يعني سوينا فيها، وهذا مطلوب مننا انه نحن نكمل ما بعدها.
يعطيكم العافيه جميعا.
انا اعتقد اذا تسمح لي هنا، ترى الشورتج موجود من زمان، مو هو الان موجود. اللي فرق الان انه الان صرنا مور ترانسبيرنت. الناس صارت تعرف المعلومه، ايش اللي حاصل، وش اللي مو حاصل، وش اللي ناقص، وش اللي مو ناقص. مو هو مثل ما اول، يعني حتى الفيدباك صار اعلى الان صرنا نسال فيدباك للبيشنتس. اول ما كنا نسال از ماتش از ناو يعني. فالفرق اللي حاصل الان انه المعلومه صارت مور ترانسبيرنت. الشورتج موجود من اول، احنا في وضع افضل، نقدر نقول احنا وضعنا افضل الان انه اتليست ترانسبيرنسي از ذير. الديسربشنز دائما ترانسفورميشن كمز وذ ديسربشن. فالديسربشنز هذه هي بعض نتائج الديسربشنز، لكن انا كان سي ان شاء الله الفيوتشر افضل. moving to non-traditional supply chain I think this is the future. وانت ذكرت مساله انكم احنا وانتم البيشنت، اعتقد without ان نعمل مع بعض we cannot do nothing. So هذا شيء اكيد، we have to plan with each other. I think the only problem واعتقد الاخوان في الاوتوميشنز والانفورماتكس اللي نحتاج نعملها اللي هو الربط ما بين الكلينيكال داتا والسبلايز داتا. Once we reach this اعتقد راح يكون فيه we will close a lot of gaps. We will be much better than right now.
اتوقع اضافه لكلام الدكتور فهد اليوم، يمكن الشورتج فعلا ما هو وليد اليوم، ولكن لو ناخذ التجربه الماضيه وكانت تجربه حقيقيه اللي هي كورونا، يمكن المملكه كانت من الدول القلائل بالعالم اللي تاثرت في المخزون. الشورتج ولا احد يقدر ينكر اليوم موجود. يمكن التغيرات اللي صارت ما بعد الجائحه حتى في مصانع الادويه اثرت على المنظومه، ولكن ان شاء الله بتضافر الجهود والشراكات اللي تمت مؤخرا نوصل للهدف المنشود باذن الله بزياده التوفر.
باذن الله. يعطيكم العافيه جميعا. For the sake of time عندنا مجال لسؤال واحد من الجمهور، اذا عندكم اي سؤال. يا اي احد عنده سؤال؟ نختم. طيب دكتور محمد، ترى انا عندي كل المايكس، عندي 3 مايكات. ما راح يجيب لك.
شكرا لتواجدكم وشكرا للمعلومات القيمة اللي احنا أخذناها منكم. أنا عندي بس أسئلة سريعة جدا على موضوع السبلايز. في كثير من الأحيان تلقى السبلاي تشين يقولوا للصيدلية أنتوا لازم تخزنوا أدوية بكميات كبيرة تكون موجودة داخل الصيدلية. من الطرف الآخر حنا نقول للصيدلية لا يا جماعة الخير، أنتم كلينيكال اريا مو المفروض أنه أنتم تخزنوا كميات أكثر من أسبوع داخل الصيدلية. في عملية السبلايز بيكون في تأخر في توصيل الأدوية إلى الصيدليات في بعض المناطق في بعض المستشفيات، مما يضطر مدراء الصيدليات أنه يخزن كميات كبيرة. إيش نصيحتكم في هذا الموضوع؟ عملية السبلايز ليش بيكون فيها أو السبلاي تشين إيصال الأدوية إلى الصيدلية بيكون متأخر؟ هذا السؤال الأول. السؤال الثاني، كثيرين جدا من يقوموا على السبلاي تشين أو الميديكال سبلايز عموما في جميع القطاعات الصحية هم صيادل، ولكن إلى الآن صححوني يعني أنا يعني قديم، ولكن إلى الآن ما أشوف أي جامعة من الجامعات اللي عندنا سوت برامج لتثقيف أو لتوعية الصيادلة هذولي إن عندكم برانش كامل من العمل اللي هو السبلاي تشين مانجمنت أو الميديكال سبلايز. هل تنصحوا الجامعات ومن ممكن يقدم؟ هل هي كليات الصيدلة أم كليات أخرى هي اللي تكون موجودة؟ إلى الآن في المملكة يعني ما أشوف أحد مثلا متخصص يعمل في مستشفى مخصوص في السبلاي تشين أو سلاسل الأدوية أو سلاسل خصوصا الأدوية مع شهادات من داخل المملكة، أو عندنا انستتيوشنز داخل المملكة بتقدم هذه الشهادات للناس. هل تنصحوا بهذا الموضوع أم نبقى على الخبرات اللي بياخذها زملائنا اللي لا يتعلموها على يعني من الجامعات الأكاديمية حقته؟ شكرا جزيلا.
طيب إذا تسمح لي في النقطة الأولى دكتور محمد، النقطة الأولى أنا ما أؤيد إنه الفارماسي تخزن أبدا نهائيا، هذا في خطأ. إذا سبلاي تشين بيرسون سيء للفارماسي إنه خزنوا كميات كبيرة في الفارماسي، معناته he's not doing his job. هذا مهم جدا. إنه لا أسبوع أنا معك أجري، أسبوع يكون موجود عنده في المخزن الخاص فيه، لأنه هذا الماكسيمم المفروض اللي الفارماسي ستور يكون عنده الايتمز خاصة فيه. لكن ليش المشكلة في تأخير التوصيل؟ أنا ما أقدر أتكلم على وزارة الصحة بشكل عام، ولكن إذا بتكلم يعني من ناحية كونسبتس وايز وليش تتأخر من ناحية الدراسات، الاعتماد على السنترال وير هاوسز في التوصيل مباشرة إلى ستورز هذه is not the right solution، خصوصا الجيوغرافيك لوكيشنز اللي موجودة عندنا في البلد. فمن الحلول اللي المفروض ننظر لها الآن اللي هو إقامة ترانزيشنال وير هاوسز اللي يسمونه ترانزيشنالز، اللي ممكن تكون في مناطق معينة. السنترال يكون الأساس في الكميات الكبيرة، ولكن الترانزيشنال وير هاوسز الكميات اللي هي من شهر وأقل، فتكون الموضوع عنده يكون أقرب للفارماسيز اللي هو الدليفريز الخاصة فيهم. فمن ضمن الحلول اللي هو اللي جاب عليه اللي هو ترانزيشنال وير هاوسز. if الإخوان في نبكو think about it, I think it's going to solve the problem في موضوع الدليفريز والتايم والليد تايمز. النقطة الثانية دكتور فيما يخص الاديوكيشن، أنا معك توتالي أجري معك. أنا متخصص سبلاي تشين، باتشلر وماستر من برا مو من هنا، من كاليفورنيا ستيت. ولما جيت كنت قاعد أدور، كان من ضمن مهامي العملية إنه كيف نبني جيل جديد من السبلاي تشين educational wise، مو بس باي براكتس. وعملنا على different initiatives. وفي جامعة في السعودية موجود فيها باتشلر وماستر ديجري الآن اللي هي في السبلاي تشين في جدة، طبعا مو في الرياض، في جدة اللي هي University of Business and Technology. عملنا مع الإخوان هناك، أنا was the advisory board member معاهم، وطلعنا بمخرج الماستر برضو ديجري في الاوبريشنز والسبلاي تشين مانجمنت. Should we do it here? Yes, we should do it. At least if the pharmacist wants to do it in the pharmacy, we need to build a module. The educational modules في الفارماسي نفسها ونحطه optional elective. هذه من فاذا في اخوان من الجامعات اللي هي في كينج سعود او ذا، انه وي كان ديفلوب وذ ذم الكوريكولم نفسها الخاص فيها. We can put it just as an elective course في للفارماسيست، للكلينيشنز، whoever in the على فكرة يعني أغلب الدكاترة الآن اللي يبغوا يدخلون في الإدارة في المستشفيات ويأخذون MBAs، واحد من أكبر الماجلز عندهم اللي هو السبلاي تشين. أنا أقول الكلام هذا لأني أنا أدرسهم أعطيهم توترينج. فواحد من أكبر الماجلز اللي عندهم اللي يأخذونها طبعا كلها executive MBAs خارج البلد، فأكبر ماجل عندهم اللي هو السبلاي تشين. بس your spend is there, your issues is there, your services, you know, it doesn't happen without that. Understanding it, knowing it very well is going to help you excel في العمل حقك. أنا أؤيدك وأتمنى الانشيتيف تطلع منك دكتور محمد. أنا راح أعمل معكم في موضوع الكريكولم، إنه أتليست لو نحط في الفارماسي في وات ايفر education في وديجريز في الجامعات السعودية، لو نبدأ من جامعة الملك سعود نجهز الموديل هذا ويكون إلكتيف للستودنتس
باذن الله. لعلها تكون ثمره IHOP السنه هذه ان شاء الله.
باذن الله.
يعطيكم العافيه جميعا. احنا
بس تسمح لي بس اضافه هنا على الكلام اللي قاله اخوي فهد والتعليق على الكومنتس اللي ذكرها الدكتور. يمكن واضح نحن من خلال التعامل المباشر مع المستشفيات كان عندنا وضوح جدا في التعامل بين المودلز المختلفه للمستشفيات في طريقه البناء، في طريقه توفير المستودعات يمكن اللي ذكرها اخوي فهد هنا. فكان هذا انعكست على البراكتس اللي موجود في الصيدليات، ما يكون البراكتس في كل الصيدليات بنفس الطريقه. اتكلم بالذات على في وزاره الصحه، في وزاره الصحه في المستشفيات اللي فيها مستودعات تستوعب انه ياخذ ستوك لمده شهر او شهرين، يخليه في المستودع الرئيسي في المستشفى، ثم يصل للتخزين في الفارماسي نفسها لاسبوع او اسبوعين. يس they can do. لكن الاساس او خلينا نقول هذه هي الفكره الاساسيه، بالاضافه الى الدليفري المباشر من السنترال وير هاوس للمنطقه كامله. unfortunately في بعض المستشفيات they didn't have enough space في نفس الوير هاوس المركزي حق المستشفى، فبالتالي هو قاعد يستخدم الفارماسي as a warehouse somehow. هذه يمكن النقطة الأولى. النقطة الثانية فيما يخص الإديوكيشن، التوتال أجري مع الكلام اللي قلته الدكتور ومع الكلام اللي وضحه أخوي فهد، لكن برضو في مسار آخر اللي هو خلينا نسميها البروفيشنال سيرتيفيكيشن في اكريديشن من فيري جلوبال اورجانيزيشنز. يمكن عندنا مسارين في السبلاي تشين. كل الناس يعني سواء الفارماسيست او غير الفارماسيست they can apply for this و they can proceed و they will be certified supply chain.
يعطيك العافيه دكتور، معلومه قيمه جدا صراحه لاغلب الحضور اللي هنا اللي انترستد في هذا الموضوع. طيب يعطيكم العافية. This is the end. So I'm going to ask الدكتور راشد الغانم مدير إدارة الصيدلة التطبيقية بالإدارة الرعاية الصيدلانية بوزارة الصحة for the appreciation. تفضل.
أهلا تفضل. دكتور محمد باطوق. لا. دكتور فهد الملافخ. دكتور نايف الجشعم. دكتور أبو بكر عمر.
So now we're going to have a short talk with Dr. Majid Jaweed, who's used to be a pharmacist at Royal Commission Medical Center at Yamba, and as he has actually served as well as the inpatient supervisor, pharmacy automation and informatics supervisor at Security Forces Hospital in Mecca. He established the pharmacy automation and informatics services in Security Forces also in Mecca. So please everyone join me to welcome Dr. Majid Jaweed.
السلام عليكم جميعا. First of all, my name is Majid. I work as a pharmacist, inpatient supervisor, and automation and informatics supervisor in Security Forces Hospital, Mecca. My whole experience as automation informatics supervisor. Today I will talk about the role of pharmacy automation informatics. Pointer. This one. I will talk about the role of pharmacy automation informatics in the hospital with our case report, real case report we implemented for automated dispensing cabinet. This is our objective today. Can you scan this code if you can? There is one small question. I need your response after the presentation. Then I will show the code again so that you can scan it again. So now, as you all speakers talked before, with advancement in the technology, pharmacy practice always change. And even there is a need for pharmacy automation informatics in the hospital, okay? Those are pharmacists with the basic knowledge of the pharmacy, and they should work in all areas of the pharmacy, inpatient, outpatient, ER, OPD, clinical, and they have clinical IT skills, data analytics, data transformation, database management. Those are pharmacy automation informatics team. I will not talk in detail. The advantage of this team, they will improve the clinical care, they will ensure patient safety, and increase the efficiency and effectiveness of organization process. These are the pharmacy automation informatics team they do. Okay. This is the pharmacy informatics. I will not talk about definition, as the speaker already talked it before. There is 5 core competencies in the pharmacy information informatics team to work very well. These are the 5 core competencies they needed to build a strong, effective team. If there is a gap in one of these competencies, they can build it and they can learn it. I will talk in summary about this detail so that because of the time, and then I will show the case report we presented in Security Forces Hospital, Mecca. First of all, data information. Now, for any hospital, when they want to build a database, new workflow, they should know what type of data they are dealing with, the first phase. Why I should know the data? Because this data later on will be transferred into information. From the information, you generate multiple reports. If there is garbage data, at the end you have garbage report and garbage information. That's why they should know about the data, how to analyze the data, what type of data I need. Like example, antibiotic stewardship program. If they want to establish antibiotic stewardship program, they should know, okay, what type of data I need and how I could establish this data. Control terminology standard using the HIS system. Audit, ensure data easily understood and maintenance. So these teams should work with the HIS team and IT department to build all databases in the hospital. It should be from the pharmacy team. The IT doesn't know the pharmacy. If you ask the IT what's the process in the pharmacy, he doesn't know anything. The pharmacist should answer the question very well. Then after they know the data, they know what type of data I need, they should know what information I should generate from each data. Starting from inpatient, outpatient, IV, automation, antibiotic stewardship, anticoagulant therapy. They should know with all this data. They transfer this information to entire pharmacy team. Then they should know about the analytics, how to analyze the data. When I get Excel sheet, how to get important information from the Excel sheet into graph. They should know all this information and present it to the pharmacy committee and the medical director into good information. They should know all the analytics solutions. And it's not that difficult if you learn analytics. Analytics, if you have basic access databases and basic Excel, then you can develop yourself in the future. I will show you one of the cases we implemented by basic tools. Then clinical informatics. He should be aware with all entire process of the pharmacy. It's not possible that I put pharmacy informatics team, he doesn't know what's happening in the inpatient pharmacy. He doesn't know what's happening in the OPD. If you put like that, you will face a lot of struggle, a lot of challenges. He should be aware of the entire process, what is going on, what's not going on. So he should work with the entire team. He should not work as a solo. I used to say team because pharmacy automation informatics is working as a team. You cannot work alone. I will show a real example with a case. They start innovating new databases, new information, like we implemented databases for extemporaneous preparation, emergency medication, crash cart. We automated all the solution by simple tool, Access database. Then pharmacy automation informatics, they need leadership support. They cannot work alone. They should get the full support from the hospital administration, medical director, nursing director, and starting from pharmacy director first. If the pharmacy director support the pharmacy automation, then they can go with a lot of innovation. If the pharmacy is not supporting, then they will face a lot of challenge. As you know, the general pharmacy process involves prescribing, dispensing, administration, monitoring. Let's say we are a new hospital. We don't have HIS system. We don't have anything. We want to implement pharmacy automation informatics. These are the basic. You should just start from the beginning. Let's say one of the hospitals, they want to implement informatics and automation team. They don't have HIS. They have all their work is paper. It's difficult for them to establish all the solution. First, start with the clinical decision support and CPOM, HIS system. After you have this successfully, then you could start with carousel or central dispensing robotic or decentralized automated dispensing cabinet, IV, TBN compounding, and pneumatic tube system. This involves dispensing. Then third, start with administration and monitoring. These are all, there is a lot of solution for pharmacy automation informatics they can use, okay? So it's necessary for the team to establish the pharmacy automation informatics gradually as we started from zero. So we established a full team with full services. Do you see these are bold? The one in bold color we established in Security Forces Hospital Mecca from zero, from scratch. Now we are working on this not in bold color to establish gradually. You cannot establish all at once. There should be strategic plan from the beginning what to do next year, next year, next year. This is what we are doing and still we are working on it. So this is the team involved in pharmacy automation informatics. First of all is the leadership support. The leadership support is very important in the team. They are the ones supporting each activity happening inside the hospital. Then starting in the pharmacy. I put pharmacy in that color. Why? Because unfortunately, the pharmacy think, okay, once I do the service, okay, khalas, I will do it alone. No, you cannot do it alone. You need all this to work together as a team. You should establish a committee to work as a team to make sure successful program you implement it. Like I will show you, for example, many hospitals have automated dispensing cabinet, correct? What's the main problem you have in the automated dispensing cabinet? Discrepancy, correct? Many hospitals, and unfortunately, I visited many hospitals, until now they cannot manage the discrepancy. I sat with 2 or 3 hospitals they are my friends. They couldn't manage. I asked my friend, did you manage it alone? He said, yes. I said, you cannot manage it alone. You need a leadership support. You need a team. Should all work together. If you do it alone, you cannot do anything alone. So this is the most common challenge is lack of support, lack of training, resistance to change. You will face the pharmacy informatics team they are facing. So first of all, leadership support, why? Starting from the pharmacy director, because they are the one, they set the vision for the pharmacy. After 5 years, what does my pharmacy look like? Suppose we established in Security Forces Hospital Mecca, new hospital. There is nothing. We put strategic plan First year, what we will add. Next year, what we will add. Third year, what we will add. By that plan, we get leadership support, then we establish full automation informatics service in the hospital. Second thing, pharmacy. The pharmacy, they manage all the entire process of automation informatics. And the third thing is nursing. You cannot work alone without nursing. Nurses should be involved in the entire process for the automation informatics. Otherwise, we'll face a lot of resistance. That's why we monthly meeting, do schedule meeting with the nurse. We discuss all the challenges that we are facing in the pharmacy automation informatics, and we come up with one solution. So by that way, we did proper management. Another thing is IT. Sorry. IT department. IT, they have to manage the server, data backup, HIS integration. Biomedical, they make the maintenance, preventive maintenance. Engineering, they do infrastructure. And vendor, they do training, support, and troubleshooting. But IT is why is needed. How you maintain your data, how you manage your data, how to extract the Excel sheet of the data and do presentation of your data with the help of IT department. There should be a pharmacist who is with the knowledge of automation informatics, work there and do all this one. What's the benefit after implementation of automated dispensing cabinet in our hospital? We get all this benefit. We get, first of all, patient safety, medication error completely decreased, inventory management, we know what medication is there, what's not there, we did complete management for the medication. We did KPI measurement for the data from the first day of the implementation of ADC until now. So we have a plan in the beginning, what to measure, what not to measure. Until now, there is new measures coming up. Time saving, error reduction, process standardization, improve medication management cycle, reduce medication wastage. We did cost inside the ADC cabinet and the HIS for the future plan for the billing system. Then we know what the patient is taking from the automated dispensing cabinet by knowing the expiry and batch. This is one of the things we add, and so that in case of drug recall, we know each information for the patient. But this is the automation, what do people think of automation? It's not like that. The computer cannot do anything for you. You should work on the computer so that things should be worked together. The automation will not do anything, okay? As some of the speakers, they said before, automation will not replace the jobs for you. You have to work on the automation. This is the things I would to show you here. This is our case report in Security Forces Hospital Mecca after the implementation for the pharmacy automation informatics from scratch, from zero. New hospital started in 2014. Okay, we did a strategic plan from that time. We have challenge in the budget, but still we are working. The budget challenge, I think, in entire hospital, not in our hospital. But first of all, we did strategic planning after we established the pharmacy, what we want to be in the next year, third year, fourth year. After we did this plan, then we did implementation plan. Okay, if I take this solution, how I do the implementation of this solution? Who's my team? Who's supporting our team? Then we did planning for the training. After we buy the solution, we did training for all the team. We go live, then we took a lot of reporting measures. There is something that you cannot improve what you cannot measure. Because many hospitals, they say, okay, we want to improve. The first thing you ask them, do you have a data? No. Then how you improve? You cannot improve. This is the problem here. We took reporting, maintenance, and follow-up. This is 11 measures now we are taking from the automated dispensing cabinet. I will show a report in detail until now, from the first day we go live until now. This report are coming, will be delivered to the nursing director, medical director on monthly basis, just to monitor the performance. I will explain each one in summary. So, how we utilize this report? Okay, it's simple solution. Pharmacy automation informatics. Okay. We utilize data access database, okay? We took all the data from the automated dispensing cabinet Excel sheet, add it into the access database. Because the Excel sheet, if it's heavy data, it will stuck. Then we generated Power Query containing a lot of formula and calculation in the Power Query. Then into Excel sheet. We utilize the DAX, data analysis expression, that is present in the Excel sheet, free version. You can do it, that's not cost solution. We started from zero cost. After we did all this, whenever we take the data from the automated dispensing cabinet by Excel sheet, we do nothing for the data. Just we take it, we drop it into the database. Automatically, all the graph is coming automatically. I'll show you now the graphs that's coming automatically every month to monitor the performance. So one of the benefits we observed that before in the inpatient pharmacy, we are dispensing, let's say September, okay, or August, 17,233 doses given from the inpatient pharmacy. After we implement the automated dispensing cabinet, we make a reduction 91 to 89% of medication dispensing. Now the pharmacist who's working in the inpatient pharmacy, he's feeling very relaxed because 90% of the medication is in the ADC cabinet. Now, so it became easy for them to manage. Another improvement we observed, missing dose requests. Before the implementation, we have the nurses asking a lot of missing doses. After the implementation of ADC, we observed 90% reduction of missing dose requests. There is also decreased the workload for the pharmacist. Before, we were putting 2 staff in the afternoon and night. After the implementation of 24 cabinets in the hospital, we now put 1 in the afternoon, 1 in the night. He can manage everything in the inpatient pharmacy. We did reduction for the working hours in the hospital. This is the KPI measure that you are taking on monthly basis inside the hospital. These data are coming automatic. We are not manipulating the data. We take it into Excel sheet from the database, from the automated dispensing cabinet, put it in the database, then graph automatically reflected in the Excel sheet. I will show you here the ICU unit, the most critical unit, the most high dispensing unit. As you see the discrepancy, less than 5%. We managed with the team that after we implement the solution, we don't want discrepancy. Please, okay, we will monitor your performance on monthly basis. We measure the data so that it should be less than 5%. Some people said, why 5%? Why not 10%, 20%? I asked them, okay, in KPI measurement, medication error, what's the accepted percentage for medication error? 5%, correct? As in our hospital, accepted 5%. So we put it 5%. So on monthly basis, we measure this KPI. Then we measure the null transaction. As you see, started the machine with 98, ended into 42. We investigate in May why it's 116. Null transaction, those nurses are playing with the machine. They're not using the machine wisely. We take their name and follow up with them. Another here, let's say adult intensive care unit here, item issued. We monitor how many doses dispensed on monthly basis. Why I measure this doses dispensed? To see how the medication quantity enough or not enough, to measure the data, to analyze the future performance of the machine. Override percentage. We are measuring the override, how many orders taken by override by each cabinet in each station to monitor their performance. As we agree, we should not exceed more than 6% to 7%. So as you can see, this is for the IC unit. And here, as you can see, item expired. We monitor the item expired inside each cabinet. This is only for the ICU, the item expired, on monthly basis to measure, to minimize. We linked the item expired with the cost at the end because on monthly basis, we generate cost report for the top administration. What's the cost of the expiry? We make a plan to minimize the cost. Then another measurement we make, this one, how many items refilled on monthly basis inside each cabinet for each station. So we measure to measure the workflow for the technician. Is 2 minutes? Okay. To measure the workflow for the technician, okay? Then another missing dose request. One of the discrepancy that the hospital are facing, that missing dose, correct? They go to the cabinet, they saw it's a lot of discrepancy, a lot of missing medication. We link the cost with the missing medication. After we link the cost with the missing medication, the nurse become more aware. So they become scared a lot so that they cannot play with the machine, they cannot take more medication. This is the report only for ICU. Same report, male medical, male surgical, female medical, pediatric, NICU, PICU, generated separately. How many items return? We try to minimize the return medication. But we did, after implementation of 1 year in the hospital, we did a questionnaire for the nurses, okay, to see how they are happy with the services. One of the question, the ADC helped them to, my medication administration is more efficient on time on dose. 76% they agree it's okay, which is a good response. Again, 78% that it is efficient for them. We train a pharmacy staff to manage minor problems so that whenever they call the pharmacy at any shift, they can solve the solution. So 68% they said the pharmacies are helping to solve many solutions. And the last survey question we make for them, it helped workflow more easy. 81% of the nurses reply that's make them their workflow is very easy. طيب, you have the question, you received the question? This is scan question. Okay. After implementation, the automation solution, do I need my staff or will the solution run automatically? Unfortunately, some of the medical, let's say, pharmacy director, they think the solution will run automatically. No, it's not running automatically. You need your staff to do all the tasks, all the information, all the necessary tasks. So I have a small video here. But does it worth them investing in automation in this cabinet? If the question was with you. You can have data but without information, but you cannot have information without data. That's why you need pharmacy automation informatics team in each hospital. I have a small video with what will happen if there is no pharmacy automation informatics team in the hospital. Just imagine what is happening. Just funny video for you. كيف أشغله؟
That's not good.
Oh, I don't need this. I'm already late.
Somebody will come.
Voice.
Anybody out there?
Do you have a phone?
No. Sorry. Somebody! Hello! There are two people stuck on an escalator and we need help. Now, would somebody please do something?
Help!
I don't believe this. You gotta be kidding me.
I'm gonna cry.
Well, there's not enough left to do, is there?
Hello? Hey, don't worry about it. I'll fix it in a second.
He said he can fix it. All right. All right. That's more like it. He says he can fix it.
Walking down the sidewalk, kicking my feet as I'm moving to the music. Step to the beat. I woke up today, canceled all my plans, and I stepped right outside with my guitar in my hands, and the notes became a.
Thank you so much. Thank you. I don't know if you have any question for any of this presentation. Okay.
Thank you so much for your informative presentation. I have a question about the pharmacy staff, the pharmacy informatics staff. Do they need to take some courses, or do you ask for a special degree to allow them to work, or only by experience? In your situation.
Okay. Based on our experience, there is a lot of courses for pharmacy staff, like SHP Informatics, as you know. There is another course called Health Informatics by Coursera, another course for pharmacy team called Data Analytics, available in different online solutions that help you a lot to build a strong team in the pharmacy. The pharmacists can take these courses. If they cannot take these courses, at least one, like in our hospital, I already have these courses. What I did, I trained my staff one by one. I sit, let's say, with this week with one staff. I train my staff all the information, all the necessary items so that he can work very well. Then after 1 month, I take another staff. By this way, we build a good team, good pharmacy team. Thank you, Doctor. Okay, thank you so much. Thank you.
Thank you, Dr. Majid, for this enriching talk. I would like to invite Dr. Rashid Al-Ghanim to the stage for recognition. And now we will take 15 minutes break. Then we will be back for the round session. Thank you all.
please, at the doors. If you can be seated so we can get started. Colleagues at the door, everyone, if you can be seated so we can get started, please. طيب السلام عليكم ورحمة الله وبركاته. أرحب بكم من جديد من بعد البريك. I would like to welcome all of you. Again, my name is Abu Bakr Amar. I'm the head of the scientific committee for this great event and scientific gathering. اليوم إن شاء الله, and right now we're about to start a new concept that's been given and delivered for the first time among all the scientific gatherings and conferences. We're introducing the concept of round table, where decision makers, leaders, and people known of good figure and strong and powerful figures who can help in advancements of our profession as much as we are trying as much we can. Meet with experts, leaders, managers, to hear and live the moment they are living down in the practice. And in a very open floor, deliver the difficulties, challenges, barriers they are facing, or even whatever they think that it can help them progress and deliver optimal patient care in our hospitals, to our families, to our visitors, and to our patients. And for that, we need to welcome the moderator of this specific and special event, مدير إدارة الرعاية الصيدلانية في وزارة الصحة الدكتور محمد الشناوي والمعروف لا يعرف. أدعوه للحضور introducing the guest of honors and the speakers for this afternoon. So please join me to welcome Dr. Mohammed Shanawi.
First of all, sorry for the delay in our program. And I hope everybody got his lunch already and the glucose level in the blood got to normal levels. Because we are starting a round tables that it will really it will be really exciting for all of us. طيب, first of all, we will give a chance to our pharmacy directors in different regions to talk about our roundtable session about the mapping out the pharmaceutical care demand in the kingdom. Roadmap to equal distribution of resources and manpower. أنا ما أعتقد في أي مدير صيدلية في العالم لو رحت سألته سؤال do you have enough staff هيقول لك عندي عدد كافي ولا أريد زيادة عدد. أعتقد كل مدراء الصيدليات في العالم وليس في وزارة الصحة وليس في المملكة فقط هيقول لك هيجاوبك هذه الإجابة.
with the committee session. Present we make for the distribution of clinical pharmacy. So, King Fahd Specialist Hospital in Al Qasim Buraida, the hospital capacity is 600 beds, and the yearly admission rate, it's about 19,000 per year. So we have more than 29 specialties in our hospitals. So you can see all these specialties are available in our hospital. In terms of the numbers of clinical pharmacists and pharmacy technicians, we have only 4 pharmacists, clinical pharmacists and 14 pharmacists. So we need around 30 clinical pharmacists to cover the clinical services in the hospital. So the barriers and the what different regions, even as I mentioned in the previous slides, we only have 4 clinical pharmacists. Another barrier is lack of job opportunities for senior and consultant clinical pharmacists. I'm seeing this job. I mean, the الحمد لله الفترة الماضية كثير من الصيادلة الإكلينيكيين الفترة الماضية، ولكن ما زال في بعض الصيادلة ما زالوا على وظائف صيدلي وهما senior clinical pharmacist. And postgraduate training. جزاهم الله خير، يعني مشكورين. بالتنسيق دائما قالوا أي أحد يحتاج تدريب يعني نتمنى إرسال الأسماء لنا، ولكن إحنا نبي باثوي واضح جدا عشان ما ياخذ الوقت الطويل إنه يكون في تدريب للبوست جرادويت كلينيكال فارماسيست وياخذون الخبرات ويحتكون في other specialized hospital and experts clinical pharmacists. Lack of awareness among healthcare team about the patients, about the important role of a clinical pharmacy. And I would say this is our job. So we have to introduce the clinical pharmacist. We have to be knowledgeable. We have to have a good communications to make it, I mean, the physicians understand the good role of a clinical pharmacy. Lack of electronic scientific references such as up-to-date journal access, Sanford. يعني أنا شخصياً وبعض الزملاء يعني هو في موجود المايكروميدكس في الوزارة، ولكن أحياناً نحتاج إلى بعض الريفرنسز اللي ممكن أنها تفيدني as a clinical pharmacist، وكلها للأمانة جهود شخصية إحنا مشتركين يعني personal subscription يعني بل lack of financial incentives for advanced clinical services such as running anticoagulation. بالإضافة للورك لود اللي عليهم as a clinical pharmacist في القسم، هم جالسين يقدموا clinic service وللأمانة there is no reward for that. في الافتتاح ممكن الدكتور أحمد عرج على موضوع أن الكلينيكال فارماسيست اللي graduated as a clinical pharmacist but they are not practicing. هذه أحد الأسباب اللي قد تكون ساهمت في الشورتج، إنهم sponsored by Ministry of Health and they are working in different sites. They are not practicing their clinical service. Lack of sufficiency and clear privilege. We face this issue يعني الأمانة الإشكالية دي واجهناها لما تم تفعيل وصفتي، خصوصا الزملاء اللي في الأنتي كواجوليشن كلينيك واللي في الديابيتك كلينيك، فلما يحتاجون إنهم يصرفون أو يغيرون change الدوزز of warfarin ولا they are prescribing some diabetic medications. وصفتي يعني للأمانة قالوا إن البريفليج هذه موجودة فقط للأطباء، فالزملاء as a clinical pharmacist they need this privilege. Just to propose some solutions for that barriers. So hiring a skilled clinical pharmacist, also expanding postgraduate residency programs, especially the PGY2, the specialty one, intensifying the clinical training and of a clinical pharmacist. This issue, I think it has been discussed many times for our colleague, and I'm one of them, clinical pharmacy with a master degree. يعني الزملاء متأكد أن الزملاء واثقين فيهم وكفاءاتهم بإذن المولى عز وجل، ولكن لما نحتاج أن نكمل الدراسة البي اتش دي أتوقع حاليا ما في مجال، ولكن لما يكون عندنا تفكير أن ندخل الريزيدنسي إحنا نحتاج أن نبدأ من R1 بالرغم من أنه ماستر ديجري. This one can help in, offset clinical pharmacy shortage, the telepharmacy, with the, أنا أقصد في النقطة هذه with different, regions. يعني إذا إحنا نحتاج أن نتواصل مع أي clinical pharmacist for consultations, so the telepharmacy can help in that. Thank you very much.
Our next speaker is Dr. Ali Faris Tibinawi. He is the Regional Director of Pharmaceutical Care Services, Hayel Health Cluster, Ministry of Health, Hayel. Please welcome with me Abu Faris.
السلام عليكم. أسعد الله أوقاتكم الجميع بكل خير. Good afternoon, everyone. So, we are requested to prepare the same slide from the scientific committee. I will go through it, inshallah, quickly. So, starting with our experience in King Salman Specialist Hospital. The hospital capacity is 500 beds. Annual admission rate, I cannot get this information. Regarding the specialties in our hospital, we have 3 different specialized center, which are cardiology center, oncology, hematology center, diabetes and endocrinology center, and with a specialized surgery such as bariatric surgery. Regarding the manpower, we have a different department in our King Salman Specialist Pharmacy. Starting with inpatient pharmacy, we have 18 pharmacists. IV, TBN, and chemotherapy, we have as well 8 pharmacy. Outpatient pharmacy, we have 10 pharmacists. In drug information center, we have 1 specialized drug information center, clinical pharmacist, which is Dr. Maram Al-Anizi. Automation as well pharmacy, we have 1. Pharmacy store, we have 5. The point here is in different institution, almost the store related to or involved under umbrella of the supply chain. But in our hospital, we linked them to the pharmacy directly. The total number of technicians is 23, more than the number of pharmacists. We have as well 4 clinical pharmacists, and the pharmacist to patient ratio was 10.6%. So the barriers, as Dr. Abdul Majid mentioned, we have shortage in pharmaceutical items. This really one of the important things, which is the drugs as well consumables. High number of technicians versus low number of qualified pharmacists. No clear roadmap for WASFATI and outpatient services. Because in the beginning we have started with WASFATI, so each hospital or the roadmap was to close outpatient pharmacy, but before I think 6 months, we have been informed to no, don't close the outpatient pharmacy, just work as what we called partial operation for outpatient. So there is no residency or development program for pharmacy technician, which is very important thing. Limited number of professional certificates. So we have some solution can be inshallah suggested. Link pharma supply chains under pharmaceutical services. I think this is important thing to solve the shortage issues. Increase the number of PharmD position is very important because, as you know, we have more in technician. I think in Riyadh here, the opposite. They have pharmacists more than the technician. But when talking in Hail, in our city, the number of technicians is more than pharmacists. So increase the number of senior pharmacists and consultant position, as Dr. Abdul Majid mentioned, to publish a clear roadmap for WASFATI and outpatient services, to distribute the new PharmDs equally, to establish a new residency or development program for pharmacy technician to prevent any dropout and increase their loyalty to the profession. Thank you.
Thank you, Dr. Ali. Thank you, Dr. Ali. Our next speaker is Dr. Muhammad Shar'an. He is the head of Pharmaceutical Care Department, Prince Met'ab bin Abdulaziz Hospital in Skaka. Please welcome with me Dr. Muhammad.
السلام عليكم، مساكم الله بالخير جميعا. شكرا على الاستضافة على التنظيم الرائع. صراحة السلايدات هي مطلوبة من الجميع كما هي العناوين. دكتور علي دكتور عبد المجيد تقريبا تكلموا عن جميع الأمور اللي تواجهنا احنا كمدرس صيدليات واللي شفت أننا متشابهين، لكن راح استعرض السلايدات. بالبداية أنا مدير الصيدلية في مستشفى أمير متعب بن عبد العزيز. الهوسبيتال كاباسيتي عندنا 300 بيدز. الانوال ادميشن ريت 8,707. We are a general hospital. We have orthopedic, surgery, and the other specialists. Here, this pharmacy department, we have inpatient pharmacy, and I put here the things we are do as extra, like antimicrobial stewardship and VTE, and some programs are request from us to do it. And we have IV and TBN, narcotic and control medication unit, outpatient pharmacy, AR pharmacy, quality and patient safety, medication counseling clinic. We have some barriers, and before that I have a small story. أنا قبل ما أبدأ بتحضير السلايدات جمعت الفريق في قسم الصيدلية وسألتهم سؤال إيش الأشياء اللي تشوفونها ممكن تسوي لنا barriers. فالجميع أجمع على manpower shortage in general, shortage in certain specialists like a clinical pharmacist in our hospital. I'm sorry to say that we didn't have clinical pharmacist and pharmacist at all. Old electronic system, and I think this is one from the very important problem in our pharmacy because we have the old Oasis system and we cannot use it for many things. Proposed solution, I think we have to do some redistribution of workforce in the hospitals. Like you will find in my city, there is some hospitals, they have a lot of pharmacists, and in my hospital we have just 9 pharmacists, and the other are 14 technicians. Qualified people who work outside the scope of hospitals. Like we see some clinical pharmacists, they are not working in the hospital, and as you know, we need him to be in the hospital to give a good service. Follow up by pharmacy director for requests that's related to modern technology. And as we see now, we have good communication with Dr. Muhammad to make our hospital fully automated, inshallah. Thank you.
شكرا جزيلا دكتور شرعان. Now it's my pleasure to introduce our guest of honors. The problematic people will be sitting here, and the names that they have, inshallah, the solutions. Please welcome with me Dr. Ahmed Al-Judea, Assistant Deputy Minister for Therapeutic Affairs. Our second guest of honor, Dr. Ahmed Al-Fahid. He's the Director General of General Administration of Academic and Training Affairs in Ministry of Health. Please welcome with me Dr. Ahmed Al-Fahid. We are expecting Ms. Masha'al Azza. She is the manager of our HR. I believe because of heavy traffic outside, maybe she will join us during our discussions. Thank you all, pharmacy directors. لا عنده شغال. أنا اللي عندي شغال. طيب. Let me start first with Dr. Ahmed Al-Fahid. Dr. Ahmed, one of the challenges that it was mentioned clearly, the unavailability for development of technicians. They don't have possibility for development, for postgraduate studies. It's limited just only for their diploma degree, and that's it. There is no any future. From your point of view, how can we help as the academic and training affairs in the Ministry of Health? How can we help our technicians to improve? Is there any kind of opening for bridging? Anything that we opened in the past? Anything that we may open or we may increase in the future? Anything up to your knowledge.
Thank you very much, Dr. Mohammed. First of all, I'd like to thank you all for this great event and the huge preparation that has been done the previous period. And we would like to confirm and assure you that with regards to your questions about qualifying the pharmacist or any allied health or even the workforce for the Ministry of Health is one of our top priorities. The question is, do we have enough resources to qualify and train pharmacists or other allied health specialties? Unfortunately, no. We still have a demand for qualifying our staff, and specifically when we're talking about pharmacists or pharmacology practice, we were keen to open new windows for our colleague, collaborating with institutions in Saudi Arabia, such as universities and training institutes, to build this kind of collaboration that will last for many years to bridge the qualification of our technicians. And we had successfully implemented such collaboration in previous years. Also, we invest in our international collaboration with different bodies for our international scholarship plans. And again, to assure you that from the records of 2022 and 2021, we had reviewed many applications from pharmacists and technicians as well. And all applications have been approved and they got the chance to proceed with their studies. So we don't limit the resources for them while trying also to provide new opportunities for them. So to assure you, if you have an application, if you have an acceptance in any educational settings, university, or in Saudi Arabia, or even abroad, we are welcoming your applications to be supported by Ministry of Health. Today we have a transition. We are witnessing this transition, not only in the Ministry of Health, but also with education settings, such as university. They are moving towards a different model now. This different model has many advantages for us. So our scope now, or our mission, is to try to invest these new opportunities with the universities. And obviously, Dr. Ahmed knows very well the new trend now in the new model. And we promise you that we will support the studies for our pharmacists and our colleagues in all specialties, inshallah, in the near future.
يعطيك العافية أبو رتيل. دكتور جديع one of the challenges that it was mentioned clearly, unavailability of residency for technicians. Is this possible? And if it is possible, can we support it from Ministry of Health point of view?
Just to make sure that I heard you well, unavailability of residencies for?
Technicians.
Ah, for technicians, okay. Okay, so technically speaking, yes, we could develop some sort of residency-like experiences for our technicians. And it's important for our technicians who haven't been exposed to different parts of health system pharmacy settings. Yani you might find a technician who's been a pharmacy technician for 10 years who doesn't have any experience with sterile preparations, مثلا, or cytotoxic preparation, or مثلا automation, unit dose automation, automated dispensing cabinets, parenteral nutrition. All of these are very important for us to prepare well-qualified technicians in a hands-on experience. However, the name residency, as per the Saudi Commission, is only applies only to postgraduate studies in the healthcare settings. يعني healthcare professionals postgraduate. نتكلم عن after bachelor degree. So we're talking about residencies in medicine, surgery, nursing, pharmacy, radiology technologist, and others. طبعا مسمى technologist, just for clarification, is different than a technician. Technician is somebody who has a diploma below bachelor degree. Technologist is a terminology used for other allied lab technologists, those who have bachelor degree, and currently we have residencies for them in the Saudi Commission, under the umbrella of Saudi Commission. So to me, the name doesn't really matter a lot. What matters is the structure of the program. I think it's doable. We can do it under the Saudi Commission Academy, Health Academy. Any program less than a year can be done there. يعني ممكن يكون 9 months, ممكن يكون 12 months or so, 50 weeks مثلا. And it qualifies them for an extra step in their career ladder. At the same time, we make sure that we train them in the best, state-of-the-art settings where they can actually gain experiences. يعني الآن one of the challenges you have, Muhammad, you open a new IV room in X hospital, right? And then you have to send somebody, 1 or 2, sometimes even more, to a higher institution with very good sterile preparation standards, يعني Joint Commission / Sibahi required, in order for them to be trained. But there is no structured training program similar to this. We could definitely develop a diploma, وفي بالمناسبة under Saudi Commission multiple diplomas, less than a year time, and it will qualify them في ديوان الخدمة, في التشغيل الذاتي, for a different arrays in their career. At the same time, احنا we benefit. I think it's a win-win situation. And if you ask me who should do this, أنا أعتقد Ministry of Health should take the lead. We should take the lead, and not necessarily in creating the sites for training, the main sites for training, but at least take the lead لأن إحنا أكثر ناس محتاجين. Okay? Number one. Number two, we have the capabilities of expanding these sites to become reference sites in the future. يعني عندنا ما شاء الله multiple medical cities, multiple central hospitals with the excellent, and I've seen, honestly, and I've seen IV rooms, sterile preparation areas in some of the central hospitals because they were built, designed recently. They're actually better than sterile preparation room اللي كانت عندنا في التخصصي. Okay, why? Because it was built recently under the ASHP guidelines and USP 797 compliant rooms. Some of them actually are USP 800 compliant cytotoxic areas. So we have ability to expand in the future and to accommodate more trainees. So I am with having special diploma for technicians, and it can be customized depending on the experience the technician had before. And if you have a technician مثلا who came from primary healthcare settings, doesn't have any hospital pharmacy experience, then you can give them the whole experience from A to Z. If you have somebody who's been working in sterile preparation all the time, and a very good experience for sterile preparation, but they don't have good experience مثلا في automation, they don't have good experience في cytotoxic ولا parenteral nutrition, it can be customized to be more flexible in order to address the need that we need.
شكرا جزيلا دكتور. أنا إذا تسمحوا لي أبغى أسأل المدراء. إحنا أعطينا أرقام جدا رائعة. كيف أنت تتأكد إنه عدد الموظفين اللي موجود عندك أنت مستغلهم أو مو مستغلهم؟ أنت معطيهم أعمال بالقدر الكافي. بمعنى إنه الناس اللي موجودين عندك فعلا مثلا clinical pharmacists, are they doing a good number من الكلينيكال interventions اللي هو مطلوبة؟ الصيادلة اللي موجودين عندك هل الورك لود اللي assigned لهم هم good number of work ولا لا؟ ودي أسمع منكم يا جماعة مدراء الصيدليات.
إذا تسمحوا لي أنا ممكن دكتور بالاعتماد على حسب الديجري، يعني الفارماسيست يختلف الحديث عنهم عن التكنيشن بالنسبة للاحتياج، وكذلك للتاسك اللي ممكن نعطيها. يعني بالنسبة للتكنيشن ما جانا يعني توظيف من فترة تكنيشن. التكنيشن كان توظيف قبل فترة يعني طويلة، ولا لا دكتور عبد المجيد؟ قبل فترة طويلة، فما فيه إلى الآن تكنيشن. والمشكلة لما ذكرناه حنا أنه عند التكنيشن من أرض الواقع لما نشوفهم اليولتي عندهم ضعيفة للبروفيشن، لأنه يدري أنه ما عنده مجال إلا يكمل مثلا بكالوريوس. وأيضا القضية أنه لما يكمل بكالوريوس المجال المفتوح له من الكليات للأسف المخرجات ما هي جيدة أبدا، يعني كأنه هو نفسه ما تغير بس أنه معه شهادة بكالوريوس. فحتى ممكن يضيق علينا هنا على توظيف النيو فارم ديز. وزي ما ذكرت يعني الدكتور مشكورين، التوظيف اللي كان جديد كل الفارم ديز أو اللي بكالوريوس كانوا حطيناهم يعني بأماكن فعلا كانت حساسة، وكل واحد they lead new initiative وشغال قسم معين والورك حقه ممتاز مرة يعني. بس حنا قضيتنا بالنسبة للتكنيشن إنه لو كان زي ما ذكر الدكتور أحمد في دبلوم مثلا 1 year ويرجع لي مثلا IV يكون expert TBN preparation كيموثيرابي النيدز اللي أنا أحتاجها هذه، ويكون في عنده يعني تطور وظيفي معين، إنه مثلا يرقى درجات معينة بالسلم لو ما كان في بسلم الدبلوم أي شيء، بس إنه يكون في عنده تحسين. هنا أنا متأكد إنه حتى اليولتي حقتهم بتزيد أصلا البروفيشن، ونواجه كثير يعني مشاكل بهالأسباب. من قضيته من أكثر الأسباب الثانية أيضا التسرب، بس الحمد لله قدرنا يعني نمسك نعمم نضبط الناس إنه خلاص ما فيه. بس إنه حتى لو ما كان فيه ما فيه مرة added value من الموضوع. وكذلك مع موضوع وصفتي لما جبناهم الآن جدد، كل هذه قضية التكنيشن. حتى تريننج لما بنسوي لهم تريننج، يعني مثلا نتكلم عن منطقة حائل على سبيل المثال، أنا عندي بس 2 هوسبيتال اللي فيهم اي في out of 14، وهذه مشكلة صراحة إنه ما فيه اي في روم. فمسألة حتى تدريب كل الناس بتكون بسنتر واحد على نفس التدريب اللي أرسلتوه مثلا دكتور من الرعاية الصيدلية. فنحتاج دعم لهم بهالجانب، دبلوم معين يلتحق به اللي عنده زي الريزيدنسي مثلا، يلتحق اللي عنده باشن،
يكون في شروط معينة يعني للقبول في هذا البرنامج.
هو متحمس، يعني في من التكنيشن ناس متحمسين زي ما مثل البكالوريوس في ناس متحمسين وعندهم باشن انه يكمل ريزيدنسي يكمل، فهذول عندهم ولازم يكون لهم ادد فاليو.
احنا طبعا اللي بدأ عندنا العام اللي راح بس لسه ما شفنا المخرجات حقته اللي هو التجسير. عندنا سنويا الآن بالتعاون مع الإدارة العامة للشؤون الأكاديمية والتدريب تجسير كامل للفنيين يصبحوا صيادلة، بس لسه ما شفنا المخرجات حقته. يعني يلا عدت سنة عليهم فلسه ما بدأنا نتخرجوا وقدرنا إن احنا نشوف المخرجات تطلع منهم يعني إن شاء الله بإذن الله. دكتور
محمد
تفضل.
Can I add something هنا؟
تفضل.
معليش. ترى في نقطة مهمة جدا أعتقد دكتور علي يعني alluded to. تسمعوني واضح؟ اوكي. ترى مو لازم الجميع يجسر، مو لازم الجميع يكون فارماسيست. احنا نحتاج فارماسي تكنيشنز اكثر من الفارماسيست كاعداد. وهذا النورمال ثينج انه عدد كل فارماسيست المفروض معاه مينيمم 2 to 3 تكنيشنز. النورمال ريشيو انه يكون في عدد اكبر من التكنيشنز من الفارماسيست. فترى مو الهدف انه نجسر الجميع، ولا الجميع اعتقد عنده انترست انه يجسر، لكن لانه في بعضهم اصلا رواتبهم الحمد لله ارتفعت بشكل كويس، لو رجع مره ثانيه يمكن يقل الراتب حقه لانه بيدخل في اول
صحيح
مربوط. بس الاشكاليه وين؟ الاشكاليه اعتقد مهم جدا، ودي اعلق على موضوع المخرجات اللي تكلم عليه الدكتور علي. ترى الزملاء مسوين يعني بلاننج، وهذه نقطه مهمه جدا، موضوع السنتراليزيشن والكومبيتيشن على السيت واختيار الافضل من المتقدمين. انا شفت تكنيشنز مستوياتهم رائعه جدا وعندهم خبرات رائعه جدا، تمام، وحقيقه متميزين، لا من ناحيه اي كيو ولا من ناحيه كوميونيكيشن ولا من ناحيه خبره ومعلومات، بالعكس almost a pharmacist، بس يحتاج له يعني certain training في يمكن اشياء معينه. انا اعتقد هذول الناس المفروض يجسرون، ويمكن اسهل، انا عندي افضل اني اجسر واحد زي هذا، وعندنا حالات ترى كثيره جدا، اجسر واحد زي هذا يكون افضل لي من واحد نيو جراديويت فارم دي. ليه؟ لانه اول شيء هذا جاي عندي خبره، الشيء الثاني عنده بوزيشن في وزاره الصحه، ما يحتاج اوظفه، ما يحتاج اطرح وظيفه واروح اختار، لا هو موظف عندي، انا اعدل وظيفته فقط. اوكي، ما يحتاج اني اطلب يعني بادجت جديده على نيو بوزيشن. فانا اعتقد بالعكس، لكن لازم يكون في توازن. انا لا متوقع مني اجسر الجميع، ولا متوقع مني اني ما اجسر احد، انا المفروض اجسر الافضل. اوكي، حتى اني انا لما اختار بناء على كرايتيريا معينه واضحه جدا متعلقه ممكن انجلش، ممكن مثلا اكزام ريزلتس، ممكن مقابله، ممكن جي بي اي whatever، تمام، والاحتياج، هل انا فعلا احتاج العدد هذا ولا لا في المنطقه اللي انت فيها. طبعا صيادله احنا عندنا سفير شورتج كل المناطق كصيادله، كتكنيشنز ما اعتقد احد عنده كنمبر وايز، ما حد عنده شورتج. فلذلك اللي انا اقوله التوازن في الموضوع هذا ترى مهم جدا، ما هي قضيه انه انا ما ابغى اجسر ولا لازم اجسر الجميع. انا ترى احتاج تكنيشنز يا جماعه الخير. احنا تتذكر محمد ايش سوينا في التخصصي لما موضوع الكارير لادر، وي كرييتد حاجه اسمها سينيور فارماسي تكنيشنز، تمام، بحيث انه ما يصير على طول اول ما يتخرج يصير تكنيشن ويجلس تكنيشن طول عمره. اوكي، يصير سينيور تكنيشن. اوكي، والسينيور تكنيشن الجريد حقته نفس الجريد حقت الفارماسيست، جريد 8. تمام، والراتب حقه اعلى من راتب الفارماسيست. اوكي، اللي هو الفريش جراديويت فارماسيست. حلو، مقارنه بالسينيور تكنيشن. فهذا طبعا مهم جدا، وهذا الموجود ترى في امريكا يا جماعه، ترى الموجود في امريكا الان اعداد التكنيشنز اكثر من اعداد الفارماسيست. التكنيشن لهم كارير باث، عندهم سوسايتي معينه، عندهم سيرتيفيكيشن بروجرامز، عندهم الان كثير من الستيتس صار يو كانت براكتس زي زمان، يو كانت براكتس الا عندك سيرتيفيكيشن انك سيرتيفايد فارماسي تكنيشن. تمام، CPT يسمونهم. فانا اعتقد هذا الاهم عندنا من موضوع التجسير.
ولكن ما بنقول فقط يا دكتور تجسير، هل في حالة وجود دبلومات أو كورسات مخصصة تكون للفنيين؟
ممتاز.
مثلا زي ما تفضل الدكتور، مثلا في التحضيرات المعقمة، الستيرايل بريباريشنز، أو في الاكستمبورينيوس. هل هذه الدورات فعلا ممكن ان هي تكون مساعده؟ وكيف انه احنا ممكن انه احنا نخليها تكون اكريديتد مثلا من الهيئه السعوديه للتخصصات ومدعومه؟ اعتقد من صححني دكتور احمد الفهيد، اذا هذه الدورات انا اشوفها موجوده في تخصصات اخرى بتكون موجوده فيها الدورات او الكورسات هذه بتكون موجوده، اللي هي الدبلومز اللي هي ممكن تعطى للفنيين.
انا اعتقد ممكن هذا الطرح جدا مهم. ما ادري الصوت عند الاخوان واضح؟
كثف شوي. ايوه.
اعتقد النقطه او الجزئيه هذه انتم ذكرتوها، يعني تفضلتوا انتم في مساله واحنا ممكن نسميه اللي هو التاهيل او التعليم الموجه. صحيح. بمعنى انه انت توجهه على حسب احتياجك بحيث انه يكون كاستمايز، لانه في سيتنجز اليوم موجوده، هي موجوده من عشرات السنين، انه والله عرف انه والله في الدبلوم الفلاني وفي شهاده الباتشلر الفلانيه، ويمكن الكرييشن اللي صار مؤخرا او في السنوات الاخيره في مساله الماسترز والبي اتش دي، ولكن غالبيه الشهادات اللي هي الباتشلر وما دون هي موجوده من فتره طويله. فاعتقد انه نعم، اتفق انه هذا وقت مناسب انه احنا نفكر اليوم بالتخصصات اللي فيها احتياج، بحيث يتم اقتراح تاهيل موجه لفئات معينه او لتخصصات معينه. الدبلومات القصيره اللي مدتها من سنه فاقل، غالبيه خلينا نقول من البراكتس اللي موجود الفيزيبيليتي حقتها عاليه جدا، لانه انت البرنامج هو مبني على احتياج واضح. اعداده من الناحيه الاكاديميه بالشراكه مع اي جهه اكاديميه اعتقد ما راح يجد صعوبه كبيره، ما هو مثل الشهادات الباتشولر وما فوقها، لانه هذا امر احيانا يكون يعني يحال الى مجلس الجامعات واقرار التخصصات الجديده وفي ميزانيات جديده. لكن اعتقد انه في فرصه مواتيه اليوم انه احنا اولا نحصر احتياجنا. اللي ذكرتوه مهم، لكن وين البين؟ اليوم الان لازم احنا نحدد البين. والله في 3-4 تخصصات معينه هذه نحتاج نأهل فيها، هذا رقم واحد، هذا التاسك الاولى. التاسك الثاني لازم نفكر ايضا مثل ما ذكر ابو عمر مساله طيب ثم ماذا لما يحصل هو على الدبلوم الموجه؟ انا لما اطلع دبلوم في احد ممارسات الصيدله TBN مصطلح مثلا، بعدين هو حصل عليه تدرب فيه 9 شهور، تدرب فيه سنه مثلا، ثم ماذا؟ هل في تعديل وظيفي في السلم؟ طيب التعديل الوظيفي يستلزم اجراءات يعني اقدر اسميها طويله جدا في مساله الحصول على الاعتمادات اللازمه من وزاره الموارد البشريه، اقرارها في السلالم الوظيفيه، اقرار حصوله على درجه اضافيه مثلا في كان هو فني فيحصل على درجه اضافيه. وميزه الدبلومات ايضا انها ما هي مقتصره فقط على حمله الدبلوم، انت ايضا تقدر تستهدف فيها حمله الباتشلر لما يكون انت عندك حاجه تخصصيه معينه، حتى تستهدف فيها حمله الPhD، ولكنها تعتمد على ريكوايرمنتس معينه انت ضعها. فبالعكس نشد على يديكم اذا في احتياج معين، احنا ممكن نشوف ايش الطرق النظاميه اللي ممكن احنا يعني نوفر هذا الشيء، ونشوف من شركائنا في التعليم. يعني الجامعات اليوم اعتقد مقترح زي هذا ما راح يعني يكون مقترح مرفوض من البدايه، بالعكس راح يبحث ونوجد له حلول. ويمكن يكون واحده من يعني افضال هالمؤتمر خروج بهالتوصيه مثلا لاقتراح مسارات ودبلومات لما اسميها مهن جديده، ممكن نقول لي اختصاصات معينه. فاحنا ننتظر منكم اذا فيه يعني تفنيد لهالجزئيات، احنا بنساعدكم فيها باذن الله من جانبنا. شكرا لكم.
شكرا جزيلا.
دكتور، اول شيء الله يعطيكم العافيه. سبحان الله، يعني الدكتور احمد ذكر الشيء اللي بخاطري وكنت بقوله، وسبحان الله يعني طلعت الافكار وحده، والدكتور محمد يعني اضفت للفكره برضو الشيء الكثير، والدكتور علي انا كتبت ملاحظه بالجوال قبل لا اجلس يعني. سبحان الله، موضوع الدبلومات، وانا فعليا شفت انها موجوده في بعض الدول مثل امريكا، ومثل ما تفضلت مو بالضروره تكون للتكنيشن، ممكن شخص مع بكالوريوس يحتاج يكون مع دبلوم في شيء معين. صح، غالبيه الناس لما يحصل على مؤهل اعلى يفكر بالموتيفيشن، الامور الماليه انها تكون موجوده، ولكن في جزء كبير من الناس يفكر كيف يحصل على دبلوم وعلى تخصص جديد ويكون عنده يعني شيء مميز فيه ويقدر يعمل فيه. في بعض الاشياء دكتور محمد مثل الانتي ميكروبيال ستورشيب، ان الحمد لله تدربنا عليه قبل لا نبدا البرنامج، تدريب جدا ممتاز. لكن انا اتكلم عن نفسي، لو كان معي دبلوم في الانتي ميكروبيال كان بيفرق معي شيء كبير. على سبيل المثال البي تي اي لو كان في دبلوم تبن، اتوقع الخيارات كثيره، وباذن الله نطلع من الجلسه هذه بمقترح جديد. يعطيكم العافيه.
وانا ودي اضيف نقطه مهمه. انا اعتقد دور الجمعيات النون جفرمنت اورجنايزيشنز، الجمعيات العلمية والجمعيات المتخصصة دورها كبير. يعني احنا وي ترايد في جمعياتنا الجمعية السعودية للصيدلة الكلينيكية تو كلوز سم جاب موجودة في الكلينيكال فارماسيست. سوينا سيرتيفيكيشن بروجرام، المؤتمر هذا اعلنا عن الام تي ام، وانتم اعلنتوا عن الام تي ام، الان قاعدين ياخذون يعني محاضرات عنه كثيوريتيكال. eventually hopefully ان شاء الله بيصير فيها اعتماد من هيئة التخصصات الصحية، وبعدين يطلع كسيرتيفيكيشن بروجرام. عندنا اوريدي الفاكسينيشن سيرتيفيكيشن بروجرام جاي ان شاء الله. ستيرل ايوه، انا اعتقد انه this is very important انه يكون عندنا دور للجمعيات. الان ما شاء الله عندنا ترى 5 جمعيات متخصصه في الصيدله، مو زي اول، يعني مختلفه، متخصصه بتخصصات مختلفه، لكن اعتقد كل منها المفروض يقدم دورات سيرتيفيكيشن بروجرامز، ما هو دوره تنتهي باعطاء شهاده مكتوب فيها حضر الدوره هذه.
دكتور محمد، بس دام المجال ما زال في التدريب، الزملاء اسهبوا في موضوع التكنيشن، ولكن حتى كمان الكلينيكال فارماسيست، خصوصا البوست جراجويشن كلينيكال فارماسيست، احيانا لما يجي يحتاج انه يتدرب في مستشفيات اكسبيرتس ولهم باع طويل في الكلينيكال فارماسي، حتى لو كان لمده شهر شهرين از كلينيكال براكتس عندهم. فطبعا احنا نقدر نحل الموضوع هذا وديا مع بعض الزملاء، ولكن تعرف الموضوع هذا يحتاج له وقت طويل. فلو يكون فيه برنامج تعاون مثلا بين مستشفيات وزاره الصحه، او اذا احتاجنا، احنا ما شاء الله عندنا مستشفيات وزاره الصحه مثل مدينه المكفات الطبيه فيها زملاء، ومدينه الملك سعود، ولكن لو احتاجنا كمان في بعض يكون في مثلا باثوي واضح اني انا اقدر مثلا اخاطبهم مباشره، فيتم ارسال الكلينيكال فارماسيست وياخذ روتيشنز لمده شهر شهرين واتيفر يعني يتحدد معهم. فهذه من النقاط اللي صراحه مهمه لنا ككلينيكال فارماسيست. يعني احيانا في كيسز كثير ما نشوفها في المستشفيات، بينما في المستشفيات الثانيه حتكون موجوده.
طيب دكتور عبد المجيد، احنا معنا الان مديرة الموارد البشرية والاستقطاب، ودنا الان نسألها. الدكاترة كلهم عرضوا لنا محاضرات، قالوا عندنا نقص شديد جدا في الصيادلة، وانا اتحداهم، قلت لهم ترى لو رحت سالتوا اي مدير صيدليه في العالم مو بس في المملكه هيقول لك انا عندي نقص وانا محتاج. بناء على ايش يتم تحديد معايير؟ هل مثلا بعض الناس يجي يقول والله يا اخي اطلب 100 موظف هيعطوك 20، هيوافقوا لك على 20. ايش المعايير اللي في الموارد البشريه بيعتمد عليها اختيار او تحديد عدد الموظفين او الصيادله اللي بيكونوا موجودين؟ تفضل يا دكتور.
يعطيكم العافيه جميعا. بخصوص الاحتياج، دائما في احتياج متزايد للكادر الصحي بشكل عام. بخصوص المعايير، دائما المعايير تحدد على معيارين اساسيه، اللي هو الاحتياج اللي موجود فعلا، الصيادله اللي موجود، والسعه السريريه اللي موجوده في كل مستشفى على حسب الفئات حقتها. والاحتياجين هذول يتحددون من ادارات كبيره اللي هي اداره المستشفيات بالسعه السريريه، في الاحتياج واحنا نوفر. بس الشيء الايجابي في الموضوع انه كصياده موجودين. في اخر سنه احنا لما طرحنا اعلان كان موجود، كان نسبه اللي شغال فيها كان بنسبه 25% من الاجمالي، فهذا يعتبر مؤشر جدا ايجابي. نرجع نقول الاحتياج ما زال مستمر، ما نقدر يعني نغطيه في يوم وليله.
شكرا جزيلا، تسلم. أعتقد الآن due للوقت we will open it for we will open the questions for the audience, please.
Hi, I'm Professor Ahmed from King Saud University, and also the RPD for the residency programs. My question is, how do we define a clinical pharmacist? Because I'm seeing in a screen that most of the presentation, they said we are lacking clinical pharmacists. Now, how do we define clinical pharmacists? Our programs as PharmD is a clinical pharmacist program, and yet we are saying that we don't have enough clinical pharmacists. How do we define clinical pharmacists and use them as in a clinical sense, because they are working with us, and we can overcome these shortages by training them, because our residency program is very limited. The numbers are very limited. Even though you go for years and years, we might not be able to fulfill the hospital requirement. The question is, how do we define clinical pharmacists? And if it is a clinical pharmacist that we are graduating, then we have to use them as a clinical pharmacist, and in each hospital should develop a program to train their own pharmacists into more developed clinical pharmacists and utilize them. Even I run the program, and a lot of the time we have a pharmacist, just the intern residents, we encourage them to be clinical, and if you guide them properly, most likely they will be very successful. So we can overcome with this difficulty we call clinical pharmacists, we have shortages of. We have a solution for it. Are we ready for a solution?
Thank you, Doctor. And I believe this question is directed to Dr. Ahmed Al-Judea.
طيب, Prof. Might, I would say thank you very much for your question. And I might differ with you on the definition of clinical pharmacists. We're guided by two things here in the kingdom. One is the classification of Saudi Commission for clinical pharmacists. Anyone who is not classified as a clinical pharmacist, we cannot give them the privileges and responsibilities of a clinical pharmacist in the health care settings. Saudi Commission now qualifies or classifies pharmacists as clinical pharmacists if they complete PGY1 or if they complete a master program in clinical pharmacy with at least 6 months of hands-on training or clerkships or training within the program. Or if they finish the Saudi board, which is, as you know, you're a residency program director of internal medicine, and you know this, if they complete the 3 years program, which is called the Saudi Specialty Board in Clinical Pharmacy. So this is from legal perspective. Graduate from the best school in the US from a PharmD program and give them clinical pharmacist responsibilities and duties. Yes, they will be more prepared to be clinically oriented, more prepared in clinical settings than pharmacists who graduated from the bachelor degree, just because they took certain courses, more courses in clinical pharmacy, pharmacotherapy, as well as having more rotations in clinical settings. But this does not qualify them to be clinical pharmacists. Honestly, I cannot take somebody from King Saud University, ولا from UCSF, and put them in my ICU and tell them, okay, you are now the clinical pharmacist in the ICU, okay? Same thing if I put them in surgery or medicine. If I put them in any specialty, I cannot give them this because it's not safe, number one. It's not in the best interest of our patients. Now, does pharmacists who graduate from the PharmD program, are they more qualified in terms of preparedness to be clinical pharmacists in the future? Yes, absolutely. But they are not called clinical pharmacists. We do have actually, we issued a position statement from the Saudi Society of Clinical Pharmacy warning about this particular issue. And we said clinical pharmacists should only be those who received postgraduate training as per the Saudi regulations currently set by the Saudi Commission. And this should be applied everywhere. And if I take somebody from King Saud University, I will be mandated to take somebody from a school of pharmacy that just graduated PharmD graduates who did no rotations whatsoever. And you know the quality of some graduates or some schools where they do the rotation in the office of their preceptor, who is not even a clinical pharmacist. Let's face it. They all graduate with a PharmD degree. And they will come all and say, I want to be clinical pharmacist. Why do you treat KSU or King Abdulaziz or King Saud, whatever, differently? That's why we do have requirements for postgraduates. It's very similar to our colleagues in medicine and others.
And, Dr. Might, just one, sure.
Everybody who just graduate and put them in an ICU setting and all. When we talk about the clinical pharmacists, in US, if you graduate from a pharmacy school and if you got license to practice, you already a clinical pharmacist. Why? Because it is a program called PharmD, Doctor in Pharmacy. Here we are misleading of saying that individuals graduate, that we are graduating PharmD, yet we are giving out the bachelor degree. So I'm talking about the differentiation between PharmD, I'm talking about graduate. Once you have that in United States, yes, you will not put them in an ICU and special areas, but generally they are practicing. They are rounding, they are doing both work, part clinical and part dispensing. It is part of their workload anyway. So there's a 30%, 70%, and there's a lot of ratios that they go through it. I'm not going into very detail of those things, but I'm just asking that since we have a pharmacist who are qualified, quote unquote, and then if you have a difficulty getting into the residency program, why not we train them a little bit more in advance and utilize them until you overcome all your difficulties that right now you are ranking. This is the first place we are ranking pharmacists, like, you know, in a different ranking. In the United States, we don't have ranking, just you have a license to practice, and then later on you have a diploma, and they will decide where you want to work and how they're going to employ you. Thank you very much.
طيب,
Thank you,
Mohammed,
Dr.
if you
Anay.
allow me, in 30 seconds. By the way, and I did not mean that those pharmacists who are licensed pharmacists do not have clinical duties, okay? This is different than calling somebody a clinical pharmacy specialist or clinical pharmacist. All pharmacists have clinical duties because we are clinicians by default, but this doesn't mean that you are 100% doing clinical pharmacy work, which means rounding with the team, providing therapeutic recommendations, adjusting levels and seeing patients in clinics and doing parenteral nutrition prescriptions and changing orders. That's different. So again, yes, they do have clinical responsibilities. If we utilize them in things like medication reconciliation, for example, in medication counseling, in standardized dosing adjustment in renal failure. Absolutely, I'm 100% with this. But the reality of, the reality is that this is the situation in Saudi Arabia. They are classified according to their specialty, and that's why we have PGY1 to graduate general clinical pharmacists. And that's why we have PGY2 to graduate specialist clinical pharmacists.
One of the most good things in IHOP 2022, that it's opening new discussions and debates. I believe in the next clinical or Saudi Society for Clinical Pharmacy conference that they can discuss in more details. So I am not clinical, however, I totally agree with Dr. Ahmed. Clinical duties are given our pharmacists. Even not a PharmD degree graduates, even for a bachelor degree graduates, they are given clinical duties. Part of them, even they are participating in our antimicrobial stewardship programs, and they are doing a great. They are taking. We are giving them a special training, and they are doing a great job, by the way, in this. Can we take one more question, please? No? Quick question, please. Thank you.
ما نسمع. ما
Okay, just it is a time to change the KPI for the clinical pharmacist. And do you think that the number of interventions or antimicrobial stewardship KPI or metric, it is a real reflect the role of the clinical pharmacist in our institutions? Because sometimes, you see a law, it has become like a racing and a competition between the hospitals, which hospital is going to have more number of interventions. However, when you go to the real practice, the real world, you find that the number of interventions is not reflected the role of the clinical pharmacist. And also you heard that a lot of the hospital has antimicrobial stewardships. But when you go there, you will find that the resistance is increased, consumption is increased, cost is increased. So do you think it is time to have a targetable KPI for performance of the clinical pharmacist? Or we are happy with
Thank you. It's a great question. But if you allow me and allow me, our distinguished speakers and guest of honors, this is not the topic of the roundtable. It's a very important question. However, that I don't believe that we have a lot of answers. We have a lot of KPIs that we can show it to you, especially for the antimicrobial stewardship, the antibiograms, and how can we collect this data from clinical pharmacists. So I will take a long period of time. However, that this is the roadmap for equal distribution of resources and manpower only. This is a specialized question for clinical pharmacists. So please accept my apology.
It is fine.
That we will forward and we will take it in our consideration. in IHOP, and I promise you that we will answer this question either outside this round table or later on,
I
inshallah.
totally accept that, but why I asked this question, because that I think so this is a undergo the definition of the clinical pharmacist, so that's why I put those questions.
Thank you.
Abu Ahmed, in our last conference, the Saudi Society of Clinical Pharmacy conference in September, we had a full session about this particular question. And I promise you, that was about 2 or 3 months ago. Promise you, next September, we'll also gonna address it. So
Thank you so
stay
much.
tuned.
طيب, it's by this we will conclude our round table. Thanks for our great speakers. Thanks for our guest of honors, our great speakers. Thank you. And by the way, this is from Oman, our colleagues in Oman Pharmaceutical Society. They insisted that you have to take the Omani sweets on the stage. So thank you.
ألف شكر لهم.
شكرا جزيلا our distinguished speakers. انتوا هتنزلوا. Our guests of honor will remain on the stage. And please welcome with me Dr. Abdulaziz Al Hassan. He's the director of pharmaceutical care in King Saud University Hospital. And he's our specialized ambulatory clinical pharmacist. Please join our guest of honors. Please welcome with me Dr. Abdulaziz. And I believe she's the first ambulatory specialized clinical pharmacist in the kingdom. Please welcome with me Dr. Ghada Bawazir, and she will be our guest of honor as well. Dr. Ghada. This is her bag, so we can take her money until she will come. Okay. So, with the same consequence, our second topic in the round table will be talking about ambulatory care clinical practice advancement, roadmap to meeting national demand and achieving the Saudi Vision 2030. With the same strategy, we will give the chance to our ambulatory specialized clinical pharmacists in order to present their issues and their challenges and their recommendations for solutions. And we will have our guests of honor and our decision makers here, so they will be helping in finding solutions in order to, I know that I passed إعلان جوائز.
جائزة الجمهور عشان كذا ما
Before asking the presenters to join us, we have a gift for our attendees. The camera will choose the lucky person.
يس الحين عندنا جائزة الجمهور اللي هو الكاميرا راح تختار شخص عشوائي من الموجودين بإذن الله. فجود لك لكم كلكم. ألف مبروك.
Our first distinguished speaker, Dr. Abu Bakr Omar. He's a Saudi Commission for Health Specialties, Clinical Science Examination Committee member for Saudi Pharmacy National Command Control Center, Ministry of Health, Saudi Arabia, specialist in poison information, senior specialist, King Saud Medical City, Riyadh, Saudi Arabia. Please welcome with me my friend and my colleague, Dr. Abu Bakr Omar.
Thank you very much, Dr. Muhammad, for this nice introduction. Assalamu alaikum wa rahmatullahi wa barakatuh. Here I come again on this stage. But for now, inshallah, I'm one of many of my colleagues who are going to present on a very specific topic. We're hoping by delivering this kind of time roundtable to achieve what we look for, which is a drawing roadmap to eliminate all the challenges and barriers the ambulatory care advancements and practice to meet the national demand for achieving the goals of the Saudi Vision 2030. So to start with, very briefly, I myself, along with one of my friends and colleagues, Dr. Fahad Al-Dosari, run the Endocrine Medication Therapy Management Clinic. And that was started last February. And during this clinic, we received referrals under collaborative practice agreement on all these conditions, which are all fall underneath the umbrella of endocrine specialty. So far, we've managed patients with these conditions. Alhamdulillah, we were able to see patients 4 days a week, with the exception on Monday. And so our clinic run on the evening clinics, along with all endocrinology clinics. So whenever the endocrinology clinics are running, we run with them. We have one specialty clinic on Tuesday, and starts on 7 p.m. for insulin technology or insulin pumps, and we started expanding the diabetes technology patients who are using CGMs and insulin pumps with different models. So far, this gives you an idea of how many patients we've seen in the clinic so far, month by month, and then on the right side, a cumulative number of patients. Alhamdulillah, as of last November, we've seen more than 1,229 patients in our clinic. And this kind of cumulative graph with an increased number of patients being referred to us for management gives you an indicator of two things. We've gained the respect and the trust of the healthcare providers. Number two is the need for our involvement in such practice. This gives you an idea of how many prescriptions we've sent and the number of medications we've sent, both electronically through Wasfati portal or within our healthcare system, which is the HIS, with the exclusion of November because it takes some time to extract these data. But so far, within almost 8 months span, we've prescribed and renewed 1,614 medications. So during the establishment and since we started the clinic, we've had our prescribing renewal privilege granted. Same goes for medication initiation, medication discontinuation. We've had full privilege of dose titration and adjustment. We've been granted to do or to order laboratory investigation orders and making follow-up appointments. What are we really lacking in comparison with our practice back in the United States when we were doing our residency is the medical liability insurance. And so whatever practice we're pushing for to achieve the clinical goals or the strategic goals of the Saudi Vision 2030, which we can involve in the strategic goal of number 1 and 2, we're lacking the protection. So we're performing our work, we're seeing our patients, we're contributing to optimal care, but we're not being backed up in case of human error occurrence. We also are lacking point-of-care devices, so These are the needed supports that we're looking for. We've faced a couple of barriers when establishing this kind of wonderful service. The first of them is the establishment of the concept of independent clinical pharmacist clinic. So many of the physicians, they did not understand what are our scope of practice, what can we do, what we can't do. The second of all is being granted the prescribing privilege needed for successful clinic model, because in order to get a prescribing privilege, you'll be tagged with questions like, why do you want to prescribe medications? Who are you to prescribe medications? We are only physicians who are authorized to prescribe. And we've had a difficult time writing conclusive collaborative practice agreement, which, alhamdulillah, enabled us to independently practice at King Saud Medical City. What I'm here today proposing as solutions for myself, for any others to pursue this kind of practice, and for the advancement of clinical ambulatory care clinical pharmacy practice, is appealing to decision makers to grant highly trained clinical pharmacists some, or limited even, prescribing privilege. We're also, I'm right here on this stage appealing to establish a national CPA, Collaborative Practice Agreement, to enable clinical pharmacists in all different specialties to provide optimal care to our patients. And as you saw, the numbers can tell you how much this service is needed in all different specialties. I'm appealing to MOH, Minister of Health, to provide medical liability insurance for the expansion of ambulatory care clinical pharmacy services as well. And so thank you very much for this. I'm going to leave it for my other colleagues to present their practices.
Shukran. Thank you, Dr. Abu Bakr. Our next speaker, he graduated from King Saud University in 2015 with a PharmD degree. He is now a solid organ transplant clinical pharmacist in King Saud Medical City, Ministry of Health, Riyadh. Please welcome with me Dr. Misfer Al-Ghamdi.
Assalamu alaikum. Good evening, everyone. First of all, I would like to thank the organizing committee for giving me this opportunity to discuss the progress of the kidney transplant medication therapy management clinic. So, the reasons why we established this clinic, first of all, King Saud Medical City considered the only hospital in the Ministry of Health following up patients, transplant patients who did their transplantation outside the kingdom. The second main reason, the study demonstrated the crucial role of the clinical pharmacist and the positive impact of the transplant clinical pharmacist. And majority of the complications for the transplant patients is related to the immunosuppressant. Therefore, it's a crucial of the clinical pharmacist to be involved with the multidisciplinary team. Okay. The kidney transplant medication therapy management clinic runs daily except Thursday. We have up to 100 patients monthly. We are guaranteed to see the patient's appointment so we can know when the patient is coming to the next visit, as well as we can review the medication or medical record so you can see the patient history, labs, medications, as well as cultures. We have the privilege to document our interventions in the medical therapy. So this chart represents the different type of interventions that have been made in the first 6 months of 2022. As well as the approval of requested order under a physician supervision. And I believe we had an excellent acceptance of approval of our recommendations up to 98%. One of main role as a clinical pharmacist to do counseling to patients, family, as well as to the relatives, as well as reporting the medication errors and ADRs. One of the most important things that we are doing in the clinic, doing the medication adherence by reducing the high bill burden, minimizing the adverse effect, as well as to do the appropriate counseling. What we need manpower helping with the primary clinical pharmacist so he can cover during the vacations of days and to maintain an appropriate service without any interruptions. Also, I believe it's good to have laboratory test ordering. So sometimes there are some of the tests that is not routinely ordered, such as liver function test, thyroid function test, A1C, and so on. So the barrier during running the service, previously we used to dispense the medication, specifically the immunosuppressant from our pharmacy. However, now WASFATI system is introduced. So during the counseling, we noticed that some patients has a duplicate medication, so same active ingredient, however, from 2 different companies. And some pharmacists in the community pharmacy, they are completing the dose from 2 different companies. So for example, 1.5 milligram tacrolimus, the strength of 1 milligram from company A and 0.5 from company B. So this is a huge issue that we are facing, especially for the narrow therapeutic index and the switching between the brand and generic and vice versa. Also, one of the barriers, which is going back and forth to the patient clinic to explain some certain medications and complex medications. One of the obstacles was the distance of the clinical pharmacist clinic was far away from the physician clinic. However, now it's next to each other and the problem is solved. So my proposed solution for all of these, hiring transplant clinical pharmacists, or we can train BGY1 clinical pharmacists, establishing a national solid organ transplant specific CPA, collaborative practice agreement, to enhance the role of the clinical pharmacist in such practice, as well as to have access to WASFATI. So at least we can see the medication list, or if we have CPA, we can prescribe through WASFATI. Thank you so much, and this is what I have.
Thank you, Dr. Misfer. Our next speaker, Dr. Yahya Mahzari. He's an infectious disease specialist, clinical pharmacist at King Saud Medical City. He got his fellowship PGY2 infectious disease from King Faisal Specialist Hospital and Research Center in 2011. He has an American Academy of HIV Medicine 2021, Antimicrobial Stewardship Certification, Society of Infectious Disease Pharmacist 2018. He graduated in 2015 from Al-Ma'rifa with a PharmD degree. Please welcome with me Dr. Yahya Mahzari.
يعطيك العافية دكتور محمد. First of all, السلام عليكم. أسعد الله مساكم جميعا. I'm so happy today to be here and talk about my journey for establishing the HIV clinic. 2022, I came back from my journey for BGY2 ID training from the King Faisal Specialty Hospitals. And HIV outpatient there, it was a longitudinal experience. And I was so excited about that because I saw the value of the HIV clinic when it is run by the clinical pharmacists in optimizing the patient care for HIV patient. So I bought this in myself. When I get back to my hospital, I'm going to implement the HIV clinic there. First of all, it is a CBA clinic for HIV. The proposals, it was 1 day per week. That means 20 patients per day. That means total 80 patients per month. We wrote the proposals, and that proposal was contained requirement and demand for sustainable HIV clinics. What we get right now, access to the patient list and their medical records, ability to refill antiretroviral, modify antiretroviral, and other needed medications. What we need and looking for, inshallah, we will get it, clinic equipped, authority to access, order necessary lab tests, also to view the radiological report, prescribe recommended vaccine as needed, access to WASFATI, free hand to take the full care for patient regarding other medical care, for example, refer to patient to other specialty. As we know, it is a multidisciplinary management. As anything that we started, there is some barrier, and we should accept that. This is a part of the journey, and inshallah, we are going to overcome this barrier soon. The barrier that we face is the space, manpower. As we know that one hand cannot clapping, so manpower is necessary to sustain that HIV clinic. Assessment of patient medical file, and that is due to the semi-electronic system. However, inshallah, soon we are going to get the electronic system. Lack of understanding of vital role of the clinical pharmacists among the healthcare providers, and inshallah, with a lot of awareness, we are going to overcome this one. If you allow me, I'm going to present some humble solution to overcome these obstacles, like infrastructures, qualified manpower, full electronic system, awareness among the healthcare provider regarding the vital role of the clinical pharmacists when it's come to deal with patients living with HIV. Thank you so much.
Thank you, Dr. Yahya. Our next speaker, he graduated from University of Hail in 2018 with a PharmD degree. He completed his residency specialty in 2021 from the Saudi Commission, and he got his board certification 2021. He's an American Board of Pharmacy Specialties, and he's now is the Regional Director of Pharmaceutical Care Services, Hail Health Cluster, Ministry of Health, Hail. Please welcome with me Dr. Ali Faris Al-Tibinawi.
Assalamu alaikum, good afternoon again. I will talk inshallah about our experience in King Salman Specialist Hospital in Hail region. We have 4 clinics run by clinical pharmacists. Started with the first one is the diabetes clinic. It's run from 8:30 to 12 p.m. and for 2 days, Sunday and Tuesday. The estimated number of patients per month, you can see 100 patients. This clinic unfortunately has been suspended or halted because the clinical pharmacists who run this clinic transferred to another institution. The other clinic is anticoagulation clinic. By the way, we have published one article in American Journal of Clinical Pharmacy, JACOB. We have wrote our experience as an international report there. The next clinic is anticoagulation clinic as well, run by 2 clinical pharmacists. It started from 8:30 to up to 12 p.m. and we have exceed or add another clinic for afternoon because the number of patients has been increased. The third clinic, familial hypercholesteremia, FH clinic. This clinic has been run in collaboration with another physician. So 1 week, this clinic will be covered by consultant cardiologist and 1 week by clinical pharmacist. The last clinic is medication therapy management clinic, MTM clinic. This clinic has been started and launched recently last week. So the privilege, we have used the same collaborative practice agreement and the same prescribing privilege from our previous clinic, which is the diabetes clinic. So we have guaranteed the labs order, prescribing as well, referral to other specialties and clinics. Also, we have a lot of privilege such as counseling, adherence, education, and others. We have seen some obstacle during or from the beginning to establish those clinics. So there was no clear statement that authorized clinical pharmacist from ordering lab and prescribing. This barriers has been solved partially, let's say, by the collaborative practice agreement and the prescribing privilege. The second obstacle is a huge number of patients. So we need to increase the seat of residency, and we need to increase the job for a clinical pharmacist position. So long waiting list as well, limited number of clinical pharmacists. We would like to healthcare professions لائحة مزاولة المهن الصحية to increase as well the number of residency seats to prepare and approve, as Dr. Abu Bakr mentioned, a national collaborative practice agreement or new protocols for pharmacist-led clinics. Finally, to release new professional certificates from national societies such as Saudi Society of Clinical Pharmacy, and one recommendation and maybe question. So I would to utilize the PharmDs if our pharmaceutical services allow. We would like to authorize the PharmDs from covering such type of clinics such as MTM clinic with more professional certificate and continuous education. Thank you.
شكرا جزيلا دكتور علي. Our last but not least, she's an internal medicine clinical pharmacist in Prince Mohammed bin Abdulaziz Hospital. She got her bachelor degree in pharmaceutical science from King Saud University in 2008 and got her master science in clinical pharmacy from Riyadh Al Ilm University in 2020. And she completed her PharmD certification from Riyadh Al Ilm University in 2020. Please welcome with me Dr. Wajd Al-Shammari.
Assalamu alaikum. First, I want to thank give me the opportunity to be here today. In the Prince Mohammed bin Abdulaziz, we have two clinical specialty in outpatients. We have heart failure clinic and anticoagulations clinic. For heart failure clinic, we established nearly before 1 year after the COVID. We lost a lot of the patients in heart failure clinic with the physicians, and we start to open the heart failure guided by the clinical pharmacist. We have only one day per week, only 4 hours per week for heart failure clinic. And for anticoagulant clinic, we have 2 days per week. For the estimated number of heart failure patients, 48 per month. And for anticoagulant clinic, 100 patients per month. For our clinical pharmacists, we have the prescribing privilege, and we have referral, and we can order the medications and lab for the patients. And only we need to increase the number of the clinical pharmacists, because for heart failure only we have 2 clinical pharmacists covering this clinic. And we need more healthcare staff and resource to guiding this clinic. And for the barrier, before we have clinical pharmacist rule and privilege, and we have no clear referral request to the clinic, and limited number of the healthcare worker. For the proposed solutions, we're developing the ambulatory care clinic program in the hospitals, and developing the clinical under the directions of the clinical pharmacists, and we need more manpower. Thank you.
Thank you, Doctora. I'll start questions. Dr. Judea, I believe there is a lot of opportunities for the Saudi Society of Clinical Pharmacy to help in. For example, Dr. Mesfer, he mentioned hiring of specialized transplant clinical pharmacists. Correct me, are they in the whole kingdom? I believe they are less than 10 specialized clinical pharmacists in transplant. How can we help in improving this, Dr. Judea?
Okay, so...
by the way, sorry, Dr. Judea here now as the founder and the chairman of the Saudi Society of Clinical Pharmacy, not as the assistant deputy minister. So his hat is changed in the same seat.
طيب, so أنا will wear the hat of the SSCP, but also as a practitioner myself. I think there are 2 ways that we could help address this particular issue. Number 1 is by advocating as a society, specialty society or a scientific society. We advocate for specialized training of clinical pharmacists in all different specialties. We also publish our position statements. We have already published 2 currently. One on the roles, responsibilities, and areas of practice. Or the first one is roles or definition, roles or responsibilities of clinical pharmacists. The second one was about the areas of practice of clinical pharmacists. And our pharmacist specialty networks, they actually published different ones. We published already one for infectious disease, critical care, internal medicine, and more to come. So and I actually call for all other specialties. We were looking for different specialties. Unfortunately, this year only 2 specialties were added because we didn't have enough people to serve in the board of the specialty. One of them was organ transplant. Currently, we have pediatrics, the extra one, the new ones, pediatrics, medication safety and use, medication use and safety, PSN, or Pharmacy Specialty Network. The second thing, so working as an advocate to the profession and to the practitioner is number one. Number two, as a practitioner myself, I started the first specialized clinic, pharmacy-run clinic, more than 20 years ago. And it's still ongoing, but we maintained it by training more people. And Mr. was about to be one of our residents at King Faisal, but he preferred National Guard, so we'll take this against him anyway. And we continued to train more specialized residents in order to create more clinics and to expand in the clinic coverage as well. And currently we have more than one specialty within the organ transplant, let alone other clinics, including transition of care, anticoagulation, heart failure, and HIV and others. So my advice is you really have to capitalize on human resources by providing them the appropriate training through the specialized residency training in order for them to be able to help you in the future. And when I started organ transplant clinic, I was alone. And I actually staffed in this clinic for 10 years alone, until the second transplant clinical pharmacist came and helped me. So I think it's never too late. You can always open a residency program. You can always hire from those who graduate. And you can also collaborate with other centers that have good practices or good practice settings. As a society, the society doesn't have jurisdiction on enforcement of laws or regulations. It's mainly advisory, scientific, and works in an advocate manner, and that's what we have been doing. However, we have been offering certification programs such as MTM, for example, that we just talked about, for those clinical pharmacists, general clinical pharmacists who would like, مثلا PGY1 graduates who would like to be trained and certified as MTM providers. And this is inshallah going to be approved soon by the Saudi Commission, hopefully. And then we'll have the official, now it's approved by you guys, the Ministry of Health. And we're waiting for the Saudi Commission for, inshallah, their approval. And at that time, we'll have the accreditation or the approval of two regulators. And this will help train those who can work as MTM providers in MTM clinics.
شكرا جزيلا دكتور. دكتور الفهيد, a lot of people, they are getting acceptance from the Saudi Commission for health specialties. What are you really doing for such people? Do we have a limited number of seats that we can accept them from the Ministry of Health especially to go and attend those programs? Or it's open?
You mean for a Saudi Commission program?
Yes.
Actually, we have no limits at all. If you get accepted, you'll get the approval straightforward. And this is one of our, main focus is to build on this kind of courses in our training centers, not only in the Ministry of Health, but all over the kingdom, So it's our duty to support these training centers and to facilitate training within certain areas also. Focusing on expanding these centers also because we have a national duty as well. So if you get accepted, then you will be having this kind of sponsorship from the Ministry of Health. Specifically talking about Saudi Commission programs, whether are you a pharmacist or allied health or physician, you will be sponsored straightforward.
So you need just only to get the acceptance and pass the requirement of the Saudi Commission. Once you got the acceptance, no restrictions, you will be sponsored.
Absolutely. We still have some, admin regulations, which is obviously have been met by the applicants itself. The demand and the needs, and we don't block the way for our, colleagues who are keen to proceed with their, career or even with their education. Yeah.
Well, I can testify to this, okay, myself. I don't remember any rejection came from our colleagues in scholarship and training for any program under the Saudi Commission, any residency or diploma program, because once the paper or documentations are complete. So if you have complete documentation or you submit them on time, طبعا ما هو after deadline, I don't remember any rejection. يعني ما في rejection because والله ما عندنا budget ولا because there is no need, and I can testify to this.
Also, he is testifying this because he is vice president of scholarship committee. This is still a secret to be exposed today.
This is the third hat.
He is one of the supporters of yeah, actually, this is the truth. Have to be, clear for everyone here in this room that Dr. Ahmed Al-Judai is one of the most advocates for pharmacology practice, and this is not my personal view only, because I'm aware of many efforts that have been taken place in previous years, and he's supporting, the residency program even outside the Saudi Arabia. Trying to invest the opportunities, linking us to certain institutions there within Saudi Arabia or outside Saudi Arabia. So I would say, request the audience a round of applause for Dr. Ahmed Al-Judai.
Thank you.
شكرا جزيلا. Just an announcement for everybody. After this round, the top 5 universities in the patient counseling competition will be announced. So please be here after this round. أستاذة مشاعل, one of the requirement ذكرت عدم وجود insurance على الكلينيكال فارماسيست اللي بيشتغل. هل فعلا ما في تأمين صحي على الموظفين أو على الممارسين الصحيين؟
هو فعلا لما يتصنف الممارس الصحي ملزم أنه هو يكون يغطي التأمين، يكون من متطلبات مزاولة المهنة أن يكون هناك في تأمين بحيث يكون هو يستطيع ويكون التأمين يغطي الأخطاء الطبية. وفي إجراءات كثيرة ومشددة قاعدة تصدر من الوكالة بحيث يكون هناك التأمين إلزامي، بحيث إذا ما قدر يتغطي التأمين الأخطاء الطبية تكون من مسؤولية المنشأة نفسها.
بس أعتقد كان في صدر مرسوم بالتأمين على كل الممارسين الصحيين اللي في المملكة.
صحيح.
هذا هيبدأ يعني يمكن صدر مؤخرا، هيبدأ تنفيذه خلال الفترات القادمة.
صحيح، ما زالت التنظيمات موجودة يعني.
طيب سؤال، أنا ودي أعرف، يعني أعتقد السؤال هذا عند الناس كثيرين هنا. أنا متأكد إنه الموارد البشرية أو HR أو التوظيف ما في أحد بيسألهم إلا ويقول لهم إحنا نبغى موظفين. كيف بتتعاملوا مع الناس هذا؟ كيف تحطوا الأولويات عندكم؟
يعني مثلا هل بتبدأوا بأطباء الأسنان ولا بتبدأوا بأطباء الطوارئ ولا بتبدأوا بالصيادلة ولا بتبدأوا بالتمريض؟ كيف الأولويات بتكون موجودة عند التوظيف والاستقطاب؟
طبعا لا يخفيكم علما أنه الخدمات الصحية اللي موجودة في ازدياد وتوسع، وبرضا كمان الساعات السريرية قاعدة تزداد. فتحديد الأولويات كان له أولويات كثيرة بخصوص الحالات والجواب. مثلا على سبيل المثال الجائحة اللي صارت الكورونا، كانت في إعادة ترتيب الأولويات اللي موجودة، ومن ضمنها كان العلاج التنفسي. كان في طلب كثير على أخصائي علاج تنفسي، فدائما الاحتياج يكون بناء على أكثر من معيار زي ما حكينا في البداية، اللي هي الخدمة، توسعات الخدمة اللي موجودة، الساعات السريرية اللي موجودة. فبناء عليها ومرئيات اللي موجودة احنا نضع خططنا وأولوياتنا على الاحتياج الموجود ده.
شكرا جزيلا. دكتور عبد العزيز، عدم وجود كادر في المستشفيات للتدريب للريزيدنسي، هل هذا يعني انه الجامعات يجب ان هي تقوم بدور اكبر؟ يعني مثلا انا اجي اقول لك انا والله انا كنت صيدلي مثلا في مستشفى، يوم يجي يقول لك والله ريزيدنت بجيب لك ريزيدنتس عندك يتدرب، اقول والله انا ما عندي وقت ان انا اقعد ادربهم واقعد اجلس معهم. لكن لما تيجي تروح مثلا لاعضاء هيئه التدريس في الجامعات، ترى هذه شغلتهم، هي شغلتهم التعليم. كيف ممكن نوافق ما بين برامج اللي ممكن تقدمها الجامعات والبرامج اللي على أرض الواقع اللي بتقدمها الهيئة السعودية للتخصصات؟
طيب الله يعطيك العافية. Thank you دكتور. I think طبعا it's a very complicated question. يعني الجامعات هي جزء بسيط يمكن من برامج تدريبية الموجودة حاليا في المستشفيات السعودية. والاغلب البرامج يعني ما هي 90% من برامج الدراسات العليا سواء الريزيدنسي العامة ولا الريزيدنسي التخصصية مقدمة بواسطة مستشفيات مستقلة أو تابعة لوزارات مخصصة. أنا أعتقد أن الدور يعني مقام على كل الجهات سواء كانت مستشفيات أو جامعات. يمكن الزملاء ذكروا في البرزنتيشنز. I'm speaking in Arabic. I'm not sure if anyone will turn to English. As what we saw previously from our colleagues here who are leading now clinics, the major issue is not by having the problem is not maybe having many clinicians as the problem of having programs available. And يعني for anyone who is specialized in ambulatory care is very wide specialty. يعني ambulatory care, you can be an ID clinical pharmacist who is specialized or providing a clinic, as well as with many other specialties, HIV or like oncology or any other. فالprograms are there but not too many. Especially we only have one program of residency in ambulatory care if we are tackling ambulatory care. So what we want, and inshallah hopefully next year we'll have يعني program or two hopefully coming in ambulatory care. Role of I'll echo what Dr. Ahmed mentioned about collaborating with healthcare facilities or with universities. الجامعات مليئة ما شاء الله people who are trained but maybe not practicing for some reasons, maybe due to no access or maybe due to they are not willing to do so. But I think collaborating with these people who have this kind of training, and then they can provide either education or training or also service at this level, it's very important. I think one of the most important thing to come out of this meeting is to have a policy, a national-wide policy, either from MOH, from different bodies. I think the MOH should lead this kind of policy to regulate and to empower this kind of specialty. One more thing I think it's very important to highlight today is دكتورة مشاعل mentioned إن الأولويات حسب الحاجة. I think الambulatory care clinical pharmacist هم من آخر الأولويات في كثير من المستشفيات للأسف because they are المستشفيات أغلبهم ينظرون إلى critical care priority, infectious diseases priority, clinical pharmacist in outpatient there is no need at this time maybe later on. مع العلم أنهم لو عرفوا ولا شافوا الدراسات التي قاست تأثير الكلينيكال فارماسيست في الاوت بيشنت لكانت هي الفيرست بريورتي في أي مستشفى.
فعلا هو اللي بيقلل الادميشن تو ذا هوسبيتالز وما بيكون في حاجه للكريتيكال كير كلينيكال فارماسيست بعدها. مو ضد الكريتيكال كير كلينيكال فارماسيست. دكتوره كوميونتي فارماسي الان والامبيلاتوري بارت من الفيجن 2030 اشراك القطاع الخاص، وهذا ما بدأ. الشباب ما شاء الله عليهم كلهم ذكروا نظام وصفتي والبدء في نظام وصفتي. وصفتي مو بس فقط امر صرف من صيدليه كوميونتي، لا هو تحويل لكل البريفليج اللي كانت في المستشفيات الى القطاع الخاص بما فيها كلينكس والنيد للامبيلاتوري كلينيكال فارماسيست انه يكون موجود هناك. طبعا كان الكريتيكال كير كلينيكال فارماسيست دائما يقولوا لنا، يعني لما يشوفوا احد دخل الامبيلاتوري يقولوا والله هذا دخل عشان ما يبغى شفتات ويبغى يبعد عن الشغل 24 ساعه في الاي سي يوز. بورطهم في بعض انا. ف how can we plan ourselves؟ يعني احنا بنتكلم الان مثلا يعني ابسط شيء، بنتكلم عندنا حوالي 8500 صيدليه كوميونتي مجتمعيه في المملكه. Do we have a plan؟ يعني الشباب ما شاء الله في المستشفيات يقولوا نبغى 1 2، ما هم كثير يعني. Do we have a plan national wide to cover 8,500 community pharmacy with at least one ambulatory care clinical pharmacist to be there?
Thank you, Dr. Mohammed, and thank you for the conference, IHOP, for inviting me. طبعا سؤالك مرة متشعب، but أول حاجة بالنسبة للكوميونتي براكتس والامبولاتوري كير براكتس، one way زي ما قلتي دكتورة إنه موضوع وصفتي is only an order just to dispense the medication. If we want to look at the US experience بالنسبة لهم كان في عندهم حاجة اللي هي medication therapy management في السيفتي والefficacy of الهيلث كير نفسه. But this is one that's, if you want to point out who should do that, it's the Ministry of Health. That's when they have to expand or to at least mandate. أنا اللي عجبني في كل الكلام من بداية الدكتورة عبد المجيد إلى الدكتورة واجد، they all بلا استثناء they mention the problems and they mention the solutions. The solutions basically are three. It's the regulation, the education, and the facilitation to actually maintain and to actually support. So regulation-wise is again بما يخص التعليم، بما يخص الريزيدنسي، بما يخص التكنيشنز، بما يخص الريجوليشنز اللي هي صرف الأدوية، البريفليجز حق الفارماسيست، بما يخص all kind of regulation that you can consider that will affect a pharmacist practice at all levels. Education-wise زي ما تكلمنا على موضوع education والtraining والadvanced training BGY1 residency training للtechnicians courses compact courses whatever you want to call them. That's also another area we can have a focus on. And definitely موضوع support والfacilitation is the part for every institution بما فيها الgovernment طبعا to support this thing including طبعا insurance. ما عندنا حتى insurance but definitely insurance is another component that will also enforce موضوع إنه هل وصفتي هذه حتكون فقط مجرد dispensing ولا حيكون معاها حاجة زي medication therapy management، وبالتالي you will reimburse the pharmacist. You're going to see more of our students, our graduates go to the community. I think by this year we're going to have almost 3,000 students graduating from the colleges of pharmacies. يعني حتى الزملاء اللي كانوا بيتكلموا من حائل ومن ال other areas, you can see that every area has its own مش issues بس عندها ال deficiency أو ال need اللي يحتاجونه, but everybody agrees إنه we need technicians and we need pharmacists. We have a lot of students graduating. يعني 26 29 كلية whatever the number واصل إلى الآن, لكن we have enough manpower at least البذرة حقتهم that تحتاج somebody زي الدكتور الجديع لما تكلم في الافتتاح عن الدكتور سليمان السلامة. You're going to need somebody who actually push those to the community practice, but give them أول حاجة ال reimbursement مهمة جدا. money. Sorry, everybody is living in 2022. You need money, you need to live. But it's very important to improve their salary, their benefits مهمة جدا. Plus, the privileges is very important, and that comes from regulatory standpoint.
شكرا جزيلا. تسلم دكتورة. Now we will open the floor for questions, please. دكتور علي جاهز ماسك الميكروفون
الله يسعد قلبك دكتور.
تفضل.
Two direct question. السؤال الأول لل HR representative الأخت مشاعل والدكتور ممكن أحمد بخصوص التوظيف. يسألوننا كثير حنا من الصيادلة اللي عندنا بالمنطقة, في ناس خلصوا residency program يعني they are classified as a pharmacist 1 و consultant pharmacist, لكن إلى الآن ما في توظيف. هل الصلاحية التوظيف الآن انتقلت لنا عندنا بالتجمعات الصحية مثلا؟ عندكم إلى الآن متى بالضبط؟ يعني السؤال يخص الأرقام هذه, وإذا كان في أرقام للصيادلة البكالوريوس متى حنا نقدر نوظف عليهن؟ هل هي تبقى سنترال من الوزارة زي كل السنوات الماضية ولا راح تكون من عندنا؟ السؤال الثاني بخصوص الامبولاتري كير دكتور, كان وي يوتيلايزد الفارم دي, لاني اعرف انه في بعض الانستتيوشنز they run MTM clinic by PharmDs, يعني pharmacist bachelor degree with extensive training, يعني معها ممكن MTM professional certificate. هذه ممكن تحل وضع الشورتج اللي عندنا, لانه زي العيادات مثلا, او ممكن نطلع سب سبيشاليتي معين انه الانتي كواجوليشن كلينيك كان بي رن باي ذوز فارم ديز وذ تريننج, ولا يعني تقريبا ممكن العيادات اللي تكون سهله ادارتها زي الانتي كواجوليشن كلينيك. شكرا.
شكرا جزيلا استاذه مشاعل. طبعا هذا بيور كويستشن MOH ترانسفورميشنال يعني كويستشن. تفضلي.
شكرا. لا فيه ممتاز. بخصوص التوظيف, هو بعد جائحة الكورونا زي ما أنتم عارفين صار التوظيف موقف بشكل كامل بعد صدر فيها قرار سامي بخصوص هذا الموضوع. فكونت لجنة تنفيذية تشارك فيها أكثر من وزارة, وزارة الموارد البشرية ووزارة المالية, ترفع لها طلبات التوظيف أو على أساسها تدرس الطلبات من ناحية الاحتياج ومن ناحية كمان الخدمة الطبية المقدمة. فالحد الآن هي مركزية بناء على القرار السامي, وراح تستمر لين أنه يصدر قرار بإيقاف يعني بيرجع باستئناف التوظيف كما جرت العادة. بخصوص الاحتياج زي ما قلنا وذكرنا, احنا عادي مستعدين انه نرفع طلب, بس انه يجينا طلب من الإدارة المعنية, وليش لا.
طيب السؤال الثاني بالنسبة للبراكتس ل just only PharmD graduates بس ما يكونوا ماخذين extensive training في ال MTM.
And I will echo what the Dr. Al-Judia mentioned earlier. Maybe anyone can do MTM after training. حتى أعضاء التدريس اللي عندنا احنا ما راح ننزلهم في ال MTM إلا بعد ما ياخذون certification أو kind of training. والحين الحمد لله training is available online or available in person. For sure, if you have manpower PharmDs, graduate or baccalaureate anyways, graduates, and you have the capability of including them in any certification program, use them, because MTM is all about knowing or having a background in medication and knowing how to get the history of the patient and how to provide the advice. The answer is for sure, but you have to have certification or training at least to run these clinics.
Another question? تفضلي دكتور.
السلام عليكم يعطيكم العافية. Thank you Dr. Ali for your question. طيب, maybe Dr. He has the half answer. He asking also about the anticoagulation clinic. So anything clinically should be according to the qualification of the pharmacist. If we said he is has licensed from Saudi Commission as a clinical pharmacist, so he is the clinical pharmacist. If you need to use the PharmD, you have to put the responsibilities for PharmDs. So, what is it? As the doctor said, MTM clinic, it is okay to go with the PharmD because the responsibilities is less than the anticoagulation clinic. Anticoagulation clinic is not just only the adjusting the dose, it has further or more details need from clinical pharmacist to evaluate before he's starting to give the dose, the adjusted doses. So I think, Doctor, we need the clinical pharmacist in this clinic.
أنا كان ممكن أتدخل؟
تفضل دكتور.
طيب.
هم جايين في الكلينيكال and I can see all the problems coming from the clinical pharmacists by the way.
راعي مشاكل. احنا راعي مشاكل.
تفضل دكتور.
طيب اوكي so أنا سمعت دكتور علي قبل شوي يقول why can't we use the PharmD with training in MTM
specialized
to run MTM clinics. في نفس الوقت سمعت واحد consultant ولا باقي لك سنة تصير consultant يا دكتور مسفر consultant level specialized in organ transplant اوكي يقول ابغى لا سوري الدكتور ابو بكر اللي قال شوف consultant في ambulatory care ويقول ابغى insurance coverage for medication errors اوكي او for interventions. فشوف النقيض شلون احنا قاعدين نتكلم في ناس يقولون يا اخي واحد توه متخرج اوكي اعطوا بوت كامب وخليه يمسك كلينيك اوكي واحد سبيشالايزد واكسبرت في مجاله ويقول يا جماعه انا نيد انشورنس زي الاطباء
صح
اوكي فوي نيد انا اعتقد مهم جدا اول شيء الانشورنس جاي ان شاء الله مناسبه فرض على الجميع ان شاء الله اتس نوت باي تشويس لكل الممارسين الصحيين سواء عندك كلينيك ولا ما عندك كلينيك سيفرض زي ما هو مفروض على كل الاطباء. بس انا الصراحه انا يا جماعه متخوف من انه because of shortage of staff ان احنا we lower standard لانه ال consequences is huge. We could the fact يعني كوننا ما نقدم خدمه نقول والله ترى ما عندي واحد qualified انا معذور لما اقول انا ما عندي واحد qualified اوكي بس ماني معذور اني ما اعمل لسد النقص هذا زي ما قلنا موضوع ريزيدنسي وابتعاث وتطوير وكورسز ووات لكن لما اعطي واحد هوز هاف بريبيرد وبعدين يصير في مشكله ترى الريسبونسبيلتي ستمتد ما هو فقط عليه ستمتد لمن اعطاه الحق يعني opening a clinic ولا seeing patients ولا making modifications. أنا أشوف ال MTM مرة صعبة يا جماعة الخير. That's why it has a board في أمريكا. You have to go through يعني certification, qualifications و you sit for an exam عشان تأخذ ال PC MTM. تمام؟ MTM is wide. أنا if you ask me ممكن أسوي boot camp الواحد يعني PharmD with some experience وأسوي له boot camp على anticoagulation. ممكن تمام؟ وممكن اخليه مثلا اذا في difficult cases يسوي consultation مع specialized clinical pharmacist. بس MTM is wide، يعني حيشوف all types of chronic diseases، حيشوف diabetes، hypertension، hyperlipid، FH حيشوف FH يا دكتور. Can they manage patient على لوميتابايد؟ أنا أسألك، جاء واحد على لوميتابايد، can they adjust the dose based على they cannot. خلينا نكون واقعيين. فأنا أعتقد MTM لما أعطيه أنا certification ترى أنا أعطيه على الميثودولوجي of conducting MTM، اوكي، اللي هي الفايف components of MTM، الدوكيومنتيشن، السوب، بس ما راح ادخل اعلمه الفارماكوثيرابي. I need somebody who has the knowledge، هو عنده درس، اوكي، بس عنده التريننج، الهاندز اون، عنده الاكسبيرينس، اوكي، وهذا اللي يفتقدونه خريجين الكليات. عشان كذا they have to go through residency يا جماعه. That's why اللي دارس طب، اوكي، ترى دارس multiple sclerosis ومختبر في المالتيبل sclerosis، اوكي، في النيورولوجي بلوك، والله مختبر، بس ما يروح يشوف multiple sclerosis patient. It's the same thing. They have to go through proper structured training program. Let's not lower our standard وبعدين we pay the price and the patient pays the price. أقدر في many clinical activities that they can do. أنا ممكن أعطيه course on how to adjust aminoglycosides dosing، TDM، vancomycin، بس MTM ويصير في clinic و makes a decision alone، تمام، وبعدين تقول لي عطني insurance، أوكي، لا يستويان، ما يصلح، أوكي. في نفس الوقت أنا أعتقد we need to give them the clinical responsibilities that meets الليفل حقهم. ممكن أعطيه TDM بعد التريننج، ممكن أعطيه مثلا stable patient surgery، مثلا يسوي لهم parenteral nutrition، ممكن medication reconciliation، ممكن نسوي discharge counseling، ممكن multiple things. وأكشلي وجوده في الصيدلية to review الأوردرز هذه is a clinical practice. Okay, هو reviewing l'indication والدوز والcontraindication drug interactions، all of this is clinical practice. But making decisions where nobody else is يعني checking after them أنا without proper training أنا to me is dangerous. That's my opinion.
أتفق دكتورة غادة.
شكرا دكتور أحمد. بس واضح الصوت؟ الصوت واضح. ثانك يو دكتور احمد. بس نعترض شوي معك معليش.
Sure.
طيب طبعا بالنسبه لاول حاجه ما نسميهم فارماسيست، هذول graduates so they're pharmacists right and they are the same pharmacists who are actually verifying orders for patient with transplant, patient with heart failure, patient with whatever you want, right? They check their orders for safety, for efficacy and everything. So how come you cannot trust them to run the MTM clinic? هذه رقم واحد. رقم اثنين, when we say that we're going to have a pharmacist, clinical pharmacist, whatever you want to call them, and they're going to run a clinic or certain service, it's not going to come out of the blue. This service has certain structure. They have collaborative agreement. They have certain protocols. So all of the things is going to be done based on the protocols. غير كده احنا ما نتكلم على ناس طالعين توهم من graduation. Those at least you can have at least a year, maybe two, زي النيد حق السايت نفسه. If it's 1 year of practice, you give them additional training في الاريا اللي انت حتبغاهم يغطون فيها as مش clinical pharmacist, whatever service that you want to provide. I think that's fair. يعني طلابنا وحتى الجراديوس حقونا والفارماسيست حقونا they have a huge experience. Some of them are sitting in the dispensing or operation role for 2, 3, 5, 10 years. You can utilize those individuals to do an area where you can have some kind of judgment, provided that you have a structure, protocols, collaborative agreement that they can deliver within it. You mentioned something in ممكن certain areas they can consult with a physician or consult with a consultant pharmacist in order to resolve certain issue. I don't think the problem is hard. I practice MTM. I am MTM certified pharmacist, and I think the process نفسها, it's not as يعني the most challenging part in the MTM is your communication with the patient. That's the most challenging part. Solving the problem, it will require definitely your experience. It will require, if you have certain collaborative agreement, your knowledge, your إلى آخره. وبالتالي I think إنه it's something doable. It's highly needed, especially with وصفتي. Now we're talking about the hospital, but what about the community? So الناس اللي في الهوسبيتال اوكي عندهم clinical pharmacists او عندهم clinics. What about the people in the community? Dr. Mr. I think you mentioned the patient who has 2 orders of tacrolimus. طب who verified that order? طب الاوردر لما طلع المفروض لو الام تي ام سيرفيس او whatever you want to call it، ترى مو ضروري نسميها ام تي ام، السيرفيس اللي حتقدمها مع كل وصفه اجباري على الصيدلي انه يسوي الاديوكيشن نمبر 1 2 3 بالطريقه اللي تبغاها الهيئه او الوزاره اللي تضمن انه الدواء تاخذ بطريقه صحيحه وانه المريض فاهم بالضبط ايش ياخذ. I think this is a win situation for all pharmacists and the healthcare system.
طيب انا ما ودي بس يصير في ديبيت كثير، بس بوضح النقطه مهمه جدا. انا اول شيء I'm coming based على general consensus. الامريكان College of Clinical Pharmacy تقول for any pharmacist to provide direct patient care they have to go through a residency training. Okay? So كون يطلعوا من الفارم دي، هذا في امريكا اللي الفارم دي حقها من 1958 بادي. اوكي؟ وانت عارفه يا دكتوره انه let's be honest our فارم دي اللي هنا ما هو زي بعض. اوكي؟ انا عندي في عندي graduates فارم دي سووا كل اول شيء الروتيشن حقتهم 6 months تمام او 6 rotations. اوكي؟ الروتيشنز ولا واحده منهم شافوا بيشنت، كلها في الاوفيس يناقشهم هذا على كيسز كانهم ثيرابيوتكس. Would you trust somebody أنا الآن would you trust somebody like this يكون provides consultation للphysicians for selection of therapy وعنده proper assessment to make judgment على selecting medication therapy for you؟ أبداً. أنا would never. أنا بما إني أنا I don't trust him لأنه did not get the proper training I wouldn't allow it. الشيء الثاني why do we have residences؟ طيب إذا الفارم دي بيطلع جاهز why do we have residences؟ أوكي؟ أنت قلتي فارم دي صح؟ أوكي pharmacist regardless. أنا تمي واحد pharmacist طالع bachelor degree ترى أخذ 2 rotations، أخذ inpatient و outpatient. أوكي؟ واخذ 1 course therapeutics. انت ما اعرف اذا شفتي الكوريكولا حق الاذر universities. طيب there is no way انه this is يعني اذا انا اقول لك فارم دي في امريكا اللي هي according لل ACPE standards they are not considered they cannot provide direct patient care. They cannot. By يعني ما هو كلامي انا by consensus of the pharmacy community في أمريكا. In fact, الآن to be a clinical pharmacist PGY1 is not enough. الآن عشان تشتغل في IV room you have to get PGY1. شوفي وين وصلوا الآن. أنا I've seen it myself. عشان تشتغل في IV room minimum requirements PGY1 plus Pharm D. وحنا نقول Pharm D من أو pharmacist fresh من لا okay.
That's what I said. They have to have at least certain experience that you
طيب
will allow.
This is the point. Where are they going to get this experience unless it's شيئين. It's mentored experience وهذه mentored experience is different. That's fine. ACCB ايش تقول؟ تقول ال PGY1 1 year of PGY1 is equivalent to 3 years of practice in the same area. يعني واحد يجلس 3 سنوات في telemetry floor mentored experience تعادل 1 year. هذا تعادله. واحد جلس 3 سنوات في surgery floor mentored experience تعادل 1 year. ما عندي مانع. I'm not against this.
So we're not disagreeing. We're just saying that if you have حسب النيد السايت حقك.
لا الشباب this is not the question حق دكتور علي.
لا مو حق الدكتور علي.
دكتور علي يقول جيبوهم نعطوهم بوت كامب دخلهم MTM.
I don't think this was his idea بالبداية.
ايش extensive training؟ What's your definition of extensive training؟ ايش هو extensive training is what؟ احنا certification programs حقتنا 2 weeks يعني programs وتسوي بعدها امتحان عملي ونظري. هذا هو certification program. اكبر certification program موجود في هذا this is requirement حقته. ف what kind of extensive training؟ الاكستنسيف تريننج اللي نتكلم عنها انا والدكتوره غاده مختلف. احنا نتكلم عن منتورد اكسبيرينس، واحد يشتغل كل يوم في السيرجري فلور، تمام، وديفلوبد الاكسبيرينس سيينج ديفرنت سيرجري، يعرف الكومبليكيشنز اوف السيرجري، ويعرف هاو تو مانج ايلياس بيشنتس، ويعرف هاو تو مانج الديكونتامينيشن، ويعرف سيرجيكال بروفيلاكسس، ويعرف تمام. وجلس 3 سنوات. at that time اقول له ما عندي مشكله. at that time انت equivalently PGY1 graduate to me. you can work independently. ما هو المشكله وين؟ المشكله working independently versus under supervision. ما ترى بالمناسبه القانون عندنا حتى ترى يسمح للتكنيشن يصرف اوكي under supervision of pharmacists. فاندر supervision responsibility على السوبرفايزر. عشان كذا انا اقول لكم يا جماعه لما تيجي تقول لي اعطيه بوت كامب وخليه يسوي MTM في كلينيك، ترى الريسبونسبيلتي ما هي عليه، ترى بتروح للي اعطاه الاوثوريتي.
شكرا جزيلا. تسلموا. I want to take this opportunity to thank our guests of honor, دكتور أحمد الجديع، دكتور أحمد الفهيد، دكتور عبد العزيز الحصان، دكتورة غادة بوزير، أستاذة مشاعل عزة. شكرا جزيلا. أخذنا من عندكم وقت طويل جدا، بس أنتم كرماء وحنا نستاهل، والصيادلة كلهم يستاهلون، ومؤتمر اي هوب يستاهل. وشكرا جزيلا للحضور. والآن عندنا راح ناخذ صورة بعد التكريم للجيستس اوف اونر مع كل المتسابقين اللي كانوا في الكومبيتيشن لمسابقة التثقيف الدوائي. وسيتم الإعلان على ال5 المتأهلين الأول. طبعا كان عندنا 21 جامعة ب37 متسابق ومتسابقة. سيتم الإعلان عن ال5 الأول اللي هيكونوا معانا بكرة إن شاء الله في المسابقة النهائية اللي راح تكون بعد الظهر على الستيج هنا إن شاء الله. شكرا جزيلا، يعطيكم العافية.
طيب، سعادة الدكتور أحمد الجديع. سعادة الدكتور أحمد الفهيد. سعادة الأستاذة مشاعل العزة. سعادة الدكتور عبد العزيز الحصان. سعادة الدكتورة القديرة غادة بوزير. المتحدثين المتألقين مدراء إدارات الخدمات الصيدلانية اللي يتحفون اليوم بمشاركتهم الدكتور عبد المجيد الحربي. سعادة الدكتور محمد الشرعان. الدكتور علي تبيناوي. مرتين يا دكتور في الراوند تيبلين. عشان ما ندي مرة ثانية. سعادة الدكتور مسفر الغامدي. سعادة الدكتور يحيى محزري. أترككم الآن مع المفاجأة الكبيرة اللي الجميع ينتظرها، ولكن بعد الصورة الجماعية أعتقد. أترككم مع الدكتور يحيى والدكتور محمد المزنعي.
السلام عليكم، يعطيكم العافية جميعا.
دكتور يحيى، خانتني ذاكرتي كالعادة، باقي الدكتورة واجد الشمري.
يعطيكم العافية جميعا. في ختام يومنا الثاني لآي هوب بنسخته الخامسة، راح نعلن اليوم معكم على المرشحين معنا لليوم الأخير غدا بإذن الله تعالى في المسابقة الخليجية للتثقيف الدوائي. ندعو كل الجامعات المشاركة معنا للصعود على المسرح. طبعا عندنا 37 مشارك من 21 جامعة، لكن اليوم ما حد في هذه المسابقة خسران، الكل فائز، ولا لا دكتور محمد؟
أكيد. أول شيء أسعد الله مساكم جميعا ويعطيكم العافية. الكل كسبان، لأن صراحة هذه النخبة تم اختيارها وتصفيتها على مستوى مئات الطلاب من جامعاتهم، وتم ترشيحهم لخوض هذه المسابقة. والحقيقة نحن شفنا مستويات رائعة جدا، شفنا تنافس كبير في خلال اليومين الماضية. طبعا اخترنا 5 المراكز الأولى، وكان المركز الخامس اليوم تنافس عليه 4 جامعات، فاضطرت اللجنة العلمية واللجنة التحكيمية إلى إضافة كيس جديدة لعمل اختبار لل4 المراكز الأخيرة إلى أن اخترنا المركز الخامس. فصراحة كانت في منافسة قوية ورائعة بين الجامعات.
يعني عندنا يا دكتور 5 جامعات مرشحة.
هذا نعم صحيح.
احنا كنا نحتاج اللي عارفينه 3.
والله راعينا يا طويل العمر عدد الجامعات الكبير، حضورهم من مختلف مناطق المملكة ومن دول الخليج. حبينا يكون اليوم الختامي فيه يعني منافسة أكبر وبعدد أكثر يعني.
يستاهلون. والحين راح نعرف، يستاهلون جميعا. راح نعرف معكم جميعا أن المرشح الأول معنا في المسابقة الخليجية للتثقيف الدوائي جامعة مين تتوقعوا معنا؟ متأكدين؟ أنا عندنا 21 جامعة، فين الجامعات الثانية؟ جامعة تبوك. طيب خلونا الآن نعرف عن المرشح الثاني. دكتور محمد، أنا ما أشوف هنا.
الجامعة من الغربية.
أوه، من الغربية. عندنا 3 جامعات من الغربية. مين تتوقعوا معنا؟ مين؟ أوه، دكتور محمد توترت. الله يكون بعونكم، الله يكون بعونكم. بس كلهم فائزين معنا، ما في أحد خاصة في المسابقة هذه. شوفوا كذا. جامعة الطائف. المرشح الثالث.
مفاجأة المرشح الثالث.
من فين؟ من الشرقية ولا من الشمال ولا من الجنوب ولا الغربية؟
الغربية.
برضو من الغربية. مين؟ كلية ابن سينا. مرشحنا الرابع جامعة الإمام عبد الرحمن بن فيصل. عاد المركز الخامس. الدكتور محمد عملوا تيست علشان يحددوا مين المركز الخامس.
صحيح.
كم كلية دكتور وجامعة اللي حددوا؟
4 تنافسوا على المركز الخامس وتعبونا اليوم صراحة
علشان نحدد المركز الخامس. مين الخامس حيكون؟
جامعة الفيصل وجامعة الأميرة نورة وجامعة شقرة الملك سعود بن عبد العزيز الصحية.
التنافس قوي. والمركز الخامس معنا المرشح من فين؟ جامعة مين؟ لا مين؟ جامعة شقرة. فليتكرم الدكتور أحمد الجديع والدكتور محمد في التقاط صورة تذكارية لكل الأبطال معنا اليوم، وكذلك أعضاء اللجان، أعضاء لجنة مسابقة التثقيف الدوائي، وكذلك المحكمين للمسابقة. فليتفضلوا على المسرح.
أولا شكرا جزيلا لكم، وألف ألف ألف مبروك للمراكز ال5 الأولى. طبعا المراكز مو بالترتيب، احنا ما ندري لسه إن شاء الله في المسابقة. كلكم فائزين وفائزات، ما في ولا واحدة منكم ما فازت، ولا واحد منكم ما فاز، كلكم فائزين. شكرا جزيلا لتعاونكم. اللي فاز عنده فرصة إن شاء الله بكرة، الخمسة الأولى. اللي ما وصل عندهم إن شاء الله فرصة في النسخ القادمة من اي هوب. أهلا وسهلا فيكم، شرفونا. مو الهدف فقط الفوز في المسابقة يا جماعة، الهدف إنكم أنتم تتعلموا إيش اللي أنتم تسووه مع المريض، مع المرضى نفسهم. وأنا متأكد التجربة في حد ذاتها هو نجاح لكم. إحنا نجحنا، إحنا كسبنا تواجدكم جميعا، وإحنا كلنا كسبناكم كلكم جميعا، وإن شاء الله كسبين صيادلة رائعين في المستقبل. شكرا جزيلا، ألف مبروك للي فاز، وألف مبروك للي ما وصل للخمسة. إن شاء الله كله بالتوفيق. شكرا لكم جميعا.
يعطيكم العافية جميعا، ونلقاكم غدا بإذن الله. كلكم أبطال المسابقة بدون